There are chairs in the other room as well, so all of y'all can be seated in that room if y'all are having deficiency of chairs over here. Wishing you all a very good afternoon. Today, Dr. Navroz Mehta and I, Dr. Kartika Rao, fellows of this institution, would like to welcome you all to this academic event. A very special welcome to our chief guest, Dr. Professor Giorgio Peretti and Dr. Professor Alok Thakkar. On the occasion of this institute celebrating its first anniversary, we feel extremely honored to be standing among such esteemed faculties. The theme for today's program is Decision Making in Laryngeal Cancer, Real-World Issues from Conservation to Salvage. Without further ado, let us commence with today's event. I would like to invite our chairman, Dr. Sultan Pradhan sir, to please come and address us all with a welcome note.
You've already welcomed them, Kartika. Good afternoon, Professor Giorgio Peretti, Professor Alok Thakkar, friends and colleagues from the fraternity, and of course my very, very dear Sexaria fellows. I welcome you to this first anniversary of the HNCII conference on laryngeal cancer. It has been a year of reckoning after years of dreaming. The project came to fruition. But one of the main things that I want in this institute is a culture of education, training, and research. And your presence here and your participation here today is going to infuse that dose of academics into this institution. When we started, Dr. Ilavia and I were just a bit nervous. Will we be able to attract good talent in this institution? But I can tell you at the end of 1 year that we have the very, very best talent. very best in surgery, in radiation oncology, in medical oncology, histopathology, technicians, laboratory, everywhere we've been able to attract very good staff, and that's the big, big fortune that we have. And the biggest, of course, is our director, Prathamesh. He is determined to fulfill our dream of creating a culture. You can't get a better person than him. None will disagree on this one point. You can't get a better person than him. So we're very, very fortunate in having this. But these events have to go on. These events are important steps in infusing that dose of academia. And to have a person like Professor Alok Thakkar and Professor Paretti is an additional booster dose for our academics. So thank you very much for being here. Even the second line that we have here in every department has been very good. Even the second line, it's not just the seniors, but the second line also has been extremely good. And we are very fortunate in that. So thank you very much for being here. Thank you.
Thank you, sir, for your kind words. Now we would like to call upon stage our director, Dr. Prathamesh Pai, sir, to give an introduction to this academic fest.
Thank you, everybody, for coming here and making this dream of ours live through your proceedings. What we would have envisaged this theme of larynx, we felt that we needed to convey what has happened in the past 3 decades. And as you are aware, this is an area of interest of Dr. Pradhan, very dear to his heart. And we wanted to focus on what has transpired in the last 3 decades. And hence we got Professor George Paretti and Professor Alok Thakkar, who are also exponents of this art and form of laryngeal cancer management, to deliver their thoughts and for us to imbibe all these as we go ahead in learning how to manage these cancers better. So what we decided in the afternoon session was to focus on the surgical aspects and how we can go about learning to investigate and make treatment decisions for managing these cancers. So in these next 3 hours, what we will focus on is having 2 didactic lectures followed by video sessions. So I would then ask Professor Sultan Pradhan and Professor George Paretti to intermittently show cases which will then showcase the entire gamut of surgery from transoral laser surgery for early glottic cancers, wherein they do a phonosurgical resection across, and then move on to the intermediate advanced cancers, wherein we would then need to focus on open partial laryngectomies. So we will have 2 talks followed by video, and we leave this flexible. We'll take it as it comes, and as per your requirements, please feel free to communicate. So I will hand over the mic for initiating the talks. Thank you.
Thank you, sir. Now, before we move on to the sessions, we would like to request the audience to kindly keep their mobiles on silent mode. We would also expect enthusiastic participation from everyone in the audience by asking questions and providing your valuable comments. And questions will be taken after each session due to each speaker getting just 10 minutes for their talk. So, thank you.
So let's begin our first session. The first session deals with early laryngeal cancers. The chairperson for our sessions are Dr. Murad Lala, Dr. Bachi Hathiram Madam, and Dr. Roshni Chinoy. As I introduce our chairpersons, I request them to please come forward and have a seat over here. Dr. Murad Lala, consultant in surgical oncology at PD Hinduja Hospital, Mumbai. He has special interests and specializes in thyroid and parathyroid surgery, voice restoration, and has even summited the Himalayas. Dr. Bachchi Hathiram, I think, has not yet come. So Dr. Roshni Chinoy, she is the head of the histopathology department at our institute. She was the former HOD of pathology at Tata Memorial Hospital and Prince Ali Khan Hospital, Mumbai. She has pioneered the BBG, that is the Bombay Breast Group, FNAC, and immunohistochemistry of breast tumors, and has founded the Tumor Tissue Bank at Tata Memorial Hospitals. So before we call on the speakers for the first session, it is a humble request that all the speakers please complete your talk within 10 minutes so that we can progress punctually. The first topic for the day is basics of laser surgery. I would like to call upon Dr. Karthik Krishnan to present the topic. Dr. Karthik Krishnan is working as the associate consultant over here at HNCI. He's completed his MCH in head and neck oncology from the prestigious Tata Memorial Hospital. He's completed his fellowship in robotic surgery as well. His special interest lies in minimally invasive head and neck surgery. He's also the recipient of the Dr. Milant Kirtane Award for the best student during his post-graduation. Handing over the mic to Dr. Karthik Krishnan.
So thank you for your introduction. So good afternoon, everyone. First of all, I hope you have all had a very good lunch, and I hope to vanish your post-lunch somnolence by giving this small talk. So to begin our academic session today, I would like to speak on the basics of laser surgery in laryngeal cancers. So the early laryngeal cancers, as we all know, it has got very good survival outcomes as well as it has got very good survival outcomes, and we need to give voice outcomes also. So all over during the years, technologies have evolved and treatment strategies have also changed. Like radiotherapy takes more than 6 weeks to complete. So there are many treatment options being introduced which are shorter in duration, and like patients can be taken treatment in as a day care procedure also. So laser stands for light amplification by stimulated emission of radiations. It is based on Professor Einstein's theory of quantum theory, which is that any photons in an stimulated state excites energy. So based on his theory, in the year 1917, and as we proceed in future years, in 1958 was the first laser developed by Swallow and Towns. And as we go further, the Ruby laser was developed in 1960. The helium neon gas laser came in 1961. CO2 laser was introduced by Kumar and Patel in the year 1962. And Jacko and Strong were the first to use CO2 lasers in ENT. And the micromanipulator, which is was used for the scanning technology, was developed in 1980. And future more extensive laryngeal tumors were treated by Eckel and group in 1992. So coming on to the functioning of lasers, how does it work? So the basic components of the laser are, so there is an optical cavity which consists of our lasing medium, which can be CO2, argon, KTP, whatever medium we are using. In this medium, we have got the photons, which can be in a stimulated state or in a ground state. And there are two mirrors. One is a partially transmissive mirror and one is a completely opaque mirror, which helps to transmit the beam. So this is a small video which shows how the laser works. So energy is pumped into the medium from an outside source, and the electrons go from a ground state to the excited state. And when they come back to the resting state, they emit energy in the form, and those energy combine to form a wave which comes out as our light beam. The properties of this beam is that it is monochromatic of a single color. It has got a single wavelength. For example, our CO2 laser has got some 10,600 micrometer wavelength. It's collimated, that means all are going in one direction parallelly, and it's coherent, that the electrons and all are in a single phase. So the main lasers which we use in larynx are CO2, KTP, and the PDL, that is pulse dye laser. The KTP laser and the pulse dye laser are mainly for benign lesions, while CO2 laser is for the malignant lesions. The particular properties of CO2 laser is that it emits infrared and light energy in pulses, while others cannot emit energy in pulses. It is selectively absorbed by water. Hence, it deals with vaporization, which cuts the tissues. And our tissues also contain chromophores, which are molecules which are pigmented like hemoglobin or melanin, or non-pigmented water which absorb the CO2. And these tissues selectively absorb, reflect, and transmit the laser energy. Nowadays, newer technologies are coming up. So initially, it was only continuous lasers which used to emit continuous energy, which cause more damage. So nowadays, pulse lasers are coming, which can be like ultra pulse or acupulse. So lesser the time frame the laser is sent, so lesser the lateral damage to the tissues. The micromanipulator is applied to a microscope. So it is used for a scanning technology. So it has got two AccuBlade and AccuSpot technology. So AccuSpot is like where a circular beam, you can control the size of the circle. So lesser the size of the circle, lesser the tissue you can control and cut. And AccuBlade has got different shapes. So it can be curved or linear. So it helps you to cut that according where the tumor is placed and how far or near you want to go. So this is a small video which shows like how the laser, the machine looks like. So you have got your different options. So we select larynx. Then we have got the different technologies, like whether you want to go in pulse mode or continuous mode. Pulse mode has different modes, like repeat, continuous. Then you can control the shape of your beam and how many seconds each pulse you want to give. So all this can be controlled in the latest luminous laser. And the depth, how deep you want the laser to go, that also you can control. So the advantages of transoral laser microsurgery, this I would like to thank Dr. Alok Thakkar sir, because he has a very good book on carcinoma of larynx and hypopharynx, which you all can read. So this has been taken from his book. So the advantages of transoral route are there is avoidance of disruption of the laryngeal muscles and cartilage, lesser so physiological disruption and better functional outcomes. Laser gives good surgical hemostasis, improved margin assessment and postoperative healing because of lesser tissue damage, and microsurgery helps in magnification and better tumor delineation. So coming on to now, what are the barriers which we face during transoral laser surgery? So first is your laryngeal exposure. So only if you get good exposure, you will be able to completely remove the tumor. So if the laryngeal exposure is not good, then the patient is not to be taken for a laser surgery. So what does good laryngeal exposure means? Your complete anterior commissure should be visible, because that is the site which is the most difficult to see during the microlaryngoscopy. Then you have to first delineate the involvement of the extent of tumor, that how deep it is and what are the whether it is involving your paraglottic or pre-epiglottic spaces, and arytenoid fixation, because arytenoid is the structure. If it is involved and if the cricoarytenoid joint is involved, then the patient is prone to aspiration. So those cases are we consider to be more locoregionally advanced, and we try to go for other modalities of treatment. And finally, thyroid cartilage invasion. Any doubt, if there is even minor thyroid cartilage involvement or major, these cases should not be taken for laser. So Dr. Professor Giorgio Peretti and group came up with this scoring system, the Laryngo score. So initially it was proposed in 2014, where they took up 11 different parameters and gave each one a score. And they found that any less than 6 is score if a patient has, then it is having a good laryngeal exposure. And more than 6 and above had difficult laryngeal exposure. So it was scored from 0 to 17 in total. Eventually, they even validated this laryngo score in 2019. And that paper, they suggested that three main features like the inter-incisor gap, the thyromental distance, and upper jaw dental status. So whether the patient is completely edentulous, partially edentulous, or dentate, then so that these three main features can also give and decide whether there is good laryngeal exposure or no. So the indications of transoral laser microsurgery, it can be used in all these cases of laryngeal stenosis to remove the stenotic segment. The papillomatosis, leukoplakia, vocal cord nodules can be removed, then laryngeal cancers and granulomas in cases of GARD. Contraindications, as I said, are inadequate laryngeal exposure, anterior commissure involvement. So especially you have to remember that anterior commissure involvement can be in two planes. One is a vertical plane and one is a horizontal plane. Horizontal plane is involvement of both cords. In those cases, you can consider laser. But if it is vertical plane, that it is coming into the supraglottis or into the early infiltration of preepiglottic space can also be tackled with laser. And minor or major thyroid cartilage erosion. Then what is the classification of laser? Like what we have to, whenever we are operating, we should keep in mind that how much we are going to resect. For this, the European Laryngeal Society came up with this classification. So for the vocal cord glottis, there are 6 types depending on what we remove. So this is based on the depth of the tissue we remove. So as we all know, vocal cord has got its layers, right from the epithelium, the Rinke space, then you have got the vocalis, that is called the vocal ligament, then you have the vocalis muscle, and finally you go on to the pericordium of the thyroid cartilage. So type 1 only you remove the epithelium. Type 2 is when you remove the complete vocal ligament. Type 3 is you remove a part of the vocalis muscle. Type 4 is a complete cord. And type 5 is when it is extended to involve other structures. So A is the contralateral vocal fold, B arytenoids, C your ventricle, and D subglottis. And finally, when you dissect the anterior commissure, it's type 6, which was later added. Similarly, for supraglottis also there is a classification, which is again divided into 4 types. So type 1, where you remove a limited excision of wherever the superficial lesion is. Type 2A is when there is no involvement of the pre-epiglottic space. So when we remove only upper half of the epiglottis, it is called as type 2A. When a complete epiglottis is removed, it is type 2B. Then type 3 is when the pre-epiglottic space is also removed. And if you excise the ventricular, without the ventricular fold, that is the false vocal cord, it is type 3A. With the involvement of false vocal cord, it's type 3B. And finally, it's when it's lateral supraglottic laryngectomy is when it involves the false vocal cord and arytenoid. So the important concept after surgery is the margins. So in laser surgery, we say we should always follow the tumor. Rather than if we go in the oral cavity, we have specific terms like mandible, we have hemimandibulectomy, segmental mandibulectomy. But here you should go because we have to preserve his voice. The more you remove, the outcomes will be worse. So depending on where the tumor is, in vocal cord we say that 1 to 3 millimeters is enough. While in hypopharynx and supraglottis, we have to take 5 to 10 millimeters. So a close relationship with the pathologist should be kept. Finally, laser safety is a very important feature which all our operating team and the support team in the OT should know, because we have to avoid any unnecessary complications, which is the airway fire. So few important points are that there should be a laser resistant endotracheal tube. You have to maintain oxygen concentration less than 30%. Jet ventilation can be considered. And finally, any exposed skin or mucous membrane should be covered with saline soaked gauze. So to summarize, the CO2 laser has revolutionized transoral laryngeal surgery. It is used for both benign and oncological purposes, and it has the ability to handle multitude of laryngeal pathologies because it is a very reliable, precise, and effective surgical tool in the right hands. Thank you.
Okay, any questions for Dr. Karthik? Thank you. Thank you.
I've just informed the audience that Dr. Bachi is on her way and she will be here shortly.
Thank you, sir, for that very interesting topic. It was very informative for all of us. The next topic is treatment decisions in early laryngeal cancer, and I'd like to call upon Dr. Kanav Kumar to present the topic. Dr. Kanav Kumar is a surgical oncologist and an associate consultant at HNCII, previously trained and worked at the Prince Ali Khan Hospital, PD Hinduja Hospital, and Nair Hospital. His special interest lies in head and neck cancers and breast cancer surgery.
Thank you very much, Karthika. So I'll be giving a brief talk on treatment decisions in early laryngeal cancer. We'll start off with glottic cancer. So coming to the T staging of glottic cancer, like all cancers, TIS is when it is an in situ carcinoma. T1A is a tumor that is limited to one chord. T1B is a tumor that involves both chords. T2 is a tumor that extends to the supraglottis or subglottis, or even a tumor with an impaired chord mobility is labeled as T2. T3 is when the tumor is limited to the larynx but has vocal cord fixity and or invasion of the paraglottic space or inner cortex of the thyroid cartilage is involved. T4 tumors are advanced tumors, T4A being moderately advanced, while T4B are very advanced local disease. So the options for early glottic cancers, those are T1 and T2 glottic cancers. There are mainly three options. You have transoral laser microsurgery, radiation therapy, which may be with or without chemotherapy, and open partial laryngectomy. So there are various factors that influence the choice of treatment. They are the treating clinician's preference, patient's preference, the profession of the patient, how high is the voice demand of the patient. That is very important to keep in mind. Third is the location of the tumor within the glottis. And fourth, the availability of the facilities and expertise. So there are various advantages of transoral laser microsurgery. It is a day care procedure. There is no need of a tracheostomy. It is cost effective. Voice quality is better as compared to an open partial laryngectomy. And most importantly, a salvage with repeat transoral laser microsurgery or radiation is possible. So coming to a T1A mid-chord lesion, like we can see in the figure, this is a lesion that is limited to the mid-chord with freely mobile chords. The treatment of choice in most cases is transoral laser microsurgery. The next option is radiation therapy. Radiation therapy is usually considered if exposure for transoral laser microsurgery is unsatisfactory. Radiation in such cases is limited to the larynx. The neck nodes are not included in the field of radiation as there is a very low chance of lymph node metastasis. The third option is open partial laryngectomy, which is rarely used nowadays, and this is considered if neither transoral laser nor radiation therapy is feasible. For a lesion that is a T1 lesion but involving the anterior commissure, transoral laser microsurgery is possible, but voice quality is may be severely affected in this case. So in cases where voice demands are high, the quality of voice is important, radiation therapy may be considered. The third option is again open partial laryngectomy when neither laser or radiation therapy is feasible. Another thing that we should keep in mind is when there is a lesion that is involving the anterior commissure, up to 20% of these lesions may have cartilage invasion at presentation. That is why your imaging is important and which will guide you whether radiation or laser is the correct treatment. T1B tumors are tumors that involve both vocal cords and they are broadly treated on the same lines as T1A tumors. So from literature we see that the cure rates of laser, open surgery and radiation are similar. Usually in T1 glottic cancers you have local control rates between 90 to 95% like we can see in this table. Another thing that we should note is the moment the anterior commissure is involved, the local control rates come down significantly. As we can see, when the anterior commissure is involved, all three modalities, they have lower local control rates. This is a systematic review and meta-analysis from 2019 that included 16 studies and 1,200 patients, 600 plus patients in the laser and radiation arm, where they compared the two groups, and they found that there was no difference in the local control rates between the two arms. And another thing that we must note is patients treated with transoral laser microsurgery are approximately 6 times more likely to preserve their larynx than those treated with radiation. Because usually the ones that fail with radiation would end up with a total laryngectomy. Another finding that they had in this review was that they found that the overall survival and disease-specific survival was superior in the transoral laser microsurgery group, which they attribute to maybe the slightly higher and advanced cancers being treated with radiation. This is another systematic review which had similar findings, and most importantly what they also concluded was that the post-treatment voice outcomes were similar between the two groups, whether it was radiation or laser microsurgery. Coming to T2 glottic cancers, the treatment of choice when there is a transventricular spread is with radiation or chemoradiation. So transoral laser microsurgery can be considered if the exposure is very good. However, the quality of voice may leave much to be desired. What we must keep in mind is the ventricular mucosa is in close proximity to the inner thyroid perichondrium. Thus, despite a deep resection, the margin may be unsafe and the voice quality may be poor. In cases that are T2 because of the transventricular spread, certain indications for a transoral laser microsurgery would be a very young patient, someone who has a recent history of radiation, or a non-squamous cancer like a salivary gland or a neuroendocrine carcinoma, as these tumors are not radiosensitive. T2 tumors with either a subglottic spread or impaired cord mobility are not advisable to be treated with radiation with laser microsurgery. So the treatment over here would most commonly be chemoradiation or an open partial laryngectomy rarely. The options would be a hemilaryngectomy, a frontolateral laryngectomy, or a supracricoid partial laryngectomy. Radiation therapy for T2 glottic cancers usually control rates between 70 to 80% at 5 years. Thus, up to 30% of these patients would have a local recurrence and would usually end up with a total laryngectomy, as in most cases, organ preservation is difficult post-radiation. Like this study shows that between 75 and 80% was the laryngeal preservation rates in T2 glottic cancers treated with radiation therapy. When we are planning to treat T2 glottic cancers with laser microsurgery, one must remember that we must be confident that we are going to get an R0 resection. If one feels that an R0 resection is unlikely to be possible, transoral laser microsurgery is not advisable, as debulking would leave a raw area and could also open up planes and natural barriers to spread, and a radiation therapist is never happy treating this raw area, and this would further delay definitive treatment. Open partial laryngectomy, as literature suggests, has good local control rates in early glottic cancers, between 80 to 85%, like this paper shows us. Coming now to supraglottic cancers, T staging, T1, T2 are what we are going to mainly deal with. Those are either limited to one side of the supraglottis with normal cord mobility, or T2 tumors that have invaded an adjacent subset of the subsite of the supraglottis or glottis without fixation of the larynx. Again, the same three options over here like the glottis. Factors that would influence your choice of treatment would be the location of the tumor within, the exposure of the lesion on suspension laryngoscopy, the fitness of chemotherapy, and cervical lymph node status. So transoral laser microsurgery in supraglottic cancers, how is it different? It's usually technically more demanding as compared to glottic cancers, These tumors are very vascular, and that is why a good suction cautery is essential to have when we are resecting these tumors. The tumors that are best suited to transoral laser microsurgery are tumors of the suprahyoid epiglottis and marginal zone tumors. These are two areas that have good access on microlaryngoscopy, thus amenable to laser microsurgery. While for the infrahyoid epiglottis or in the ventricle, these are technically very demanding to resect with the laser. And with the infrahyoid epiglottic tumors, you also have involvement of the pre-epiglottic space early. That is why you must also keep that in mind when you're considering this. Open partial laryngectomy is rarely used, and it's only indicated when you want to treat the patient with surgery, but laser is not feasible. So radiation therapy for supraglottic cancers would include the primary as well as bilateral neck node. This is because of the high propensity of lymph node metastasis from 20 up to 65% depending on the T stage. There is also a high risk of occult contralateral lymph node metastasis up to 33% in an N+ patient. So for managing the neck is something that is important in supraglottic cancers. When you're treating the primary with transoral laser microsurgery, you have two options. Either in an N0 neck, you can observe the neck and maintain a regular follow-up, or consider a prophylactic neck dissection, which includes clearance of levels 2 to 4. In an N+ neck, the neck dissection is done, which is usually done as an interval surgery. While radiation would include both sides of the neck and would be included in the field of radiation. To conclude, in the management of early cancers of the larynx, you have three options: radiotherapy, open partial laryngectomy, and transoral laser microsurgery. Each of these modalities are important, with one or the other useful in specific situation. But the emphasis is mainly on maximizing cure rates along with preservation of your voice.
I'd like to welcome Dr. Bachi Hathiram ma'am. She one of our chairperson for this session. She's the professor and head of ENT department of Nair Hospital, Mumbai. After our second talk, now we'd have a video demonstration. I'd like to call Dr. Kanav Kumar for the video demonstration on early laryngeal cancers.
So we're going to have an open discussion. So as the surgery is being demonstrated, please feel free to ask questions.
I'll be showing a short clip of a patient who's been treated with transoral laser microsurgery. This was a 70-year-old gentleman who presented to us with complaints of hoarseness. That was since the last 4 months. This is his fiber optic. This is his fiber optic laryngoscopy, where we can see that there is a growth that is seen on the anterior 2/3 of the left vocal cord, both cords being freely mobile, as we can see over here.
You and Alok should ask questions.
Yeah.
Students will learn a lot from your questions.
So this is the patient when we took him up for 0 degree after suspension. This shows that there is a growth that is seen on the left vocal cord, and the anterior commissure is free.
So sorry, just 1 minute.
Yes, sir.
So what is your pre-op investigations? Would you do a stroboscopy for all these patients before taking them up?
Sir, a stroboscopy would help guide us on how deep, if you are worried about how deep the tumor is, then that will help guide us when we are planning a laser, it would help guide us as to how much of the cord would be resected and what are the voice outcomes we expect. So it can be done.
One more question.
Yes,
Is any imaging done before you go ahead with surgery?
So ma'am, usually what we would do is a CT scan,
Right.
CT of the larynx. That is what the standard investigation is. That will help us to look for any involvement, cartilage erosion, any involvement of the paraglottis, any neck node metastasis, which would be rare in this case. Those are in case there is those features are seen, we would not opt for a laser microsurgery.
Do you use a bioendoscopy before the procedure, like MBI or other kind of bioendoscopy, like a SPICE for the STORZ MBI?
No, sir, we don't routinely use the MBI.
This could be fine because you can better define the margin, the superficial margin of the lesion, and maybe to recognize some atypical vascular pattern in the surrounding area. Sometimes you can avoid the biopsy because you can base or presume the diagnosis, the final diagnosis with bioendoscopy. So in one-stage procedure, you can achieve a diagnosis and definitive treatment without the need to repeat these two procedures. About the exposure, I suggest you always to keep the laryngoscope a little higher to control also the false cord. I usually perform a ventriculectomy just to better expose the flora of the ventricle. So you have to keep a little higher the laryngoscope, and you don't stretch the vocal cord in this way. You put the laryngoscope higher, you remove the part of the false cord, and you keep the vocal cord in the physiologic position, and you can control much better the lateral extension or spreading of the lesion.
Okay, sir. Oh, that's nice. Let's see the video.
So this was the case that we treated with the laser. Like we can see, this is the CO2 laser that is being used. With the suction, you check for the suppleness that will help guide us on involvement of the paraglottis. Like Professor Peretti pointed out, you do not need a biopsy for a glottic lesion. You can. There is no concept of an excisional biopsy. Any lesion should be excised with a margin of 2 to 3 millimeters, which is adequate for a glottic cancer. Like we see in this video, as we are cutting with the laser, we can see the different layers that are separating over here, and the suppleness of the tissue, which gives us an idea that we are getting a free margin. Yes, ma'am.
You mentioned where there's no concept of biopsy and we take 2-3 millimeters, but what about the depth margin? I mean, would you do like a type 3 without a biopsy?
If you are considering...
So sorry. My question was just because there was a mention of no need for biopsy. So, what about the depth? I agree that the 2 millimeter around doesn't matter. The epithelium will grow back. What about the depth?
Depth, if we find it that it is the laser would be a deeper resection, then one can do a biopsy. If we are suspecting something non-malignant, then a biopsy can be performed, but that would usually be a punch biopsy, not an excisional biopsy. No.
Okay, so basically my question was, would you do like a type 2 or a type 3 without a biopsy, is my question.
We would do a type 2 or a type 3, ma'am, without
A biopsy, and then if it comes as sarcoidosis or tuberculosis?
Ma'am, that is a rare of, out of 100, I think that may be 1 or 2 that we usually see, tuberculosis or sarcoidosis.
In my opinion, when you have no preoperative biopsy, okay, and you go straight to the chordectomy, I suggest to perform type 2 chordectomy because it's the better compromise between radicality from the oncological point of view and function. Because if you spare the majority of the muscle, you have a good closure after the healing process and good voice. So if you perform a type 3 up front, you have a mild incompetence, so there was voice. So if you propose to a patient to perform directly chordectomy, you don't want interfere with the quality of voice, you have to perform a type 2 chordectomy, okay? And type 3 is reserved for cases already biopsied, where the workup, diagnostic workup is not feasible completely, okay? In these cases, the anterior commentary is not involved, but if you want to be sure about the margin, probably you have transgressed a little bit a midline, and also you have extended laterally your resection to all the floor of the ventricle, because the voice is not impaired by the superficial spreading of your resection, but the deep resection. So if you stay in subligamental plane, you can obtain a very good voice, but it's important to extend your resection laterally, including all the floor of the ventricle. For this reason, I said before, it's better to perform ventriculectomy, because it seems very close to the margin, to the lesion. So I don't know how was the margin here, but it seems to be very close to the lesion. And even the laser is a little bit the focus. You have a char cut, so it's better maybe to use a blade, a skein, instead of the single spot, and try to focus much better to avoid any char.
Yes, sir.
Professor Peretti, any disadvantage in sending the carpet as a frozen and then proceeding with the depth margin?
Yes, usually if you have a very limited lesion to the middle third of the vocal cord and you don't interfere with the anterior commissure, you don't need to perform frozen section in deep margin, because the majority of these lesions are confined to the ligamental layer. So the ligamental layer is an anatomical barrier that avoids the transgression toward the muscle. So if you stay in this plane, you don't need any wider resection. But of course, you have to study very well the patient during the workup. If you have impairment of the vocal or the mobility, of course, it means that the lesion is transgressing the vocal ligament and going toward the muscle. So in this case, is another question. You need a biopsy before the treatment, and you have to go deeper. But in this case, probably you have to reach the perichondral plane. Is another scenario.
If I may just say a few words, the message over here for our juniors should be that biopsy does not indicate the depth of the lesion. For the depth, you would need imaging definitely. Yeah, biopsy will only tell you what it is and then how you go about treating it.
Nupur, I think you wanted to ask whether you'd assessed with the infiltration test?
No, actually my question was, since we're talking about not doing a biopsy and going ahead with a chordectomy, that why don't we at least have a frozen biopsy? I wasn't talking about the frozen margins
Okay,
at that, but
right.
of course I take Professor Peretti's comments, and infiltration is another great discussion I'd like for us to have.
Professor Peretti, would you do an infiltration? Like the discussion is everybody is concerned that we are not doing a biopsy. So how exactly are we going to assess the margin and the depth? So do you use any such thing to assess the depth before you proceed?
Yes. The depth, I mean, if we talk about T1, okay, or the middle cord, very superficial lesion, the depth of the invasion is detected by video stroboscopy and infusion in the Ranke space. So if in my algorithm I have a normal mucosal wave, a good ballooning, after the infusion I perform a type 1. If I have some doubts, impairment of the mucosal wave and no ballooning, I perform type 2. Okay, no type 3. Okay, because if I have to go deeper, I have to say to the patient, after this chordectomy, your voice becomes worse, so I have to advise him about the histology of the lesion. So the excisional biopsy concept is limited to lesion confined to the ligamental plane and in the middle third of the vocal cord, okay, with positive MBI, okay, because you presume the histology based of the atypical vascular pattern, and of course on video stroboscopy infusion.
Go ahead.
One good point that Professor Peretti has made is that you take a little wider mucosal margin. Taking a wider mucosal margin is not going to hamper his voice. And of course, Dr. Chinoy will be much happier reporting on those patients because they really have charred margins by the time they get bigger the better. But
Yes, you help the pathology if you take out this part because you have a wider margin to examine it. And from the functional point of view, there is no difference because from the functional point of view, it's important to tailor your deeper resection, no superficial resection. So keep this mucosa doesn't make sense from the functional point of view, but help the histology to give you free margin resection. So I suggest you always to remove all the flora of the ventricle. Superficially, of course.
Yeah, plate. Forward.
Here now the posterior cuts are taken. The posterior mucosal cut is taken. And now we can see the vocalis muscle. So this is a type 2 chordectomy which includes resection of...
This is not type 2. This is type 3 because you are removing part of the muscle. So you are going deeper compared to type 2. So this is not a right chordectomy for a case without the biopsy. Okay. You have to spare completely the muscle. This is a conoelasticus, okay? So also this char means thermal damage to the margin of the lesion. So you make more difficult the examination for the histology.
Do you try to resect a block or do you take it segment by segment, Dr. Peretti?
Now, in this case, I try to perform a block resection.
One block.
I use a Steiner technique for more bulky lesions.
Yeah.
So the final histopath of this patient showed invasive, well-differentiated squamous carcinoma with clear margins. And on follow-up, this is a fiber optic laryngoscopy done 6 weeks post the laser resection. This shows that the resected area is healed well with freely mobile bilateral vocal cords.
And good voicing?
Yes, sir, good. It was not, there were some technical issues.
Any preference there at the type of laryngoscope to be used for plastic treatment? The question is there any preference for a particular laryngoscope for accessing these lesions?
It depends how is the exposure. Of course, you need different types of laryngoscope. The standard laryngoscope that I use is a large bore laryngoscope. Personally, I use the Dido laryngoscope, is from Peeling, but you can use also Storz laryngoscope. The problem is when the exposure is difficult, so you have to use a very small laryngoscope and the procedure becomes more difficult. So with a good exposure, like in this case, the procedure is quite easy. It's become very, very difficult in case of difficult exposure.
Okay.
Dr. Kanav, can you tell me that if the exposure wasn't so good, what maneuvers could you do to improve your access to the anterior commissure to the vocal folds?
Sir, one is like sir said, you can change the type of laryngoscope that you're using. Another, like sir pointed out, is the cut on the ventricle that would improve access. And
External manipulation?
yes, sir, external manipulation is something, the counter traction is what is important.
Even flex a little bit the head, because if you extend your head, the anterior commissure go up. It's much better to keep in Boyce-Jackson position, that a little flex, and the control pressure is very, very important. So you cannot do alone this procedure. You need a co-worker that help you pressing from the external the larynx.
And also the point made by Dr. Peretti that perhaps you could position your laryngoscope so that the beak is a couple of millimeters above the anterior commissure, and that allows the anterior commissure to fall down and to come into view. Yes. And of course, you can then also push it down with your external compression to get it in place. But if your scope is too far in, then sometimes you won't get good access.
Yes. Try to keep the laryngoscope a little higher.
Okay.
Because you can also damage the anterior commissure with the tip of laryngoscope if you go very far. So you stay up the false chord.
Thank you, sir.
Thank you.
Thank you for the video. I think given a short amount of time, there are so many questions that we all have to ask. But let's get to the next topic. The third topic for today is paraglottic space and cartilage evaluation. For the same, I'd like to call Dr. Asif Momin, sir. He's the head of imaging at our institute and Bhatia Hospital, Mumbai. He's also a visiting interventional radiologist at Sir Reliance HN Foundation Hospital. He's the ex-head of imaging at Prince Ali Khan Hospital, Mumbai from 1992 till 2022. He's the immediate past president of Mumbai chapter of IRIA. His areas of interest lie in oncology, vascular, head and neck and breast imaging. Interventions including the tumor ablation and endovascular laser ablation. Sir, please come and address us.
Good afternoon. Thank you so much for having me here. And I'm probably the odd man out here. We'll try and discuss a little bit about the radiology of the relevant topic. And I'm here representing my department of Head and Neck Cancer Institute. And Aditi, Alamgir and Shubham are my colleagues. And I have to mention about their contribution because this is our team efforts. So now we'll be discussing mainly about the aims of the imaging studies. And when we talk about this, we should know what exactly, as a radiologist, I understand, clinicians want anatomy relevant to the given clinical context, extent not seen by clinicians, extended study for staging and final decision making, and post-treatment evaluation. And why we need to understand this, because most of the mucosal surfaces are so well seen by laryngoscopy, indirect and fiber optic, that really there is very few areas which are dark areas or blind spots, and probably we'll try and uncover them. That's our usual anatomy, and we as radiologists mainly see the cartilages and the membranes, and rest all represent as a soft tissues, and that's what we try to understand by using contrast, that differentiating between the various types of soft tissues. But to our rescue, always there's a fat which allows us to distinguish margins clearly. So that's our main important aspect of the imaging. So when we do multi-detector CT of the larynx, we generally want patient to be supine in an extended neck position, which makes patient kind of difficult swallowing and moving and coughing. And we generally obtain axial volume data from base of the skull to the trachea. And this is done with a very important point, that the orientation has to be parallel to the ventricle and true vocal cords. Then we can see a glottic lesion as glottic and subglottic as a truly subglottic. Otherwise, there can be a little bit of overlap, and that's why sometimes we find it difficult to do the review of some images which have been not documented correctly. So I think that's our most important criteria, and so that's why we prefer to have a CD data which allows us to do our own reconstruction. A contrast material which can be used in 2 phases will allow us to highlight the tumor and differentiate it from the remaining tissues, and also to highlight the carotid sheaths, which will make us nodal staging important. So images are obtained during quiet breathing rather than the apnea, and for a larynx, we have to reconstruct images very well, in the sense the field of view should be very small, so only the larynx is highlighted and it's seen more carefully. We do additional dynamic scan during phonation and modified Valsalva maneuver. So that's our usual sequence which we generally just run through. But if this is an entire series right from the base of tongue, the valleculae, the aryepicular folds, the pyriform sinuses, the fat in the paralaryngeal spaces, true cords, and then we come to the subglottic area as we reach down. But we just can't document this in the day-to-day practice. So we have to know what and how we can help in laryngeal cancers. So main important thing would be to talk about the tumor volume, knowing that a certain tumor volume would be useful for radiotherapy as against the surgical resection. Relationship of the tumor to the ventricular complex will be very important. Involvement of the submucosal space, and that is the real important thing about any imaging studies, which allows you to see those deeper spaces. Anterior and posterior extension of tumor, and then these tumors can involve the paralaryngeal or paraglottic spaces, and then the decision can be made whether some surgery will be contraindicated, or sometimes radiotherapy will be not useful. So this decision will be given by radiological imaging. Laryngeal cartilage invasion, which is quite important decision, and that's what we really have kind of arguments and sometimes surprises, and that's where CT has about 70% sensitivity and about good 86 to 94% specificity. But MR in such scenarios can be useful, and it is a problem solving tool. When we see a tumor as high signal on fat suppressed T2 and enhancement on postgadolinium, then we would pick up that particular lesion is a tumor and not the just edema. Nodal or systemic metastasis or synchronous tumor is also always there at the back of your mind, that we want to not miss those. And imaging always helps in post-treatment imaging. That's a general decision. I'm not going to go through this because of the time issue, but we would, as a radiologist, we have to know the epicenter and dimensions and spaces involved, and what decisions generally the surgeons would make, and this should be kept into consideration while reporting these. So that's our dynamic maneuver. If you can see these two images, that's a quiet respiration where everything looks good and effaced true chords and false chord. But when the patient breath holds, they come and gets approximated, and there will be slight soft tissue seen in the region of the anterior commissure. While here you can see this kind of sort of effacement is seen here as though there is a lesion here, but when we make the patient do phonation, that area really opens up. So this really helps us to identify the paraglottic lesion, and especially the the pyriform sinuses, when sometimes you tend to see some soft tissue, and that's why these dynamic maneuvers are very important. These are the general regions, and as we know, we divide it into supraglottis, the glottis at the level of the true chord, and anything below that will be subglottis, and we'll be dealing with the paraglottic space. The paraglottic space, we know that it plays an important role in the T classification of laryngeal cancers, because if it is invaded, SCC, the squamous cell carcinoma, classified as T3 according to the AGCC guideline. However, invasion of the posterior paraglottic space and of the cricoarytenoid spaces is associated with poorer outcomes. So we would keep this in mind while reporting it. Furthermore, the posterior paraglottic space is invaded, the transoral laser surgery is contraindicated. So we know that how to look at this paraglottic space. It's also called as Tucker space. That's a typical tetrahedral space which is in this anatomical image is mainly seen by yellow fat, and that will be continuing in the pre-epiglottic space here, as well as it will be going into the bilateral paralaryngeal spaces, and they will be continuous, and there will be some areas of weakness just at the level of anterior chord where there can be some kind of breach can occur and the tumor can invade through this. So by and large, it is separated from the pyriform sinus only by mucosa, and it is central to the spread of laryngeal cancers. So I think we would just go and see a couple of examples related to this. That's our typical epiglottis, and that is the pre-epiglottic space, which is continuous on both sides with the paraglottic space, and it is very easily seen because it has a abundance of fat, and fat stands out as a hypodense area compared to the soft tissue, which is a grayish area here, which will be standing out against the contrast, which will be a very bright iodinated area. So I think hence we would be seeing those areas very clearly, and we need to understand that we would be using sagittal as well as the coronal or axial planes to identify these spaces. MR would also show this very well, but the MR sometimes, because of the breathing, the areas would look unsharp, but on the higher scanner machines, you can get this correctly. And as Dr. Paretti was yesterday saying, it's better to have a good CT scan done rather than a MR which is not well done or badly done. So I think this is why I think CT generally scores over by, because of the speed of the dynamic scanning, we generally tend to repeat the scan if required. So tumor spread in the paraglottic space typically occurs in the vertical direction. That's important. Lateral tumor spread from the paraglottic space results in the thyroid cartilage invasion, where we would be really looking at. Pre-epiglottic space involvement, as you can see here, is seen here completely. Fat is occupied by the tumor and reaching to the base of the tongue. That's our normal anatomy, which is highlighted by air-filled spaces, and compare that as against this lesion, which is occupying this soft tissue, fat-filled area is occupied enhancing lesion, and then you would not have any abnormal, outcome. It will be able to diagnose this. Knowing the levels is very important because it's, multiple levels are there, so we should know exactly where we are, whether we are the level of the true chord or the false chord or the subglottis, and the true chord is marked by anteriorly oriented vocal process of the arytenoid, and that's exactly where you will get the true chord, which will be a muscle density. And at that level, when we see the anterior commissure, there should be no soft tissue seen there at all, while the posterior commissure will be also a smoothened layer here. As against that, the one level higher, that is at the level of the false chord, we tend to see this fat opacity or fat density very clearly, which allows us to see the margin clearly. Coming one space down, one level down will be the subglottic air, where in the cricoid cartilage we see a very oval soft tissue, which again should be having no soft tissue there. So these are the levels. Coming to some examples, the supraglottic cancer, typically as you can see in right pre-epiglottic space and involving the hyoid bone here, compared this density compared to the hyoid which is involved here, and it is breaching this hyoid membrane and it is coming out. So that distinction is very easy and the diagnosis would be made here. Coronal reformation really helps in knowing the helical CT scan, because it brings out the ventricular interface very clearly and you can mark the lesion very clearly, and these are the ways you can document these lesions correctly and measure them also correctly. Thyroid-arytenoid gap and thyroid-hyoid membrane, these are the areas where through the lesions tend to flow out, and then they can widen this area. Compare this area as against the opposite normal area. Here the paraglottic space, the fat space is infiltrated by this mass here, and you can see the widening here. Lesion may go behind and reach the post-cricoid area, as well as it can invade the cricoid sheath. So this is how generally the anatomical description can be shown onto a good CT scan. Only other lesion which sometimes benign lesion can be a surprise, sometimes a laryngoscale, just to highlight that such a lesion can be very well demarcated compared to the other lesions which are kind of fuzzy lesions, but this is a very sharply demarcated lesion. That is one of the other paralaryngeal lesion or paraglottic lesion. I thought I should just show that one image. Left glottic cancer, as you can see here, there is a soft tissue here, which allows us to know that that's exactly the anterior level. Coming to the next thing about the general sequence of ossification, by which we should know as a radiologist that the ossification typically goes in a usual pattern from exactly from the dorsolateral to ventromedial, sparing the lamina. But this is how generally the ossification will occur, but rarely there can be unusual pattern. That's why identifying exactly the usual pattern doesn't help us, and we have to rely on the tumor and the actual contrast enhancement which occurs, and actually the breach in the cartilage and occasionally sclerosis. So even though these variations are common, we would tend to understand there are some criteria by which we can measure criteria where actually the tumor is breached and you can see a defect, and maybe there can be extralaryngeal infiltration, or there can be a smaller invasion which can be just seen as a subtle sign, and we'll just see a couple of examples. As you can see here, this is the entire cartilage is destructed here. This is a cricoid cartilage is again totally destructed here. So in these cases, there is not much difficulty, but difficulty can arise when, if you compare these laminae, there is a little bit of defect here. We don't know whether it's unossified cartilage or no. In those situations, we sometimes rely on the sclerosis, which is less specific, but it is definitely showing that there is some involvement, and maybe there is an inflammation, and this could lead to a further breach in the cartilage here. So I think even in this case, you can this sclerosis, compare this vis-a-vis from the opposite side, the left looks more sclerotic. So we'll just go beyond. MR generally helps us in situation where we can't really identify it completely, because the thyroid cartilage will have a typical intensity, and if it is breached by the tumor, you would get that replacement, and the contrast, using contrast at this stage will definitely help us to diagnose. So here again, there's a very subtle erosion. As you can see, this lamina is very clear. There's a tumor and there's a bit of defect here, which is considered as one of the signs of cartilage erosion. Coming to the MR, I think we know that these images, when we see this fat suppressed images, you can see the cartilage is seen as a hyperintense, while when there is a breach, we will actually see there is intact margins are identified, and you would use the MR in those special cases where we are having difficulty. So I think I'll not go through the protocol because it's somewhat similar, but we need a very high field MR scanner with a neck coil, and that's when we will use the contrast and use the contrast. So I think just to understand the mechanism by which cancer invades the laryngeal is one is the inflammatory phase, and second is osteoblastic phase, and there's a osteoclastic phase. I'll just take a couple of minutes. This is a typical cartilage where we can see a lesion is invading in that area, and then we'll be distinguishing between the two sides. We will be able to make this distinction. Just keep here. CT versus MR, I think we understand because ossification is a little bit haphazard, we will have some problem, and sclerosis can play mischief. So we'll also rely on MR in certain cases. And this is one example of extralaryngeal spread missed on CT, but detected on MR imaging. You can see here, there's a small subtle tumor. You will not have such a distinction here. And this is another similar attenuation values of carcinoma and non-ossified cartilage on CT can be avoided by using MR images. So these are some special cases. So I'll just roughly go through this. Rarely when we have doubts, we use guided FNCs and biopsies, and sir has encouraged us to do it in appropriate setting, and we would get a tissue diagnosis when a lesion is not seen there. And sometimes you get surprises. This was looking like a regular squamous cell carcinoma, but this was a adenoid cystic carcinoma. Just lastly, 1 or 2 slides about the ultrasound is used in larynx because larynx can be, when the cartilage is not opacified and completely ossified, it serves as a good window, and you can see a complete tumor here, and we can also use it for the movements, especially in pediatric age groups. So I think the work is always going to go on, and sometimes you use this same situation, we can use the ultrasound for doing some biopsies, especially in difficult patients who cannot lie down clearly. Glottic or epiglottic tumors are very well identified. And this is the last slide. It's about the using contrast enhanced ultrasound. In cases we may use tumor enhancement and show it against the non-opacifying cartilage, and this would be work in progress, and we would be probably doing this in our institute. So this is our checklist, the subsides, the spaces which are involved, if the cartilages are invaded, and whether the carotid arteries are involved, and the lymph nodes on either side, and what levels are involved, we'll be talking. So to conclude, what needs to be seen for better laryngeal neoplasm management is reasonably done by imaging. Depending on imaging results, management choice can change. MD-CT is the mainstay. MRI is the problem-solving tool. Ultrasound has limited role, and cartilage invasion is a jigsaw puzzle to be solved by multimodality approach. I thank you all for kind attention. Thank you for giving me this.
Can you tell us something about the post-treatment imaging?
Yeah, I think there will be a separate talk on that. So I have kept those slides away, but we use that quite often. Though it is quite often, it is, we are at little loss because of the lot of changes which occur there. So we use CT as well as MR there.
I completely agree with your, I enjoy your presentation. It's important, in my opinion, also underline the important role of imaging during the follow-up, especially after transoral laser microsurgery, because the majority of the recurrence in intermediate cases are submucosal, so very difficult to detect endoscopically. Maybe you can see just the fixation of the arytenoid, but without any esophytic pattern or lesion. So in this case, I suggest always when I treat T2 or T3 cancer, stage this imaging even if endoscopy is normal, because you can anticipate the submucosal recurrence and maybe make feasible another conservative surgery, for instance, open partial laryngectomy instead of total laryngectomy. So it's very important to follow the patient after transoral laser microsurgery with the imaging combined to the endoscopy.
Thank you. So I think we will just generally, we have a little problem. I think we generally overestimate staging wise on CT. That's what generally we tend to get that feedback from our consultants, that we sometimes overstaging is our...
Yes, from T2 and T3.
Yes.
Not T1, of course.
Yes.
But if you treat transorally T2 and T3, I suggest to perform a CT scan after 6 months,
Okay.
even if the endoscopy is normal.
Fine. So to see the submucosal lesion.
Yes,
Thanks.
because the majority of the recurrence are submucosal. So maybe you can detect
Yes.
before the endoscopy.
Yeah. Thank you so much.
So moving on to the last topic of our first session, I'd like to call Dr. Ketan Ingle for the topic frozen section in transoral laser microsurgery. He is the associate consultant in histopathology department at our institute. He's completed his MD pathology from Tata Memorial Hospital, Mumbai. Formerly consultant histopathologist at the Prince Ali Khan Hospital and assistant professor at KEM Hospital. His areas of interest lie in head and neck pathology and lymphoid pathology.
Thank you. Good afternoon, everyone. So let's get going. I'll be talking about role of intraoperative frozen section consultation in transoral laser microsurgeries. So as we all know, TLM or TOLR is an established treatment modality, and margin assessment is very important. It is often done on the final resection specimen. Frozen section is not that well established. The positivity is a risk factor for local recurrence. The margin resection, if it comes positive, the further options include either a second look surgery or observation. The impact of margin status has been analyzed by various meta-analyses. They advocated more prospective studies for accurate assessment because the different studies had different results. But the overall, what they had observed is that the recurrence rate in the patients who had positive margins was significantly higher. And the second study also has an increased overall adjusted hazard ratio, which was 1.3, with a wide confidence interval, actually. So margins are important. So frozen section assessment in transoral laser microscopy can be utilized for two things. One is a primary diagnosis to determine any other pathologies, and the margin assessment, that is the primary indication. Transoral laser microscopy, the important considerations that are that resected tissues tend to be very small, and the margin orientation is an issue. For the margin orientation, as we all know, the tissues are generally pinned on some kind of support, and the surgeons orient the tissue with the help of pins or differently inked margins. Surgeon can sometimes carry the tissue to the frozen section room, orient it for us, and which we can ink and process further. The best chance is the first chance, because very often there is no tissue or no second attempt where we can reorient or redo the margins. So these are some of the photographs. Here we can see the pins, and this one is the green ink and the other is the red ink, if you can see it. These are the other approaches that have been used at other institutes where a drawing has been done to determine the location of the tissue, and different types of inks are placed like this. Newer approaches that are being tried this is a pig liver slice on which the specimen has been fixed so as to determine a deeper margin evaluation is better. That's what the study proposes. Coming to microscopy, this is how we get the specimen in the frozen section. So as we all know, this is the tumor, and this is the overlying epithelium. You can see a part of muscle over here in the basal part. So this is the deeper margin. Now the distance of deeper margin from here appears a bit close, and these are the mucosal margins on the lateral aspect, means the anterior and the posterior aspect in the body. So this margin, as we see here, so let's go on further. Know whether it is apparent, but on microscopy it showed involvement by carcinoma in situ. So this is how we assess. This is the deeper margin. These are the tumor islands reaching near the deeper margin. This is the corresponding paraffin section. As we all can see here, this area is bit bluish, so that indicates the freezing artifacts. This is a big issue in the laser microsurgeries. This is a toluidine blue sectioning that we do for quick staining, and this is the corresponding hematoxylin eosin section. So what are the challenges that we face in microscopy of the laryngeal resections? So given the small size, first challenge is to properly orient the tissue for sectioning. The margin orientation is the first issue which is taken care by the surgeon and given to us. But the second thing is to orient for the sectioning. Because to assess the dysplasia, we have to have proper orientation of the epithelium on microscopy. The tangentially cut sections can have difficulty in diagnosis. Second thing is the freezing and the thermal artifacts. Thermal artifacts I will just show you. And the freezing artifacts which are inherent in any frozen section diagnosis. Certain low-grade dysplasias might not be apparent on the frozen section, but can be seen in the final paraffin sections. And the freezing of tissue might diminish the quality of the specimen. Sometimes if we need to do some kind of additional testing on the paraffin sections, then it hampers the quality of the tissue. This is an example of tangential sectioning. Here we can't see what is the top side of the epithelium and what is the interface to the basal side, because the epithelium has been tangentially sectioned, so it's difficult to assess the levels of dysplasia. Thermal artifacts are the most important problem in the laryngeal microsurgeries. The heat induced by the laser causes alteration in the morphology, results in crumpling, and can lead to false positive results. So many studies found the incidence of positive margins which were actually negative. The dysplasia can be overinterpreted. Use of AccuBlade system is suggested to have less thermal damage to the margins. So these are the images of thermal artifacts. As we can see here, this black portion is the ink, and over here, due to the thermal artifact, the tissue has been crumpled, and these are the nuclei which have become stretched and elongated, so we can't interpret anything over there. Another image, this is again the margin, which is showing thermal artifacts. Here we have some dysplasia in the epithelium, which we can't predict over here whether it is reaching the margin, whether it is involving the margin or not. So these cause difficulties. Coming to accuracies of frozen sections in laryngeal microsurgeries, few studies have evaluated the rules. So they found quite a good concordance rate on the frozen section diagnosis and the resection, final paraffin resections. They concluded that it's reliable and has high negative predictive value. Indian data from Bombay Hospital by Dr. Nupur's group found the sensitivity for margins to be around 60%, whereas the specificity and predictive values were in the range of around 90%. FS for primary diagnosis were found to have quite a good sensitivity and specificity profiles. In brief, our experience at HNCI, we have had around 25 microsurgeries. The types of specimen were predominantly vocal chordectomies, few false chord resections, PFS, and epiglottis. Squamous carcinomas and carcinoma C2 were the major lot, and other pathologies were seen in 4 cases. Other pathologies included laryngeal papillomatosis, 1 case of laryngeal amyloidosis, and 2 cases of leukoplakias. This was the overall data. The predominant tumor was the moderately differentiated squamous cell carcinoma. Poorly differentiated were the second in line. NC2 was seen in 2 cases. And the margin status, majority of the tumor margins were free. 1 case shows involved and 1 case shows closed margins. In few of the cases, we couldn't comment on margin due to very scant tissues which got depleted and were just showing the lesions, so we weren't able to comment on the margins. So a few examples of the pathologies that we found. This was a case of squamous papilloma. We can see the papillary outgrowths over here. This is the usual squamous carcinoma. This is a case of leukoplakia. We can see the thickened epithelium and the keratinization. This was the case which showed moderate dysplasia. So to summarize, it's a fairly accurate and reliable tool to assess margins in transoral laser microscopy. It can limit the need, the cost, and the emotional stress of second look surgeries. Thanks.
One question. You take the frozen section from the bed or from the specimen?
The entire specimen we usually receive for the frozen section, sir, in block.
In block.
And if sir, many a times we receive one or two margins, not all the margins. Okay. One additional tissue maybe which the surgeon is suspicious.
Because usually when you have to distinguish early lesion from more advanced lesion. Of course, in early lesion, you perform en bloc resection. I mean, there is no need, in my opinion, about frozen section. If you perform a larger resection, of course, if you have some doubts, you can take a frozen section from the bed of the. But most of the time, you reach the superchondrial space, so plane, so you have no tissue to send to the to the pathology for examination. And you have to take into account that in literature, the positive margin are around, after TLM, range from 20 to 40%, but almost have false positive due to the cause that you are mentioned already. But we published 2 years ago a series of more than 400 T1 and T2 glottic cancer. We observed that if you have only one margin, superficial margin, positive or close, it doesn't interfere with the survival and recurrence rate. By contrast, if you have more, all the superficial margin or the deep margin is involved, this means that the resection is not correct, is incomplete. So if you have only one margin, you don't need a second look. If you have more than one margin, or margin, deep margin, probably you have to change your approach and shift to open partial. Okay, this is our position. Okay, I can show you.
I think this is a very difficult situation, both with regard to frozens and even otherwise when you remove the whole specimen, because, I mean, when you're doing laser resections, margin is assessed in a large way per operatively, especially now that narrowband imaging is also available, so that allows you to get very good precision with your superficial margins. And also the laser tissue interaction and how it cuts the tumor, or the normal tissue, because there is more charring when you cut tumor tissue, also tells you as to whether or not you are in a reasonably good place. And of course, the excisions are so small in margin that whatever you finally get sent to your lab ultimately has such a small margin or sometimes some charring that you have great difficulty in telling us what exactly is going on there. So I frankly have very rarely do you use a laser in frozen in this situation that I tend to use. And perhaps Nupur, you can also answer. You can also. What is your thought? When do you use frozen and when do you not use frozen, if at all?
So you go first. So I do appreciate everything everyone said. I'm happier to send frozen margins always from the patient side, first thing. It just works better in our hospital when I'm sending it. And I don't agree that it becomes deeper margins, because I remove the tumor, just the tumor first, and then take it like a carpet in the periphery and the depth. So I think if you're doing a type 2, you're still doing a type 2, and my pathologists are happier. From the medical-legal perspective, it works very well for me to get on paper that the margin is free. I mean, it doesn't have to be frozen, it can be histopad too, but it works out well. And as you saw what you published, the accuracy was pretty good. So we are happy to use the frozen because we have it and for these reasons. But I'm not saying if you don't use it, you're doing anything wrong, but those are my reasons, really. So.
Very rarely do I use frozen section in transoral laser resection.
Yes, sir.
But this morning I did.
Also because the frozen section, you evaluate just a a small amount of tissue in one margin. It's not probably representative of the entire specimen. So this is the reason because it's very important to have a close collaboration with the pathology and well-oriented the specimen. So you have to discuss with the pathology how you prefer to receive the specimen. For instance, I don't use the needle because I don't want to damage the tissue. I just ink a margin suggested by the pathology. And in this way, if the histology make many frozen, can have a more accurate evaluation of the specimen. Instead, all specimen a smaller amount of tissue.
We do it exactly the same way where we send it on filter paper and we mark anteriorly.
Yeah.
We draw the vocal folds on the filter paper and place it, and we have the boy taking the filter paper, so we have a good, we don't use pins either.
This is the most important thing.
Professor Peretti, just one question. For a post-op imaging, what would you prefer, a CT scan, an MRI, or a PET scan?
You mean in more advanced cases?
Yes,
yeah.
yes.
During the follow-up?
That's right.
I talked yesterday with the radiology. If you have, I mean, it's easier to interpret a CT scan compared the MRI, especially if there is a patient not compliant. So usually the CT scan is okay.
Is a PET scan also used?
PET, no, for, I mean, for T2, T3, no.
No.
I use a PET in advanced cases, in pre-operative setting, just to exclude distant metastasis or something like
Thank
that.
you.
PET is useful in the follow-up when you suspect that there is a recurrence and you are not able to prove it. Because there is all mucosal edema post-radiation, and you are not able to, you suspect that, you strongly suspect that there is a recurrence, but there is no mucosal ulceration, you can't take a biopsy. PET is very helpful. PET, and then Dr. Momin will do a needle aspiration from there.
Thank you, our chairpersons, for guiding us through this session. So, a very thank you for this. We'd like to introduce the next chairpersons for the next session. And after that, we'll be playing few videos by Dr. Giorgio Peretti, sir.
So we're moving on to the next session, that is intermediate laryngeal cancers. So our chairpersons for the sessions are as follows. First is Dr. Anaga Joshi ma'am. She is the professor, ENT department, Lokmanya Tilak Municipal Medical College and General Hospital. She has a special interest in laryngology and she's an avid sports person and a musician. Second is Dr. Deepa Nair ma'am. She is the professor of Department of Head and Neck Oncology, Tata Memorial Hospital. Her special interests include robotic and minimal access surgery, skull-based surgery. She's also currently running a randomized controlled trial on single cord radiotherapy, and she's an expert in the field of Bharatnatyam. Next is Dr. Tapan Saikia sir. He's the chief of Department of Medical Oncology here at HNCII. He's also a consultant medical oncologist at Jaslok Hospital. He's a member of the ethics committee of Tata Memorial Hospital, and he's a visiting consultant to the State Cancer Institute in Guwahati, Assam. His special interests lie in hemato-oncology, solid tumors. Then we have Dr. Azmat Dr. Ma'am. She is the senior consultant in the Department of Plastic Surgery here at HNCII. She was a gold medalist in plastic surgery at Rajiv Gandhi University of Health Sciences, Bangalore. She was also featured in the top 10 plastic surgeons in Mumbai list by Outlook in 2024. Now, beginning our next session, we'll have our first speaker as Dr. Okay. Okay, so first we'll have a few videos by none other than Dr. Peretti sir.
Now I come back to the previous concept. I'll show you some example of type 1, 2, and 3 chordectomy, just to stress the concept of excisional biopsy and the laser treatment. Excisional biopsy means that we perform a resection without a previous biopsy, based on the information coming from your accurate workup, MBI, video stroboscopy, infusion, and maybe CT scan in more advanced cases, but it's not the case. And if you perform excisional biopsy, the two ways to perform excisional biopsy are type 1 and type 2. Okay. Type 1 is indicated in case of normal mucosal wave, positive aldro dissection in the Ranke space, and of course for the lesion limited to the middle third of the vocal cord without involving the anterior commissure, because if you involve the anterior commissure, you have to perform another type of chordectomy. So this is type 1 chordectomy or supraepithelial chordectomy. In this case, you remove the epithelial layer in the Ranke space, sparing the vocal ligament. So this is the phonosurgical approach in very selected cases. If you have this is a simple keratosis, MBI negative, the balloon is positive, and the mucosal wave was normal. So it's very limited cases. You can see the plane of the resection is between the epithelium and the vocal ligament. The vocal ligament completely spared. You see the AccuBlade is working without any char. This is very important to avoid any thermal damage to the specimen. So the same approach you use for phonosurgery. So you try to spare the ligament. And it is important also to minimize the grasping of the specimen, because if you grasp with your force the specimen, you can damage the margin. So the evaluation of the margin, this is the vocal ligament, is important, you have to take in account that you have respect also during the procedure, the margin, reduce the thermal damage. I grasp the subepithelial layer, not the margin. So you have to send the specimen in the best situation to achieve a very good or a very reliable answer. So by contrast, type 2 is performed in a subligamental layer, just keeping a small amount of muscle, and is indicated in lesion confined to the basal membrane, not transgressing the vocal ligament, that represent the majority of the case involving the vocal cord. When I perform type 2, when MBI is positive, when the mucosal wave is impaired, or when the ballooning is not complete. In this case, I try to spare the vocal muscle. This is an example of type 2, so the concept is the way the same. I perform before the ventriculectomy, I remove all the mucosa of the ventricle, but I change the plane. Now I am between the vocal ligament and the muscle. So I go a little deeper, but I spare completely the muscle. So this is the best compromise to obtain a complete removal of the lesion, but also after the healing process, the complete closure during the phonation. So it's the best compromise between oncological radicality and functional outcome. This is the same example in cadaver, just to give you some example how to train this chordectomy. Again, the plane of the resection is between the ligament and the vocal muscle. So you have not go through the muscle, but you have to spare the muscle. This is the ideal chordectomy for a case limited to the third, middle third of the vocal cord. Type 3 is indicated only when a patient have already biopsied. So you have a patient with a positive biopsy. Of course, you cannot do stroboscopy because is altered by the scar tissue. The infusion is not possible again because you have a scar tissue and the balloon is not feasible. So you are obliged to keep a deeper margin of the resection. So you remove the medial part of the vocal muscle. Sometimes you can have also no tumor, but the patient is sending you for treatment, for radiotherapy or for laser, and you are obliged to perform a deeper resection. This is the cause because I suggest not perform just a random biopsy, but a incisional biopsy up front. Otherwise, you are obliged to make a deeper resection. This is the case. The patient was already biopsied. It's very important to evaluate intraoperative with the angle telescope, the 17 telescope, just to evaluate the involvement of the anterior commissure or the subglottic station. Again, the ventriculectomy was already performed. You see the position of the laryngoscope is higher compared to anterior commissure. The concept is always the same. Take out all the mucosa, but change the plane, the deeper plane. In these cases, I go through the muscle just to keep out a little bit of muscle. It's important to rotate the specimen just to control the inferior margin of the lesion. And you see, I start always from the vocal process. It's the same concept. You have to remove all the mucosa, all the superficial mucosa, to have here the vocal muscle included in the specimen. And of course, a little muscle is taken out just to give the possibility to say that from the histology there is infiltration or not. So these are the concepts how to face with excisional biopsy. After this type of chordectomy, type 1, 2, and 3, the type 4, 5, and 6 have different tasks. The more extended chordectomy has a treatment alternative to open or radiotherapy or whatever. And of course, if you face with type 4, 5, and 6, you need a previous biopsy because you cannot remove all vocal cord or anterior commissure in a patient without any counseling, preoperative counseling. Okay? I show an example, type 4. Type 4, you go in the supracondylar plane, so you can imagine the incompetence will be important, so the voice will significantly reduced by this kind of chordectomy. And this is an example of type 4 chordectomy. Again, it's very important, especially in this case, to remove all the false cord just to control the lateral extension of the lesion. And you have to reach the supracondylar plane. So this is the treatment, endoscopic treatment, is not more excisional biopsy. This is a treatment alternative to radiotherapy or open neck autopsy. As I told you before, if you reach the supracondylar plane, it's difficult to make a frozen section of this plane because you have removed already the supracondylar, the perichondrium. So if the pathologist said to you, okay, the deep margin is positive. This is a big problem because you have not more tissue to remove. So in these cases, or you shift to open partial and you remove all the laryngeal framework, or you have to follow the patient with MRI or CT scan. This, for me, is the most challenging situation, where you have already removed all the lesion in supracondylar plane, and the histology confirms you that the deep margin is positive, because you have no space for frozen section. So sometimes happens to me to perform open partial laryngectomy for the positive margin, but in the specimen, no more tumor was found. So you have to talk with the patient to explain the problem and to say, okay, or you follow a strict follow-up with CT scan or MRI, or we can perform an open partial laryngectomy, but there is the possibility that we don't find any tumor on the specimen.
Can I ask you a question?
Yeah.
So we have been seeing that you have been doing a arm block resection all this while. Is there some situation where you do a segmental resection, like the Steiner technique?
Yeah, I don't put here because this is just to explain the ELS classification. In the next, my presentation, I show you the transport bar. So type 5, you have a different type 5 of extended cordectomy, extended to the anterior commissure, to the supraglottis, glottis posteriorly. And this is the case of type A, including the anterior commissure. Again, ventriculectomy. In this case, to achieve a good margin, you have to extend your resection to the opposite contralateral vocal cord. It's very important to underline the inferior margin, and you have always to evaluate the inferior extension with the 70-degree telescope before starting your resection. You have to put in your mind the spreading of the lesion, because this information is very important. And in this case, the tumor was located in the anterior part of the larynx, so I spare some muscle in the posterior part. This is the part of the vocal process. And I reach the subperichondral plane more or less here, where the lesion starts. So you have, with the Acu blade, you can make a faster resection without any char. So I extend the resection to the opposite vocal cord, just the anterior third of the vocal cord. This is important for the evaluation of the anterior margin. And then I go to dissect the macula flava to reach the superichondral plane. This is the superichondral plane. Even in this case, I try to do unblock resection. Okay, always you have to pull a little bit the lesion, and when you reach the macula flava, is the more tough point. You have mechanically denudate the cartilage, so you can remove all the macula flava and the broil ligament, reaching the subglottic plane. This dark spot means that with the laser attach the cartilage. And then the last one is the type 6. Type 6 means the resection of the anterior compartment of the larynx. When you face with anterior commissure lesion extended to the supraglottis or the subglottis, type T2 lesion and anterior commissure. This is the case, tumor involving the anterior commissure. So I start bilaterally. Again, the lesion was confined to the anterior compartment, so I tried to spare some muscle posteriorly, tried to improve the vocal outcome, but it's difficult because after this type of resection, for sure you have a synechia. And in this case, I denudate the cartilage, reaching the cricothyroid membrane, so I extend my resection in the subglottic plane. I delimitate the inferior margin, pulling the lesion up, and this is the final resection, where you have completely removed all the anterior compartment until the cricothyroid membrane. Here makes sense perform a frozen section maybe, because I mean the exposure in this area is not optimal. So if you want to be sure that your resection is complete, even inferior, and you have a soft tissue here because you have a membrane, you can perform a frozen section here, but you cannot perform any frozen section where the cartilage is already denudated. Okay, I stop here because in the oration I repeat many concepts. Just to explain you the difference, the goal of the classification of the ELS was to have a common language among us, and talk not only cordectomy, also to compare the functional outcome. You can compare with the radiotherapy. If you perform type 2, type 3, is a comparable result. Of course, if you perform one type of resection like this, you cannot compare the functional outcome with the radiotherapy. Okay, but the concept was to have a common language to distinguish the cordectomy with the concept of a seasonal biopsy and the cordectomy used as an upfront treatment after biopsy. This is very important to understand. Thank you very much.
Thank you, sir. Thank you for the videos. Now we will move on to our first talk of this session by Dr. Tasneem Bharma, who will be talking upon the topic chemotherapeutic agents for organ preservation. She is a consultant here at in the Department of Medical Oncology at HNCI. She has her expertise in head and neck cancers, breast cancer and gynecological cancers, and she has focused on improving patient outcomes with the recent thesis on the quality of life in breast cancer patients. And currently she's been involved in an ongoing study examining cisplatin and methotrexate as a palliative chemotherapy regimen for head and neck cancers. Over to you, ma'am.
Good afternoon, everybody. I'm here to talk about the role of chemotherapy in laryngeal cancers, ideally locally advanced. So let's start the discussion. So what does functional organ preservation mean? An organ preservation means a way to maintain an organ in an unchanged condition and to avoid its loss. While a functional preservation means that function is preserved whether the organ is totally or partially preserved. Organ as well as function preservation, it plays a very important role in quality of life of our patients. So the historical overview of functional organ presentation. So anything before 1960s was majorly surgery alone. 1960s to 1980s was the era where radiotherapy in this field developed. Post 1980s is when the role of chemotherapy came in. It evolved over the next 2 decades, followed by the role of bioradiotherapy, which came in around 2010. So what are the methods in which a functional organ preservation can be done? The first method is induction chemotherapy before resection. Second, induction chemotherapy followed by definitive RT, or concurrent chemoradiation or a bioradiotherapy. So larynx preservation, as as trials goes, it all started in 1991 with the VA trial, followed by RTOG, GORTEC, EORTC, and the Tremplin. There was a meta-analysis called McKenzie, which came up with updates in 2000, 2006, 9, and 11, which also shaped our current practice in laryngeal preservation. So coming to the first trial, which was VA trial in 1991. So what they basically did is they looked at the role of induction chemotherapy. So the cohort was divided into two types. One in which they gave induction chemotherapy, 2 cycles of paclitaxel 5-FU, followed by a response assessment. So for people who at least attained a partial response, a 3rd cycle of induction chemo was given, and then it was followed by radiation. For people who did not achieve a partial response, surgery followed by post-operative radiotherapy was practiced. This was compared to surgery plus post-op radiotherapy, which was a standard of care at the time. When they looked at it, around 64% of patients had a biopsy-confirmed CR after 3 cycles of chemotherapy, and 14 patients never received a cycle 2 due to toxicities. So looking at the 3-year results of this trial, so laryngeal preservation was possible in 64% of patients. There was no difference in overall survival. The local recurrence was higher in the induction therapy group, which was obvious given the fact that we are delaying local therapy once you give an induction therapy. But the distant metastasis and the rate of a second primary were higher in the surgery group. So to conclude, this trial established the role of induction chemotherapy followed by a definitive RT, and it is an effective means of preserving the larynx without compromising overall survival. The major criticism of this trial was that the control rates for T3 cancers, which was 65% of the enrolled patients, were similar to the historic published rates of RT alone. Another issue that came was that there was no comparison arm in which they tried radiation alone. So the RTOG 9111 came in, which was trying to address this question. So here again, stage 3, stage 4 glottic and supraglottic cancers were taken in. Patients were divided into 3 arms: radiation alone, upfront chemoradiation, in which cisplatin was given at 100 milligram per meter square 3 weekly, or a similar arm, or like the VA trial arm, where induction was given, and depending on response, patients received either surgery or radiation. So the primary endpoint of this trial was larynx preservation. Secondary endpoint was overall survival, disease-free survival, laryngectomy-free survival, and locoregional control. So again, at 3 years, if you look at this trial, it showed that concurrent chemoradiation gave higher rates of laryngeal preservation than induction or RT alone, with a better laryngectomy-free survival and a better local regional control than RT alone. Comparisons like overall survival were not significant. Treatment failures were significantly fewer in the chemoradiation arm, and overall patients who received chemotherapy, either in induction or as a concurrent chemotherapy, had a better disease-free survival than those who didn't. So this trial established that, if possible, concurrent chemoradiation should be the standard of care and not induction chemotherapy. This was the long-term result of RTOG 9111, which was done in 2013, where they looked at 10-year outcomes, and they found that laryngeal preservation and locoregional control was better in the concurrent chemo plus radiation arm. The laryngectomy-free survival was better in any arm which received chemotherapy, either as induction or as concurrent, while the overall survival remained the same in all 3 cohorts. Coming to the next trial, which is the EORTC trial, which tried to see whether there's a role of sequential versus alternating chemotherapy and radiation. So the sequential arm was same as the VA trial arm, while the alternating arm tried 4 cycles of paclitaxel 5-FU, and they alternated with 3 courses of radiation, 20 gray in 10 fractions each. Again, at median follow-up of 6.5 years, no difference in overall survival, no difference in progression-free survival, or a survival with a functional larynx. Toxicities were also relatively similar. So we just follow the sequential arm at this point of time, and we don't really alternate with radiation. Now, what is the choice of induction chemotherapy that we use? So all the previous trials have tried a doublet combination in which they've used platinum along with the 5-FU. The first trial that tried a triplet combination was the GORTEC, which came out in 2000. In this, they tried 3 cycles of induction chemo. One cohort of patients received TPF, while the other cohort received PF. So TPF included a taxane, either a docetaxel or a paclitaxel. So again, the rest of it remains the same for patients who did achieve partial response. Radiation was done. For who did not, less than partial response, surgery followed by radiation. So again, the primary endpoint was 3-year laryngeal preservation rate, while the secondary endpoints were overall survival, disease-free survival, response rate, and acute and late toxicity rates. So what this trial showed that the overall response rate after induction chemo was 80% in the TPF arm and 59.2% in the doublet arm. Median follow-up at 3 years, the laryngectomy, laryngeal preservation rate was higher in the triple drug arm versus the doublet arm. 3-year overall survival was the same in both the arms. 3-year disease-free survival was better with TPF, but it failed to reach a statistical significance. So the long-term results, which again were a 10-year results, showed that differences observed in laryngeal preservation and larynx dysfunction-free survival were statistically significant towards the triplet combination. The authors noted that this study was not basically trying to address the point of overall survival. And the conclusion of this trial was TPF is superior in terms of organ preservation and preservation of functionality of the larynx. So whenever an induction chemotherapy is tried for a patient, ideally TPF is the preferred regimen. Sorry for the typo there. The next trial that came in was the TAX 323 and the TAX 324. Both of these trials took unresectable head and neck cancers. The primary endpoint was of TAX 323 was progression-free survival, while of TAX 324 was overall survival. So again, here we saw that the triplet was better than the doublet with a significant difference in progression-free survival and overall survival in both the trials. So this concluded that the response rate of induction chemotherapy was higher with the triplet than doublet. Induction chemo with TPF improved survival compared to a doublet regimen due to increased loco-regional control. The rate of distant failure was low with either of the chemotherapies used. The major limitation of this was that there was no arm which compared concurrent chemoradiation with induction followed by radiation. So it is unknown whether that improved survival of TPF would be observed in a setting where a concurrent chemo-RT can be done. Then came in the trampoline trial in 2013, which looked at the role of bioradiotherapy, that is the role of cetuximab. It compared cetuximab and cisplatin along with radiation. And what they found was that laryngeal preservation at 3 months was similar in both the arms. The larynx function preservation was similar at 18 months. Overall survival was similar. Tolerance and compliance with treatment was also similar between both the arms. Now coming to the McKenzie analysis. So this analysis, it is a meta-analysis which was first published in 2000 with subsequent updates. What this analysis was trying to answer is the effect of chemotherapy, that is RT treatment when compared to RT plus chemotherapy, the timing of chemotherapy, whether a concomitant or alternating CT-RT is better than NACT followed by radiation, and larynx preservation with neoadjuvant chemotherapy, wherein a radical surgery followed by RT was compared to neoadjuvant chemotherapy plus RT in responders and surgery in non-responders. So the 2000 update included 63 trials, more than 10,000 patients. What it showed was that the absolute benefit of concomitant chemotherapy along with radiation was around 8%. There was not significant benefit with either an induction chemo or adjuvant chemo. Larynx preservation showed a similar impact. The McKenzie 2009 again showed a very similar kind of picture, wherein the absolute OS benefit of a concomitant chemotherapy was 6.5 versus induction chemotherapy which was 2.5 at 5 years. So to conclude, the survival benefit of adding chemotherapy was around 4%. There was no clear benefit of induction or adjuvant chemotherapy. Magnitude of benefit of concomitant chemotherapy is less in older patients. There is a clear advantage in the favor of concomitant when compared to an induction chemotherapy. Concomitant chemotherapy gives clear benefit in locoregional failure. Induction chemotherapy gives more pronounced benefit when it comes to distant failure. Hence, it is not possible to rule out benefit of induction chemotherapy. So who all do we offer this idea of laryngeal preservation? So specifically laryngeal and hypopharyngeal T2 to T4 tumors without any massive cartilage invasion or extension to soft tissues, without any laryngeal dysfunction, and age less than 70 years and who are fit for chemotherapy. When do we not go ahead with organ preservation? Gross cartilage invasion, dysfunction, larynx, patients who prefer avoiding a radiation, those who cannot tolerate chemotherapy or refuse chemotherapy, poor performance status patients, age more than 70 years, or patients who present with severe airway compromise, who either require a tracheostomy or a enteral feeding before we initiate the treatment. Why not to go ahead? Because in most trials, larynx preservation was the primary endpoint. We still don't know whether preserving a larynx will lead to a better disease control. So ideally, we need more trials which are addressing overall survival along with laryngoesophageal function. None of the trials which have been spoken previously actually gave an overall survival benefit. So is the strategy feasible? Yes. What is the best treatment protocol to follow? It has to vary depending on patient and physician preference. There can't be one rule which you just follow for everybody. So there is no standard larynx preservation treatment which is accepted worldwide. CTRT should be preferred. Role of NACT, very limited, especially bulky diseases, higher chances of distant mets, gross exolaryngeal spread without cartilage involvement. Bio-RT can be tried if chemo-RT is not possible. And options of laryngeal preservation, including concurrent induction or bio-RT, have emerged over several decades without any improvement in overall survival. Thank you so much.
Any questions from the audience? A wonderful, very good lecture. Any questions from the audience?
Very good presentation, but you don't mention the last update of the ASCO about the Forestier work that re-evaluate the previous paper, where he showed the paper that the toxicity of the combined chemoradiation is much higher, and the laryngeal preservation was negatively impacted in terms of functional result, increase the permanent gastrostomy, a permanent tracheotomy. So the paradigm shift a little bit in favor of induction compared to the concomitant upfront treatment. Are you agree? Do you agree?
So it's a difficult question, sir. I would say that induction chemotherapy has its role, but it is only in a select subgroup of patients. It should not be for everybody across the board. What else do we expose patients to in a locally advanced cancer where they will lose the larynx if we go in for a surgery upfront? So it's not a bad idea. I do understand the long-term issues that will crop up. In fact, I have a friend who suffered from CA larynx 2007. She's a survivor. It's not a very great life morbidity-wise. She has developed bilateral sensorineural hearing loss, requires a hearing aid. She has swallowing difficulties, speech. As the years have gone by, it's genuinely worsened. But it's 15 years now. She has a preserved larynx. So that is against a surgery which would have, debilitated her in many other ways. So it's a difficult one to pick.
I mean, he has a role maybe as a selection of patient. If in a responder patient, you can go for radiotherapy alone, or in non-responder, you go straight to the surgery. Combined to the compared to the chemo radiation up front, that this is the whole paper of Forestier, but the update showed that it's not so effective as in the past.
Definitely. So there is a role of bioselection when it comes to induction chemotherapy. It will help us bioselect patients who would anyway require us, because for somebody who is chemo resistant will more often than not be radio resistant and eventually will require a surgery because there will be some residual disease left. So for a bioselection standpoint, it is a good way to go forward. Thank you.
Yeah, I think one more thing we should realize, many of these trials were done in the era where evaluation of the larynx function before the treatment was not done actively. So a lot of the times the organ preservation may have been offered to patients who are already having some sort of underlying laryngeal dysfunction. Now, and of course treatment also has changed with radiotherapy, better laryngeal the better treatment of IMRT, improving the doses which can be given to the DARs has improved the outcomes. But we can't forget the SEER database of Hoffman's, which shows that compared to all the other cancers, laryngeal cancers are showing poorer survival, at least for the advanced cancers. And that is because of, I think, unselected use of chemoradiation. So that, I think, is a very important thing that we should pay attention, that you've put up very appropriate criteria, that the patient should have good functional larynx if you want to preserve the function. That should be assessed well.
Thank you so much.
Thank you for the talk, ma'am. Yeah, thank you for the talk, ma'am. Now our next topic is current indications of open partial laryngectomy by Dr. Mohsin Sheikh. He is a consultant here at Head and Neck Surgical Oncology Unit at HNCI and has previously worked as an assistant professor in the Department of ENT, Government Medical College. He was previously a consultant at Prince Ali Khan Hospital as well.
Good afternoon all. My topic for the day is current indications of open partial laryngectomy. So, starting with the history of laryngeal cancer surgery. The first partial laryngectomy was a midline thyroidectomy to remove a laryngeal piece in 1788. The first partial laryngectomy performed for a laryngeal cancer was reported in 1863 by Henry B. Sands. It consisted of a laryngofissure and extirpation of the laryngeal tumor. The first open hemilaryngectomy was carried out in 1878 by Theodor Billroth, a few years later after the first total laryngectomy, that was in 1873. Vertical partial laryngectomy. Many vertical partial surgery techniques appeared in the first part of the 20th century and were popularized by Chevalier Jackson and St. Clair Thompson. Three types of partial laryngectomy developed over time. The first type consisted of thyrotomy with unilateral or bilateral chordectomy. The second type comprised of vertical partial laryngectomy, frontolateral, with removal of the part of thyroid cartilage without cricoid cartilage resection. The third type was a hemilaryngectomy, which initially described by Billroth. It consisted of median thyrotomy, removal of the hemithyroid and hemicricoid. Now, with the beginning of the 20th century, in the second part of the 20th century, included the development of horizontal partial laryngectomy, such as supraglottic laryngectomy, glottic partial horizontal surgery, and partial horizontal surgery for both glottic and supraglottic region. The vertical partial laryngectomy, they were physiologically more sound. However, the horizontal partial laryngectomy are oncologically more sound. Justo M. Alonso developed a voice-sparing supraglottic laryngectomy in 1947. In the past 30 years, there has been a major transformation in the way we treat laryngeal squamous cell carcinoma, including the decline in the use of open surgery. First of all, it is because of the decrease in laryngeal squamous cell carcinoma in advanced countries because of the decrease in tobacco consumption. Secondly, because of the advances in chemotherapy and radiation therapy have led to high effective non-surgical regimens. Third, technical advances just like operating microscopes, endoscopes, lasers, and most recently robotics are transforming our surgical approaches. What is the aim of vertical partial laryngectomy? The partial laryngectomy. The aim is the same, to achieve a local control along with oral swallowing, phonation, and breathing without a tracheostomy. The principle of partial laryngectomy is to have a functioning cricoarytenoid unit with the intact nerve supply, which is around the cricoarytenoid joint, which is supplied by the descending branch of the superior laryngeal nerve and one branch, ascending branch of the recurrent laryngeal nerve. European Laryngeal Society has classified open horizontal partial laryngectomy as supraglottic laryngectomies, supracricoid laryngectomies, supratracheal laryngectomies. With involvement of the arytenoids, it may be extended to involve the arytenoid, the base of tongue, the piriform and the cricoarytenoid unit. For type 2 and 3, for supracricoid and supratracheal laryngectomies, the suffix A means the suprahead epiglottis has been spared, while the suffix B means the suprahead epiglottis has been removed. This is the supraglottic laryngectomy depicted here. In the first picture, as you may see, the suprahead, the suprahead epiglottis has been spared. It is the type A, and in the second photo, you may see the suprahead epiglottis is included in the specimen. In type 3, it is supratracheal horizontal laryngectomies. They will not be a part of partial laryngectomy discussion because they are associated with a thyrotomy, tracheostomy, sorry. Supraglottic partial laryngectomy. It includes resection of false cord, epiglottis, pre-epiglottic space and upper part of the thyroid cartilage. Extended supraglottic partial laryngectomy, which is when the supraglottic partial laryngectomy is extended to remove the ipsilateral arytenoid, vallecula with adjacent base tongue and the piriform. Indications of supraglottic: tumors involving the infrahyde epiglottis. It has a high propensity for invasion of the pre-epiglottic space. For tumors of the infrahyde epiglottis, as there is a high intensity of spread to the pre-epiglottic space, which is a less vascular space, and there is hence a less chance of it being responsive to radiation. Early supraglottic cancers with mobile vocal cords and nodal disease in the N2 or N3. The large lymph nodes respond poorly to radiotherapy. Young patients, either RT is not preferred and transoral laser microsurgery is not feasible. Contraindications: in elderly people with poor pulmonary reserve, impaired cord mobility, minimal thyroid cartilage erosion, involvement of the apex of the piriform sinus, interarytenoid or postcricoid, and significant base of tongue involvement. Supracricoid partial laryngectomy. Now, supracricoid partial laryngectomy is of two types. Sparing the suprahead epiglottis, where it would be a cricohyoidoepiglottopexy, and including the suprahead epiglottis, where it would be cricohyoidopexy. Resection. In supracricoid partial laryngectomy, the resection includes the thyroid cartilage with both the paraglottic spaces, and it may be an infrahead epiglottis or the total epiglottis. For reconstruction in glottic tumors where only part of the epiglottis is resected, supracricoid partial laryngectomy with cricohyoidoepiglottopexy. For supraglottic tumors where the epiglottis is completely resected, supracricoid partial laryngectomy with cricohyoidopexy. Supracricoid partial laryngectomy with cricohyoidoepiglottopexy. Indications: T1B glottic cancer, where more than half of the vocal cords are involved, but both the cords are mobile. T2A, where the disease extends up in the ventricle or to the petiole of the epiglottis. However, both the cords are mobile, or with impaired cord mobility, or T3 cord glottic lesion with mobile arytenoids, with fixed cord but with mobile arytenoids. Contraindications: poor pulmonary reserve, subglottic spread anteriorly for a distance of more than 10 millimeter and posteriorly for a distance of 5 millimeter. Fixed hemilarynx. Fixed hemilarynx means involvement of the arytenoid unit. Significant pre-epiglottic space involvement and a prior tracheostomy. Supracricoid partial laryngectomy with cricohyoidopexy. It is indicated in supraglottic tumors with spread to the anterior commissure or across the ventricle to the true cord, impaired cord mobility or fixity with mobile arytenoids, and with early thyroid cartilage erosion. Contraindications: fixed hemilarynx, involvement of the base tongue, vallecula, involvement of the piriform sinus, involvement of the postcricoid or interarytenoid, a prior tracheostomy. Why a prior tracheostomy is a contraindication? A prior tracheostomy because whenever we perform a supracricoid, the the trachea has to be mobilized, cervicothoracic unit has to be mobilized upwards. When there is a prior tracheostomy, this mobilization becomes difficult and a poor pulmonary reserve. Now, these were the indications for each of them. Now, what does literature say? Recent literature. Open conservation partial laryngectomy for laryngeal cancer, a systemic review of English language literature, which the main outcome being measured was local control at 24 months. A total of 53 articles which showed local control rate at 24 months of from 5,061 patients was 90%, pooled overall survival was 80%, and pooled mean disease-free survival was 85%. Open partial laryngectomy is a good option in selected primary laryngeal cancers. Benefits and drawbacks of open partial horizontal laryngectomies. Early to intermediate grade in stage glottic carcinoma, in which clinical outcomes of 216 patients who underwent open partial laryngectomy for clinically T2 were studied. Although TLM for clinically T2 laryngeal cancer with unimpaired vocal cord mobility remains a sound option, TLM for clinically T2 with unimpaired cord mobility. Open partial laryngectomy offers higher control rate and laryngeal preservation rate for selected patients with impaired cord mobility compared with involvement of the paraglottic space. Supraglottic partial laryngectomy, now third paper, supraglottic partial laryngectomy in the management of T3 laryngeal cancers. In this paper, oncological results only in T3 glottic and supraglottic cancers were studied in 32 patients who underwent supracricoid partial laryngectomy with a cricohyoidopexy or a cricohyoidopexy. At 1, 3, and 5 years, the disease survivals were 97%, 90%, and 78%. Overall survival is also in the same range, and local control rates were also good. Aspiration pneumonia was the most common complication. The conclusion of this study was supracricoid partial laryngectomy for selected glottic and supraglottic T3 tumors has excellent oncological and functional results. Now, next paper, the conservative treatment of advanced T3, T4 laryngeal cancer, meta-analysis of key oncological outcomes. The purpose of this systemic review was to evaluate the oncological outcomes of both transoral laser and open partial laryngectomy. It included 21 articles which suggested the disease-free survival was 79, overall survival was 71% at 5 years in all 1921 patients studied. The two surgical techniques are both valid surgical options for advanced laryngeal cancers, both the transoral laser as well as open partial surgeries. Next paper, the treatment of T3 to T4 laryngeal cancer by open partial horizontal laryngectomies. Prognostic impact of different pathological tumor subcategories. Now, 489 patients undergoing open partial horizontal laryngectomies type 2 and type 3 were classified retrospectively into subcategory 1 with anterior pathologically T3 with normal arytenoid mobility, subcategory T2, subcategory 2 posterior pathologically T3, subcategory 3 anterior pathologically T4, and subcategory 4 posterior pathological T4. 5-year overall survival, disease-free survival, disease-specific survival, locoregional local control, and laryngectomy-free survival were significantly better in the anterior tumors. Anterior tumors mean tumors which involve the paraglottic space, but they are lying anterior to the vocal process of arytenoid in the horizontal plane and perpendicular to the ipsilateral thyroid lamina in the vertical plane. Anterior clinical T3 tumors are manageable by open partial horizontal laryngectomies, and this approach can also be proposed in the treatment of early anterior T4A tumors. Despite promising results, open partial horizontal laryngectomies should be considered under investigations in posterior clinical T3 tumors due to clinical and biological behavior similar to clinically T4A tumors. Current status of partial laryngeal surgery for advanced laryngeal cancer. There are 4 studies by Gong, Mezzolela, Gaigot, and Saturno. They all suggest that open partial horizontal laryngectomy is a reliable oncological and functional outcomes, both for early glottic, for advanced laryngeal carcinoma, as well as for those who have failed on radiation and chemotherapy. To conclude, early laryngeal cancers, TLM for young patients, history of radiotherapy in the headache neck region, non-squamous open partial laryngectomy is to be given only in case of young patients, history of radiotherapy in the head and neck, non-squamous cancers like salivary neoplasm or neuroendocrine tumors, and in case of moderately advanced tumors when T2B glottic cancer with impaired cord mobility, T2B glottic supraglottic cancer with cord fixity but with mobile arytenoids. Early cancers should be treated with a single modality treatment. Irrespective of all this, major shift has been in the organ preservation to concurrent chemoradiation in case of advanced tumors, and in early to transoral laser microsurgery.
Very much like your last slide, and you have shown some very good results which come with partial laryngectomy, which have been reported even in advanced T3 tumors and some T4 tumors with thyroid cartilage invasion. So the issue that comes up is that in patients who have stage 3 tumors or T3 tumors with mobile cords, because nowadays radiologically paraglottic space involvement, preepiglottic space involvement is T3, should you be doing chemoradiation or should you be doing partial laryngectomy organ preservation?
Sir, for organ preservation, sir, first choice will be chemoradiation.
I was going to flip the question to you, Dr. Thakkar. What is your indications for open partial laryngectomy nowadays at your institute?
So primary situations, certainly T1s would go for laser and T2s would go towards partial laryngectomy or only radiation. And the advanced T2s with impaired vocal fold mobility, or the patients with which are classified as T3 today in terms of radiological paraglottic space involvement or preepiglottic space involvement. Or rather, let me say the advanced T2s would probably go for the partial laryngectomies. We would certainly explore that option very strongly. Everything is a final tumor board decision in conjunction with the patient, with so many other factors coming in, age, functional status, systemic status. But ultimately, open partial laryngectomy is a very attractive option for patients with intermediate grade tumors and mobile cords and mobile arytenoids. Yes.
So in our hospital, generally most of these patients would go for chemoradiation. A select few cases where we have offered them open partial laryngectomies in the per primum setting are for those selected anterior commissure disease which has eroded the cartilage, where we know that the chemoradiation may not be as effective. And of course, non-squamous malignancies like adenoid cystic mucoepidermoid, we've had a couple of those. But most of our partial laryngectomies are now reserved in the salvage setting in patients who've finished chemoradiation or only radiation and are still amenable for a partial laryngectomy.
What is your opinion, sir? Because after a chemo radiation, it's very difficult to do a partial laryngectomy. So, I mean, if you have to, if you take these patients for chemo radiation and they don't cross the barrier, then you have to only offer a total. At least that's my thought.
No, I think that for me also, T1 is, most of the cases will be a transoral laser. T2, I used to do a lot of partial laryngectomies. Nowadays, it's more in favor of radiation, but most of the times the radiation gets combined with chemo. So I do agree with you, Alok, that there is a role to re-look now. One of the papers that he showed, more than 5,000 cases reviewed, and have shown that partial laryngectomies, which partial laryngectomies there were, I do not know. But I'm not very hot on supracricoid partial laryngectomy like I used to be in the 90s. Because really the post-op course is very stormy, one, and number two, the voice quality is not good. And in those days we used to say if he's a professional voice user, then avoid those. But if he's not, everybody works today. Everybody is a professional voice user. In a young man, you do surgery, you don't give them radiation, you let them go for surgery. But you do surgery, supracricoid partial laryngectomy, and you have such a harsh voice. How is he going to get back to work? You know, so the pendulum is shifting more towards chemoradiation, even though they are T2, T3. It's shifting more towards, but I think we are in a transition phase here. Tapan.
I think Tasnim presented so elegantly. There's very
well.
little left to be done, said beyond that. What we know that more questions than answers in head and neck cancer were the role of chemotherapy. There is a role, but very limited role. Long way to go from systemic therapy point of view. Bioradiotherapy, probably time to forget. I think EGFR blockers, especially cetuximab, has proven to be under huge criticism now. Whosoever, young or old or anyone, probably I think the drug is not very effective. So all the biomarkers that we have now in tobacco-related cancers or alcohol-related cancers, probably the molecular landscape is so complicated. Present-day drugs that we have at this moment, we have to go far beyond it. And immunology of squamous cell carcinomas, we know, so different from anything else, probably. Epigenetics probably plays a very important role because as we get older, epigenetic comes in. And there's very little data in that. And new thought process, new biomarkers, new way to treat. At the moment of clinically, I think clinical decision, a proliferative lesion will respond very well. That's what happens in 1/3 of cases. Fibrotic, stenotic lesions. We really don't know, but the drug is delivered there, and the response is very difficult to evaluate clinically or radiologically. Thank you.
George, your views?
I mean, in Italy and in France, we push a lot for conservative surgery. General speaking, because of course every patient might be discussed in the multidisciplinary group, the position is every time you can offer to the patient a conservative surgery, we go for surgery. And when the alternative is a total laryngectomy, we go with chemoradiation, general speaking. But of course, there are some details. To perform a supracricoid laryngectomy, you need a fit patient as for a chemoradiation. And of course, the nodal burden must be limited because if you perform a supracricoid laryngectomy in N2 or in 3 patients, you are obliged to perform a chemoradiation after. So the goal is that a unimodal approach. So The indications are T2B, T3, without fixation of the arytenoid, because the type 3 supracrical laryngectomy, supratracheal, is very extreme. So I don't suggest to perform routinely, but just in selected cases, as N1, N0, and 1. Otherwise, we go for chemoradiation. But you have to take into account that somebody, the chemoradiation is limited to the very fit patient, and if you cannot offer the standard treatment, chemoradiation, and complete cycle, it's better go for the surgery. I mean, if you compare radiotherapy alone, I prefer supracricoid. But with limited burden on nodes, especially in supraglottic cancer, and a fit patient with good functional preoperative evaluation. But we push a little more surgery compared, because with type 1, the quality of voice is perfect, because you spare the glottic. If you perform supracricoid, if you can spare both arytenoid,
it's not bad.
The voice is not bad, because you can compensate. Of course, if you are talking about supratracheal or supracrite without epiglottis, with only one arytenoid, the functional outcome are not so good. But of course, you need a very good rehabilitation after the in the post-operative setting. This probably is the difference and the key of success. We started the rehabilitation immediately after the surgery. We will remove the cannula after 4 days. We remove the nasogastric tube after 10 days. We push a lot the rehabilitation after the surgery. This is important task to keep in mind. Also the rehabilitation. You need a dedicated speech pathology and
I'm very happy to have the two of you as experts here. I was feeling very bad. 3 books I have written and they've all got outdated in my time, this partial laryngectomy. One of the things that you have to remember, and I'm saying this for the younger people here, that if the nodal disease if the nodal volume is high, they will need postoperative radiotherapy. And most of the partial laryngectomies do not withstand post-op radiotherapy. Most of them will not tolerate. And if you have to radiate the neck, the radiotherapists have to learn to protect the larynx. Because they don't withstand radiation therapy.
That is not always easy.
Yes.
So the complication increase if
Yes.
you have post-operative.
Yes.
So this is important message. If you go for a supracrical, supraglottic laryngectomy, it's important to be sure that the resection is in free margins and the nodes are N0 and N1 to avoid any post-operative adjunctive therapy.
So would you
because these make the difference.
So you do send frozen sections in your supracricoid or supraglottic?
Yeah. In supracricoid, yes, the frozen section play an important
And
role.
what margins would you accept as okay?
The inferior, most of the time, or the posterior.
So in terms of 2 millimeter or 5 millimeter, what is the margin which you accept?
In open, more than 2-3 millimeters. So the weakness point is toward the arytenoid, the paraglottic space, and the inferior margin to the cricoid. The big mistake, the bigger mistake is to perform supracricoid and to have the histology with positive margin extra capsular spread. This is disaster because you perform supracricoid, then chemoradiation after. So this makes sense. For this is important to discuss before the treatment, because if I know in advance that the patient will be candidate to chemoradiation, I start with chemoradiation up front. Of course, with a big nodes, I go for chemoradiation.
Thank you, sir. Very good points.
Some scope to shift back to surgery?
So I always want to shift back to surgery. But yes, it is something we have to discuss with the patients also. A lot of times if you explain to patients, in India again, a lot of patients are very hesitant for, when you give them an option that we will do chemoradiation versus surgery, most of the times they'll say, okay, let's do chemoradiation. So if you explain to them that the control rates will be similar, but you may have a tracheostomy, even though it's temporary, a lot of them will say, no, let's go for chemoradiation, we'll see what to do later. So it's difficult sometimes.
Yes, but the problem that is that the salvage surgery after chemoradiation is not so easy.
Yes.
You need a flap, you need a lot of things. So you have to discuss before.
Yes.
Thank you, Mohsen, for that elegant talk. I think we will move on. We are having a short of time right now, but I would request Professor Giorgio Peretti to show us the horizontal partial laryngectomy before we go to the last talk of the day.
This is just a demonstration of cadaver, the different steps of the surgical technique. So I don't talk about the indication and the limits, but just to show how to perform the surgery. So my next lecture will be the boundary between the TRM and open function. And of course, we take always in account also no surgery protocol, but with this idea to perform always a unimodal treatment. Otherwise, it doesn't make sense to perform a conservative surgery and the radiotherapy on the chemoradiation. Okay. You change? Yeah? Okay. Okay. So the classification was already mentioned. I know why this make is not. But this is in a presentation. Yeah, okay, thank you. So the different type of supraclavicular laryngectomy. So the first step is the transection of the strap muscle. Usually I try to spare the superior part of the strap muscle to avoid any osteonecrosis of the hyoid, to spare the vascular supply of the hyoid. This make easier the PESI. So you pass through the strap muscle and you cut with electrocautery of the forceps. Okay, this is easy step. Then the second step is the transection of the constrictor muscle. So you start from the superior corner and you transect of the free margin of the thyroid cartilage, reaching the inferior cornu. okay? And you free completely the piriform sinus. So it's very important to visualize the superior pedicle for sparing the laryngeal nerve, because the laryngeal nerve give the sensibility of the remaining larynx. So if you damage the nerve, you lose the sensibility, and this is a big problem in the rehabilitation. So the pedicle passes behind the superior corner, so you have to visualize, you have to ligate the artery and the vein, but you have to spare the nerve. Okay, if you look at the pedicle, you can recognize also the nerve, okay? And you have the branch of the nerve that go to cricothyroid muscle. So the landmark is the superior corner of the cartilage. And of course the pedicle that run, you see here, they run behind the corner. So before cutting the corner, you have to visualize the nerve. Here you see, okay. So you have to spare, of course, the inferior laryngeal nerve, the recurrent nerve, because as already mentioned by the previous speaker, the cricoarytenoid joint is essential for the function. So if you damage the inferior recurrent nerve, you block the arytenoid, and you cannot have the compensation of the cricoarytenoid joint. So how to preserve the nerve? You have two ways. You can disarticulate the cornum from the cricoid, or, as I prefer, this is the disarticulation of the. But this is a risky maneuver, because the recurrent nerve run behind the inferior nerve. So it go from the trachea here and go inside the larynx behind the corner. So if this is the joint, if disarticulate in this way, you take a risk to damage the nerve. So personally, I prefer to cut the inferior corner to avoid any traction or any damage to the recurrent nerve. So these two steps are very important, to recognize the superior laryngeal nerve and the inferior laryngeal nerve, okay? Because otherwise the rehabilitation becomes a big problem. So the key points are these: not to injury the trunk, the superior and recurrent nerve. I suggest to transect the inferior corner to avoid any risk. And of course, you have the key of the success is to spare the cricoarytenoid joint. So the approach to the different type of OPHL is more or less the same. If you perform a type 1, of course you have to include the pre-epiglottic space in your resection. So you have to denudate the membrane until the hyoid bone, and you have to include in the specimen all the epiglottic space, like in this way. You see the effect of the pre-epiglottic space. I denudate completely the membrane. Here I isolated, I open the mucosa, keeping the epiglottics. So the surgeon stay behind the patient, and you see the larynx in this way. Here you have, of course, a different approach. If you go for type 1, you have to cut the thyroid cartilage in where the anterior commissure is about in the middle between the petiolum and the inferior border, so the anterior commissure here, and you have to cut the thyroid cartilage at this level, sparing the vocal plane, as this. You see, you mark, and the anterior commissure is in the middle, so your plane of resection is here, sparing the inferior part of the thyroid and, of course, the glottic plane. So again, in type A, you spare the supraioid epiglottis. In type B, you remove all the epiglottis and the epiglottis space. So in this case, you go inside the larynx again. This is the epiglottis. And when you open the larynx, you see the vocal cord, the false vocal cord. You crush the thyroid just to have a good exposure. This is the cricoid. So in this way you can control very well the extension of the lesion. So if you perform type 1, you put your scissor in the ventricle, sparing the vocal cord and removing the supraglottic part. Okay? This is very important, the orientation of your scissor. And your plane of dissection is the ventricle. If you perform, as in this case, a supracricoid, you cut the vocal cord in front of the vocal process. This is the final specimen after supracricoid type 2, sparing both the arachnoid. So this is the inferior limit where I perform frozen section most of the time. And in this case, I spare both arachnoid. And this is the specimen. If I have to perform type 3, I have to cut between the thyroid and the cricoid because I have to remove half of the plate of the cricoid and half of the arch of the cricoid, sparing only one cricoarachnoid joint. So this step is as a total laryngectomy, sparing the mucosa of the piriform sinus. I cut the plate in the middle, sparing just one cricoarachnoid joint, removing all the arch and half of the plate. This is very extreme operation. You have to perform this operation only in very selected cases where at least one cricoarachnoid joint is mobile and the lesion don't extend to the posterior commissure. Then the PESI, this is again type 2 with 2 arachnoids. So the PESI is important to put this suture just to put the arachnoid in the physiological position, because when you cut the muscle, the arachnoid go a little backward. So with this suture, you put forward the arachnoid, and this improves a lot the functional outcome. If you have 2 arachnoids, the suture is in the same direction the vocal cord. If you spare only one arachnoid, the suture go a little in this way, just to close the gap in the better way. So these 2 stitches, in my opinion, are very important to improve the functional outcome. Not many people do this. I learned this from Olivier Lacourey in France. Okay, this, okay, you see already. This, sorry. This is when I spare only one arytenoid, so the suture going this way. Because I remove this, I prefer to have more closure. So again, the key point are always to try to close the posterior compartment of the larynx, putting the arytenoid a little forward. In type 1 and supraglottic, you go from the cricoid to the base of the tongue, okay, in this way. Usually I put only 3 sutures. In the type 2, I go submucosally in the epiglottis. Then I go through the pre-epiglottic space, the tongue on the base. Then I pass behind the hyoid bone. I prepare all the 3 stitches. More or less the distance between the stitches is less 8-9 millimeters. You have to keep the same distance where the hyoid bone is to be symmetrical. Then you close the gap, but you have to avoid any tension, as in cricotracheal resection. So the okay, this is again this is another suture to minimize the risk of diverticulum with the pharyngeal mucosa, to reduce the abundant mucosa. In type 3, you have to remove the cricoid, so the passage is between the trachea and the hyoid bone. So I suggest to put the suture at least 2-3 rings, including 2, because if you take the passage in between the 1 second rings, you have the risk to destroy the first ring. So it's better to put between the second and the third rings, or even you can make one here, one here, one here, just to reduce the tension. And this maneuver is very important. You have to release the trachea, as in cricotracheal resection, and you have to test the tension before closing the Pepsi, because if you have a tension, you have a risk of the efficiency of the Pepsi. This is very important. You have to make the Pepsi without tension. So in case you have to flex a little bit the head, and maybe also to keep the head in this position for a few days, putting some suture as in cricotracheal resection, especially after type 3 resection. In type 2 resection, or when you remove the arytenoid, of course you have to reconstruct the piriform sinus. So with the mucosa of the piriform sinus, you suture with the half of the plate, remaining plate, just to cover the denudate part. So in this case, the extreme operation, you have a trachea, you have just one cricoarytenoid joint, and with the piriform sinus, you make a suture between the half of the plate and the mucosa. These are small tricks that are very important for the functional point of view. I showed some results. This is after type 1 supra. Why it doesn't work? I don't know why it doesn't work. I showed the other. I saw if the other works. Yeah, this is work. This is supracrical laryngectomy with 2 arytenoid and a suprahyoid epiglottis. So the function, the sphincteric action is perfect. The closure is complete. So this patient has any problem in swallowing because you have a very good closure. And this is after type 2B without any epiglottis, so remain only the 2 arytenoids. You see the vocal process here. The pes is here, base of the tongue. Again, the closure is perfect between the 2 arytenoid and the base of the tongue. And these make possible also a good voice because you have a contact between the arytenoid and the base of the tongue. And this is after type 3, where I remove half of the plate, 1 cricoarytenoid joint, remain just 1 cricoarytenoid unit and epiglottis. This is very extreme operation because the indication is the fixation of 1 arytenoid for posterior paraglottic invasion. In this case, honestly, I suggest chemoradiation or total laryngectomy if the patient is not fit for chemoradiation. But if not fit for chemoradiation, is not fit for this kind of surgery. Usually, the indication of chemoradiation and extreme partial laryngectomy are the same. If one patient is fit for one, it's fit also for the other one. Okay, thank you for that. So I have to use this one.
One of the points that I would like to highlight in a supracricoid partial laryngectomy is that if you are doing it for a lesion that is predominantly on one side, even then, don't get tempted to preserve the opposite side cord. The entire anterior larynx has to go right from the arytenoid process, vocal process of the arytenoid. Everything anterior should go. There's a temptation to save the opposite side cord if it is normal and supple. It has to go, otherwise the aspiration will be very high.
Yes, but the concept of supracrical laryngectomy is that for reconstruction reason, you have to be symmetrical. Even if the disease is localized on one side, you have to remove even the other side, otherwise the PESI doesn't work in the right way. It's not the concept of vertical, but of the horizontal. So you respect the plane, supraglottic, supracrical, and supratracheal. And in this case, you remove both sides because it's make easier to make the PESI and the functional point of view is better. The difference is to spare 1 cricoarytenoid joint or 2 cricoarytenoid joint. With 2 arytenoid and even suprahyoid epiglottis, we have very good results. So if you want to compare, generally speaking, the functional result, if I have a patient that where the laser is not feasible because there is a bad exposure, a young patient, I propose supracrical with 2 arytenoid and suprahyoid epiglottis. He can discharge in 7 days without any problem in speaking and swallowing. And of course, more is the advanced resection, more is the problem for the rehabilitation.
Thank you for the video, sir. Now we have our last talk of the day coming up by Dr. Aditya Vora, sir. He's an MCH plastic surgeon and a consultant here at HNCIR. He has done his HPNI fellowship in microvascular reconstruction and in Tata Memorial Hospital, special interests in plastic and reconstructive surgery, and specializes in head and neck onco reconstruction. And he has presented several papers in national and international conferences.
Thank you for the introduction. Good evening, everyone. Okay, my topic is on reconstructive options in laryngeal conservation. So the larynx acts as a valve conduit between the oropharynx and the trachea. It is divided into three parts: the supraglottis, glottis, and the subglottis. With the supraglottis extending from the tip of the epiglottis to the lower edge of the false vocal cords, the glottis comprising of the vocal cords and the mucosal surface 5 millimeters below the free edge of the cords, and subglottis which extends from the glottis to the lower edge of the cricoid cartilage. Now, open laryngeal surgeries can be divided into partial laryngectomy surgeries and total laryngectomies. For total laryngectomy, generally the patient in most of the patients end up with having an end tracheostoma with a pharyngeal defect that is either closed primarily or with a patch defect or with a tubed flap. And then there are the partial laryngectomy surgeries, which can again be divided into vertical laryngectomies and horizontal laryngectomies. So there will be two clinical scenarios when the patient will come, either primarily before taking either any adjuvant, a new adjuvant chemotherapy or radiation, that is and for an open primary surgery, or the patient would have had a failed radiotherapy or would have had a recurrent or a residual disease. Now, in these two scenarios, the reconstruction options that we can offer to the patient for patients who come primarily, they are managed generally by advancement of adjacent laryngeal structures, that is mucosal advancement flaps or local transposition flaps from nearby strap muscles or other neck muscles. Or in the case of a post-radiation scenario where the indications are very specific and where local options are exhausted because the vascularity is not good, we may have to go ahead with a free tissue transfer. So the goals of reconstructions are mainly restoring airway patency, prevention of aspiration, preservation of phonatory capacity, and preservation of infection or scarring by providing mucosally covered intraluminal surface. So there are many locoregional flaps which have been described depending on where exactly the defect is, and they are generally used for per primum cases where patient has not received radiation. So some of them are the sternohyoid flap, the bilateral omohyoid flap, a contralateral laryngoplasty, or an imbrication laryngoplasty. And as far as free flaps are concerned, they are mainly done in cases of post-radiation and for vertical laryngectomies. And free radial artery forearm flap and temporoparietal flaps are generally used because we need a very thin flap for laryngeal defects. So when it comes to partial laryngectomy, for vertical procedures, they can be either a standard or an extended frontolateral hemilaryngectomy, or a vertical laryngectomy but extending into the cricoid, where half of the cricoid also has been resected. So formally, if the cricoid, because cricoid is the only ring structure in the trachea, and if it has been resected, one has to reconstruct it. Otherwise, we'll have to go for a total laryngectomy because the airway needs to be patent. So for such a defect where the cricoid is involved, some reconstruction is required. So mainly the principles for reconstruction are some mucosal lining or an epithelial lining is required for the luminal part. Some volume is required for apposition. Arytenoids, if at all are resected, they need to be recreated to prevent trough from the pharynx to the glottis. It is not essential to recreate the thyroid ala. When it comes to horizontal procedures, in the last two speakers already mentioned the types of horizontal procedures which are there. The reconstruction for such procedures is either a cricoid hyoidopexy or a tracheohyoidopexy, mainly fusing the bony and the cartilaginous segments of the larynx. Now the free radial artery forearm flap, the advantage is that the skin is thin, has a robust blood supply. Chantran was the first to use the radial artery forearm flap for laryngeal reconstruction, and he used the tendon of the palmaris longus to recreate the vocal cord. Urken was the first person to use a radial artery forearm flap, but for a vertical hemilaryngectomy defect having a hemicricoid defect as well. And he achieved the cricoid reconstruction using the costochondral graft by inserting it into the subdermal tissues of the flap. Then there is a temporoparietal free flap. Mainly the blood supply of this flap is from the superficial temporal vessels, the artery and the vein. The advantage again of this flap is that it is thin, it is pliable, it gives just the adequate volume for a hemilaryngeal defect, it has a long pedicle, and there is a minimum donocyte morbidity. The disadvantage is that the vessel size is small and the venous anatomy is not consistent. So here we see the yellow part that is there is the temporoparietal free flap. It wraps the cartilage in it. Either the costal cartilage can be used or the thyroid ala can be used in such a case. And there is a buccal mucosa graft which drapes the luminal surface of the larynx. So here we see the defect in the larynx, and it is covered by this temporoparietal free flap. There is a mucosal graft on the inner surface, and the cartilage has been wrapped all around the flap. This is again, here we can see over here that the buccal mucosa graft has been sutured first to the flap and is then sutured within the lumen. And on the right we can see the costochondral graft which is there. Then came in the concept of vascularized carrier. Delaire was the first person to give the concept of a vascularized carrier. These procedures are mainly for defects involving the cricoid cartilage, where half of the cricoid has been resected. So in his original concept, it was a two-stage procedure. In the first stage, he did a neck dissection and wrapped the proximal part of the trachea with a forearm fascia flap. And 2 weeks later, he did the primary surgery, that is a hemicricoid hemilaryngectomy, and he advanced the part of the trachea that was wrapped with it. Normally the trachea would not have been vascularized enough, but with a prefabrication technique, the trachea is now vascularized and then it is taken up. He himself modified this technique, though it's still a two-stage technique, but now the primary surgery and the neck dissection, both are done at the primary setting in the first stage. So here we can see that a radial forearm flap is done. It's not only a facial flap, but here we can see that a small skin paddle also has been harvested along with it. The skin paddle covers the defect of the larynx here, and the facial part which is harvested from lower down the forearm, it wraps the proximal trachea. Approximately around 4 centimeters of trachea is wrapped, because that is the maximum resection of the trachea that can be done with a primary anastomosis. So here we can see in the stage 1 itself, here we can see that the skin part of the radial forearm is covering the laryngeal defect temporarily, and the facial part of the radial forearm is wrapping the proximal part of the trachea. And here in this we can see that the lower end of the skin flap is generally outside for monitoring. So this is the stage 2. In stage 2, which is generally 4 months apart, 3 to 4 months apart, is generally done like that in the modified technique, so that it becomes like a second look procedure. In the second look procedure, we can be very sure from the oncological point of view as well as the trachea is very well vascularized by that time. And now we can see, we can excise this part of the skin flap now in the second stage procedure and advance the trachea from over here into the defect. And a primary cricotracheal anastomosis can be done. So this is possible now with the Pierre Delaire or the tracheal autotransplantation technique. Thank you.
So in the second procedure, when you went back in, do you have to safeguard your pedicle, or it's okay if you...
Yes. So what we do here... So that is, in the first stage itself, if we see here, the orange colored, the red colored part of it, this is the facial part of the forearm flap. It is wrapped with a PTFE membrane. This is an expanded PTFE membrane, so that only the part that is adhered to the trachea gets attached to it. It does not get attached to any surrounding tissue. So we wrap it with that, and during the second stage procedure, that fascia, the PTFE fascia, is first removed. So that part is not attached to any surrounding part, but this part has been completely adhered to the trachea, and the trachea is revascularized, and then it is taken out. That is.
Any other questions in the audience? Thank you, Aditya, for that excellent talk. And I think we will break for tea now. And I think we are running about half an hour behind schedule. So try and come up at least by 6. Thank you very much.
अभी ऑफ करो. ladies and gentlemen, esteemed guests and dear colleagues, good evening and a very warm welcome to the first anniversary celebration of the Head and Neck Cancer Institute of India, affectionately known as HNCII. I'm Pearl Dias, your anchor for this evening. We are gathered here to commemorate the successful completion of a year's dedicated service, tireless efforts, and significant achievements at the Institute. HNCII is the realization of Dr. Sultan Pradhan's vision to establish an institute solely dedicated to addressing India's most significant cancers, burdens that affect our population, both men and women. Through philanthropy, the former chief of surgical oncology at the Tata Memorial Hospital founded the CanCare Trust at this institute. His unwavering dedication and contribution to the field of surgical oncology is unparalleled. Today, we stand proud of our 100-bed facility, equipped with the state-of-the-art amenities, providing comprehensive care with surgery, radiation, medical oncology, and modern diagnostic services. The theme for today's academic program is Decision-Making in Laryngeal Cancer, Real-World Issues from Conservation to Salvage, reflecting our commitment to advancing knowledge and treatment strategies in this critical area. As we mark this milestone, let us remember the relentless dedication of our healthcare professionals and the unwavering support of our patrons. We are honored to have in our midst two renowned head and neck cancer surgeons who have contributed significantly in the treatment of laryngeal cancer. Thank you for being with us. Without further ado, let's begin the celebration with the traditional lighting of the lamp. May I now invite both our chief guests, Professor Giorgio Peretti and Professor Alok Thakkar, our chairman, Dr. Sultan Pradhan, our trustees, Dr. Roshan Chenoy, Dr. Meher Ilavia, and our director, Dr. Prathamesh Pai. Thank you. May this light guide us all towards wisdom and understanding. May I request you all to be seated? May I request our chairman, Dr. Sultan Pradhan, to say a few words.
Nothing more to say than what I said earlier in the day. But Thank you very much to all of you for being here. This participation means a lot to me, as I mentioned to you, that this institute without academics will be just one more of the kind. And your presence and your participation means a lot to us. It has been a good year. We've learned a lot of lessons here. If I may say a few words about the project, a lot of people have helped in the realization of this dream, including the government agencies. I have to tell you this one thing, that we have worked with the Bombay Municipal Corporation. In this entire project, there is not one penny of bribe that has been given to any government officer. And this I say because I think it is so good to know that people have so much goodness in their heart. We are so easy in criticizing people, and particularly our own people. But it is a matter of pride for us to see that our government officers, अरे बाबू वो सुल्तान प्रधान का हॉस्पिटल का क्या हो रहा है, कभी प्लान लाते हो, जल्दी ले आओ. They want to do it. They want to facilitate it. They don't want, they are just good people. And as I said earlier, that Dr. Ilave and I have been right from the start, and we were concerned whether we will get good people. And good people we got the best people. In Dr. Prathamesh Pai as the director, what we have. Can't have a better person than him to infuse that academics into this institution. And he's doing it extremely well, that part. He's doing very well. And this whole dream had started more than 25 years ago, when we started our outreach program to the public hospitals. It is at that time that it had started. And some of you saw on the first floor that whole tree that we built. And they are the ones that I'm extremely happy when I see all these faces here, Hitendra and all the people here. So it's a dream come true for me. Still a long way to go, a lot more to do, but it's happening. Thank you.
In the realm of appreciation, your speech, sir, is a crown of a jewel. Thank you for enriching our minds, uplifting our spirits, and leaving us with a profound sense of gratitude. May I call Dr. Prathamesh Pai to introduce our orator, please?
So now we will begin with the part that all of you are looking forward to, as I, the oration. For this, we thought about whom to invite, and we then honed on to Professor Giorgio Peretti, because no one better than him, who has spent more than 3 to 4 decades in the treatment and progress of laryngeal cancer in the world, if I may add. Professor Giorgio Peretti, he is the director of the ENT department, San Martino University Hospital and University of Genova. He was formerly professor at the University of Brescia from 1986 to 2011. He has written important clinical papers, which we all have read, and are highly cited. And these have transformed our clinical practices globally. An esteemed clinician, he has been invited as an orator and keynote speaker at the most prestigious meetings the world over, and has visited India several times. He was the past president and a scientific counselor to the European Laryngology Society, and we have seen the output that they have generated over the past 2 decades. His fields of clinical expertise include laryngology, phonosurgery, and the diagnosis and the treatment of benign and neoplastic tracheal diseases. He has been specially committed to developing and improving the carbon dioxide laser-based diagnosis and endoscopic treatment of laryngeal cancer. He has been playing a crucial role in the definition and testing of groundbreaking surgical tools and instruments aimed at novel phonosurgical techniques. I welcome Professor Giorgio Peretti to deliver his oration on the boundary between open and transoral surgery in intermediate stage laryngeal cancer. Welcome, Professor.
Thank you very much, Professor Ramesh, for the kind presentation and also invitation. I want to express my gratitude to Professor Pradhan because he realized really a unique project in the world, create a hospital dedicated to the head and neck cancer. It's very, I'm sure that you realize a dream that all us have in our heart, to have a hospital dedicated to our interest. In my lecture, in the next 30-40 minutes, I try to synthesize my experience, my career in laryngeal cancer, and it's a great pleasure to be invited by you because it's a great pleasure for me to come in your country very often to share my experience with you because you are very interested always to follow our my job. So I go in presentation. Okay. So my career started in okay.
May I call upon the chairpersons, Dr. Anil de Cruz, Director Oncology, Apollo Hospitals, former Director of Tata Memorial Hospital, former President, UICC, former Professor, and Chief Head and Neck Services, Tata Memorial Hospital. Dr. Jai Prakash Agarwal, Chief Department of Radiation Oncology, Tata Memorial Hospital.
I can say, okay. So my career started in 1983 with my residence program with Professor Bocca. Everybody knows Professor Bocca. He popularized the supraglottic laryngectomy and the neck dissection. Then I follow my career with the right arm of Professor Bocca. There was my main mentor, Professor Antonelli, and started my experience in the University of Brescia. During this period, I have the opportunity to spend several times in Boston, where I training in laser surgery with Professor Stanley Shapshay, that was the chief of the Boston School and the pioneer in laser surgery. Then, when I was in Brescia, I have the great opportunity to meet Professor Steiner, and he helped me to jump from early glottic cancer to more advanced cancer, and help it to overcome the indication, the initial indication. And finally, for 2011, I became chief in Genoa, where I'm still working with a young group of people. So when we talk about the conservative surgery, the key of success is an accurate diagnostic workup. So there are some essential requirements that we are strictly follow before planning your decision. And the bioendoscopy is for sure one things that we have routinely used in our practice. Bioendoscopy help us to evaluate the superficial boundary of the lesion, to recognize satellite foci, and recognize the atypical vascular pattern that are really correlated to the neoangiogenesis process. So you have some example of erythroplakia that with MBI become very characteristic with the limits of the lesion very, very well defined. And also you can recognize the atypical spot, the atypical vascular pattern inside. And another imaging in white light, MBI, where you can recognize the intrapapillary capillary loops inside the lesion and also in the surrounding area. So in our experience, we found that with the combination of bioendoscopy and high definition, we have increased the occurrences in our diagnostic setting. This is the experience of Isabel Villaseca that show how is the gain in terms of the diagnostic accuracy in the office with MBI, especially in larynx, where the gain is more than 20% in diagnostic accuracy compared to the white light. So some example of MBI, because it's very important to evaluate the MBI imaging not only in the office but intraoperative before starting every procedure. So this is essential requirement if you perform laser or even if you perform a conservative surgery, to evaluate with angle telescope, 0-70-degree telescope, the lesion, to evaluate the ventricle, and even to evaluate the boundary of the lesion. You can see with the MBI much better the vascular supply coming from the posterior part, and also you can recognize the atypical vascular pattern inside the lesion. With this atypical vascular pattern, you can avoid the biopsy because the probability to find the cancer is very, very high where you recognize this atypical pattern. About the margin, if you use MBI, of course, you can recognize also atypical vascular pattern in the floor of the ventricle, when with the white light it seems to be a normal mucosa. Another important thing in the preoperative evaluation and the imaging, because you have always to combine endoscopy with the imaging in preoperative setting, and MRI already underlined by the previous speaker is the best way to recognize, for instance, the infiltration of the cartilage, or even distinguish inflammation and edema from the tumor. So it's always important where you face with more advanced cancer, combine this three-dimensional information with the endoscopy. So by endoscopy for evaluate the superficial spreading, and imaging in terms of MRI to evaluate the deep invasion of the lesion of the infiltration of the laryngeal framework. Another important requirement is the exposure, especially for transoral laser microsurgery. This is a good exposure, this is very bad exposure, but it's important to keep in mind that when you have exposure like this, the rate of a positive margin is very, very high. This means that if you face in one case like this, it's better to shift to another therapeutic option, because the probability to perform an incomplete resection is very high. So for the young people, don't start when the exposure of the larynx is not adequate, is not good, because you can make a big mistake to treat the patient where you cannot see the anterior commissure. By contrast, this is the right position of the laryngoscope. You can see the false cord, you can see the vocal cord in a normal position, and you can evaluate very well with a 70-degree telescope the lateral extension. So the most important things before I treat the patient is the processing decision, is the making the process, the making process. So you have to keep in account different factors related to the tumor and related to the patient. Regarding the tumor, it's very important to evaluate the involvement anterior commissure, the impairment mobility of the vocal cord, the arytenoid, the integrity of the laryngeal framework, the integrity of the infiltration of the paraglottic space, and the nodal burden. By contrast, you have to take in account also patient factors is the age, the dyspnea when you make a flight of stairs, the performance status, the laryngoesophageal function, the mental status, the need of caregivers. All these factors must be taken into account before taking your decision. What we do now is already mentioned many decades ago by Dr. Birot, that make the difference between the anterior compartment and the posterior compartment, underline that this compartment, the weakness point of the larynx, and the fixation of the vocal cord increase the rate of failure of 40%. This in the last many decades again. Strong from Boston underline how it is important the microlaryngoscopy to well define the extension of the lesion, how it is important to perform a free margin resection and a complete resection to achieve very good results. So we have to take in account when we talk about the tumor to three compartments in the larynx: the anterior compartment, the lateral compartment, and the posterior compartment. The anterior compartment, the anterior commissure, is not just a point where the two vocal cords join each other, but is a 3D space that include the vocal cord, the false vocal cord, the periepiglottic space, the subglottis, and the anterior part or paraglottic space. Is an area, is the compartment, is not just a point. It's important to keep in mind that the involvement anterior commissure decreased the local control in 25% of the cases. This is related probably to the status of the margin, because it's more difficult to have a free margin resection in anterior commissure, because most of the time the exposure is not adequate. And a big difference is between younger surgeon and experienced surgeon. And there is a significant difference in terms of determinate disease survival between the two scenarios. So the method is you treat the anterior commissure lesion only if you have a good exposure, if you have a good experience. Otherwise, it's better to plan another option. This is the case of type 6 resection. I already showed in the beginning, so I don't show another time. But just to show how it is important to remove all the anterior compartment. When we talk about anterior commissure, it's very important to differentiate the lesion limited to the horizontal plane, not transgresses the bottom of the ventricle, the real T1, from lesion that involve in vertical direction the anterior commissure. If you look at the literature, there is a big difference between T1 limited to the glottic plane with a good local control organ preservation from T2 that cross the anterior commissure in a vertical direction. And you can see a decrease in terms of organ preservation local control when you face with T2 with vertical extension. So you have to keep in account that you face with a lesion spreading to the subglottis or spreading to the supraglottis, reaching the pre-epiglottis space. Your control is decreased dramatically. So you have to always differentiate where we are talking about anterior commissure between anterior commissure involvement in the horizontal plane, anterior commissure involvement in the vertical plane. If you look also the data from the radiotherapy, you see that if the anterior commissure is involved, the organ preservation, the local control is inferior compared to the patient where the anterior commissure is not involved. So you have to take into account always that anterior commissure is the door of diffusion of the tumor toward the pre-epiglottis space or the subglottis space or even the extralaryngeal tissue. Another critical point is the lateral compartment. And nowadays, CT scan, we can evaluate very precisely the depth of the invasion of the muscle. This is a recent paper. And we found that there is a significant correlation between the DOI, the depth of the invasion, and the staging of the tumor, the presence of nodal metastasis, the presence of perineural invasion or lymphovascular invasion. So nowadays, with the new technology, we can appreciate in preoperative set the entity of the invasion of the vocal muscle. This is important because if the tumor, the T tumor, is extending superficially to the supraglottid and to the subglottis with limited invasion in inferior 2 millimeters, the transoral laser microsurgery is very good indication, maybe the best indication. And you can make a superficial resection, an entire mucosectomy, denudated the arytenoid and removing all these suspicious area in the supraglottic part with very good results. By contrast, if you go if the lesion go deeper, invading the muscle toward the cartilage with a DOI superior higher than 2 millimeter. Of course, you can still perform a transoral laser microsurgery, but you need a good exposure and you need a very extended cordectomy. You see the cartilage plane, the thyroid cartilage here, and the cricoid here. You have to remove all the lateral compartment in these cases. You see that normally I use a kind of jet ventilation, and this Evona, very small catheter that allow us to have a very good exposure of the posterior part of the glottis. This allow you to extend your resection to the arytenoid and to the lateral part, to the medial wall of the arytenoid. Always to achieve a very good resection in free margin. So if you look at the literature, you see that there is a big difference between T2 with the normal vocal cord mobility and T2 with impairment vocal cord mobility. If you look at this review that include a patient treated by laser radiotherapy, the rate of success is comparable, but if you stratify this lesion in mobile impairment vocal cord mobility, you see a big significant difference. This means that the superficial T2 with normal vocal mobility have result outcome comparable to T1. By contrast, if you have a deep invasion with impairment of vocal cord mobility, the rate of success is more similar to T3 than T2. In my opinion, the whole differentiation in T2A and T2B was a really good point. Unfortunately, the new TNM don't stratify in this way. So probably the deep infiltration of the muscle represent the risk factor in this lesion. In fact, if you look again the literature, the result in T2B with impairment vocal mobility are comparable to the same result in T3. So this means that superficial T2 are comparable to T1, deep invasive T2 are comparable to T3. So two different kind of tumor in the same category. The T2 is very heterogeneous category that include superficial spreading and deep spreading. This must be keep in mind. So the last compartment is the more critical compartment, in my opinion, in the posterior compartment. This is the paraglottic space. You see that the paraglottic space, the anterior part is filled by the muscle. By contrast, in the posterior part, you can recognize the fatty tissue between the muscle and the cartilage. But the important thing is if you see the relationship between the paraglottic space, the hypopharynx, you see that we have no anatomical barrier in this part. You have just a mucosa separating the hypopharynx from the larynx. So this is the really weakness point for conservative surgery, because these represent the door or the escape of the tumor toward the piriform sinus. So from the didactic point of view, we divide the paraglottic space in two parts, divided by the virtual line going from the vocal process to the cartilage. This is the anterior part with less problem, better prognosis compared to tumor located in this part. These two compartments of the paraglottic space are the base of many papers right even for open partial laryngectomy, because we underline many times that when the tumor is located in this part, it's good indication even for laser surgery. When the tumor invaded this part is a contraindication for the laser, and even must be treated by OPHL only in selected cases. But the fixation of the arithroid due to the infiltration of the joint is represent also a contraindication for open partial laryngectomy. So again, we're talking about T3 for invasion of paraglottic space, but are two different diseases. This is not a bad diseases, this is very bad disease. So it's important to distinguish when we talk about fixation, distinguish T3 for fixation of the vocal cord, but arytenoid is still mobile. This is due probably to the invasion of the anterior paraglottic space, to lesion that invade the posterior paraglottic space with fixation of the arytenoid. So for the young people, it's important when you classify a lesion as T3, remark if the fixation is only for the vocal cord, or in these cases, you see there is a fixation of arytenoid, hemilarynx. So both are T3, but different diseases. These are feasible, and for conservative surgery, these represent a contraindication for conservative surgery. So keep in mind the differentiation in the T3 category between fixed vocal cord and fixed arytenoid. So when you treat endoscopically T3, the problem is that even if you dissect completely the posterior compartment, as in this case, you denudate all the thyroid cartilage, the cricoid target, and the lateral cricoarytenoid muscle and the cricothyroid muscle, you cannot control the diffusion outside the larynx. You can dissect completely the posterior compartment, removing part of the arytenoid, denudate the cartilage, but you cannot control the diffusion, extralaryngeal diffusion. This is the reason, because when you have involvement of the posterior paraglottic space without fixation, the OPHL become the treatment of choice, because you can control the way of diffusion, removing all the cricoarytenoid joint and the intrinsic muscle. This is the big difference between transoral laser surgery and open partial laryngectomy. This is an example where I remove one arytenoid, I denudate part of the plate, I remove also the cricoarytenoid muscle and the cricothyroid muscle. So all the potential way of diffusion I remove with this type of surgery. You see here, we remove part the arytenoid, and of course you have to reconstruct the defect with the mucosa of piriform sinus, as in this case. So when you have invasion of paraglottic space, you go forward the OPHL for this reason, because endoscopically you cannot control the way of diffusion. And of course, you have to keep in mind that in 20% of cases, the lesion classified as CT3 are PT4 in the postoperative evaluation. so for extralaryngeal extension. So is the reason because if you have a fixation on arytenoid, probably OBCL is not enough, and you have to do things about a total laryngectomy or no surgical protocols. So there is an escalation from TLM indicated for anterior paraglottic space, OPCL for posterior paraglottic space, but without fixation. When you have a fixation of the vocal cord, probably the total laryngectomy or chemoradiation is the best option. And last but not least, the N status. I already anticipated before how it impact in your decision-making process. You have to keep in account also that when you have one positive lymph node, the risk of death for disease increase 14% and increase until 42% when you have 3 positive node. If you adapt the node burden, you have a much better stratification compared to the normal PN stage. So it's very important to evaluate the number of node involved and to keep in mind that when increase the number of node involvement, decrease dramatically the control of the diseases. And also, this is important for the radiologist, that in 25% of CN1, after the dissection, you found PN+. So this is another issue to take into account in your planning. So, of course, when you have N1, only one lymph node is involved, the conservative surgery probably with adjunctive radiotherapy is still a good indication because the radiotherapy with after chemo, after OPCL minimally interact with the function. But of course, if you have more than one lymph node positive, of course, the indication go forward the chemoradiation of the total laryngectomy plus chemoradiation. So in this situation, I prefer to propose chemoradiation up front because you are obliged in these cases to perform chemoradiation after operation. So the conservative surgery remain only in selected cases where only one lymph node or better no lymph node are involved by the diseases. So to validate this concept, recently this is unpublished data. We collect a series of more than 600 T2 and T3 patients treated by laser in 4 different centers: Genoa, Brescia, my series, European Institute of Oncology, and Hospital of Barcelona by Vilaseca. All these centers have the same policy of treatment, selection, and follow-up. So all are naive, no salvage treatment, all are T2 and T3, and treated with TORMS plus or not neck dissection. Where define 5 different subcategories because we think that according to our TNM, the T2 and T3 are category 2 heterogeneous. So we try to create some subcategories just to understand the right indication of the laser. The subcategory 3 include lesion extending superficially to the supraglottis or the subglottis in the lateral part. The 4 include lesion infiltrating the muscle, the lateral compartment, deep infiltration of the muscle with impairment of mobility. The 5 include lesion infiltrating the anterior paraglottic space, and the 6th category include lesion extended vertically in the anterior commissure. So no limited to the horizontal plane, T1B, but T2 for vertical extension in the anterior commissure. So we had a new category, that the P3 infiltrated posterior paraglottic space, that in my experience is the absolute contraindication. By Isabel Villaseca in the beginning, trust to the laser also in these cases. But if you see the cohort of patient number included in 2B is very low, is limited to the experience of Barcelona. But even Isabel now is confirmed that represent a contraindication. So if you look at the results in terms of disease-free survival, local control, laryngeal preservation, you can see that the superficial extension of T2 is very, very good indication, maybe the best indication from the laser. You can have a very good result even if you have impairment of the vocal cord, but making a very extended cordectomy, reaching the supracondylar plane. And if you have infiltration of the anterior paraglottic space, you can obtain good results, less than conservative surgery by open approach. By contrast, the worst results are obtained if the posterior paraglottic space is involved, even in case of transcommissural lesion. So this, in my opinion, not only in my opinion, but according to the result, are really the risky point, the weakness point of TLM. So good indication for superficial extension, good indication for deep extension with appropriate resection. Anterior paraglottic space in selected patient, for instance, elderly patient or fragile patient. Very selected patient in case of anterior commissure involvement, again in elderly patient or fragile patient where the other options are not feasible. Absolute contraindication in case of posterior paraglottic space involvement. And if you look at the multivariate analysis, you see that a category, the posterior paraglottic space and the transcommissural extension increase the risk of disease-specific survival 3 times and more or less more than 2 times for vertical extension. You see the stratification of the subcategory is again correct. And in terms of local control, the 2 categories remain the more risky category. In posterior paraglottic space, you increase 4 times the risk of recurrence and more than 3 times in case of anterior commissure. Again, another factor is the positive margin. And in terms of laryngeal preservation, the transcommissural lesion are the worst category. 3 times higher risk of lose your larynx. So also the multivariate analysis confirmed that the 2 category posterior paraglottic space and transcommissural are the worst, and you have selected very well the patient if you want to treat this kind of lesion. If you look at the salvage treatment for local recurrence, you see that in case of superficial extension, you can, in 50% of the cases, you can repeat a laser as a salvage surgery. By contrast, in the other category, In the other category, remained the laryngectomy the only way to salvage the treatment. In a case of deep invasion, you have still a possibility to perform an open partial laryngectomy in case of failure of the laser surgery. So these remain a good indication, and the other you have to select the patient. And this is a multi-state model just to see graphically the possibility of total laryngectomy and death of diseases. That is the minimum in superficial extension in subcategory 3, but progressively increase in case of deep invasion and in case of anterior paraglottic invasion, and in case of posterior paraglottic space, you see the risk of death of disease in the long term is increases a lot. Also the possibility of total laryngectomy. Even for the subcategory 6, in the long term, the risk of death of diseases at total laryngectomy is significantly increased. Just to underline the selection and the diagnostic overcap is very important. So to synthesize, to summary the indication, we can see that the laser surgery is a good tool to cure glottic T1 and supraglottic T1 and T2 with good exposure. This is essential. It's very good indication for superficial T2 and T3 lesion and 0 or N1 with good exposure. By contrast, the transcommissural lesion are laser indicated only if you have a good exposure in elderly or fragile patient. Otherwise, I suggest to treat in another ways. Otherwise, you have the possibility to 30% of recurrence. And the same things for if you have a bad exposure, of course, it's better to perform OPCL. The same things for the involved anterior paraglottic space is good indication in if you have a good exposure in a fragile patient is an option. By contrast, if you had a bad exposure, is much better to go to the open approach. And when you have fixation for invasion of posterior paraglottic space, of course, in absolute contraindication for laser, is a good indication for OPHL only in case of N1 or N0. By contrast, if the node burden is increasing, remain the total laryngectomy or chemoradiation. So this, I want to show you something that we are is our field of research at this moment, just to make objective the evaluation of endoscopy. So we are developing an algorithm with artificial intelligence to evaluate objectively the quality of the imaging, to classify the type of the lesion, to detect earlier the cancer in the initial state, and also to segmentate and to delineate the extension of the lesion. These are the goal that we want to achieve. This is an example, the evaluation of the quality of the lesion. If you want to obtain a good evaluation with this algorithm, you see when is red means that endoscopy is not sufficient for a good evaluation. Where you look at green in real time means that your endoscopy is good examination, and the algorithm can have the right information for give you the right diagnosis. So the trick is to go very close to the lesion with your tip endoscope in order to recognize very well the detail of the lesion. Then, of course, you can also, with this algorithm, recognize the lesion, and the machine can give you the rate of the detection. It can recognize in around 82% the histology, only with the imaging. And this is very useful in the screening program, also in a center where they have not a high volume lesion. So the artificial intelligence can help you to recognize the lesion and to give you a histology in 85% of the cases. Another thing is the possibility to segmentate the lesion. Again, the algorithm can recognize the boundary of the lesion and suggest you the extension of the lesion. Okay, again, based of the NBI examination. So the algorithm recognizes the typical vascular pattern and can confirm you this is the tumor, this is no tumor, the tumor is extended to the anterior commissure posteriorly. And this was tested not only in laryngeal cancer, but also in oral cavity and oropharynx. So we have different group of patients in Genoa and Brescia, and the results are comparable. That means that this algorithm will work not only in the larynx, but also in other anatomical sites. And this is our last task, obtain real-time delineation of the lesion during the office evaluation or intraoperative evaluation. The other imaging was evaluated offline on the cohort of patient. This now can recognize in a real time the lesion, so give you the information about the extension and the nature of the lesion. This is an example how we work. This is a normal tower. This is the screen of the algorithm. So during the examination, the algorithm can give you the information about the quality. You see the green means that the endoscopy is done in the right way. It can delineate the lesion. It can give you some information about the nature of the lesion. So we are working on, but now we arrived to this that, in my opinion, is the very useful information that everybody of us need. Especially in your country, I think that this kind of screening is very important because you have a high volume of population, and the majority of your cases are advanced cases, so very important, for instance, in the future, to have a screening program to detect the lesion very early with this system. This was already applied in India to recognize diabetic blindness with the artificial intelligence. So I hope that in the next future you are able to perform this kind of screening with this kind of algorithm to reduce the number of advanced cancers and detect very early the lesion. Thank you for your attention.
Thank you, Professor. I think that was a very brilliant perception between the two boundaries, from a non-surgical point of view. So I have learned a lot. And I really dream at some point of time you will join the imaging and the video endoscopy together to make it much more clear from the AI perspective. So that will give us much more thoughts, especially the deeper margins. And I really appreciate your AI integration with the diabetics in India. Thank you very much. We really appreciate it. Dr. De Cruz, you want to say something? Okay. Thank you.
May I request Dr. Sultan Pradhan to felicitate our distinguished guest, Professor Giorgio Peretti. May I request the chairpersons to also be here? May I call upon Dr. Prathamesh Pai to introduce our national faculty, Professor Alok Thakkar.
What can I say about Dr. Alok Thakkar? Dr. Alok Thakkar, as you all very well know, is the professor and chairman of ENT and Head and Neck Surgery Department. He heads the National Cancer Institute at Jhajjar and is a project head for the Center of Medical Innovation and Entrepreneurship at his alma mater, the All India Institute of Medical Sciences, New Delhi. Dr. Thakkar is an avid researcher and clinician and has several publications to his credit in reputed national and international journals. His special interests are in head and neck surgery, neuro-otology, and skull-base surgery. He has been at the forefront in adopting newer technologies to improve the quality of life of his patients. Dr. Thakkar has been the past president of the Foundation for Head and Neck Oncology and is presently its governing council member. I welcome Professor Alok Thakkar and I request Dr. Pradhan to felicitate him. We can finish. Yeah, he'll be speaking later. Yes.
May I introduce the keynote chairpersons, Dr. Gauri Pantvaidya, Professor and Chief Head and Neck Services, Department of Surgical Oncology, an eminent surgical oncologist known for her expertise in head and neck cancer surgery. Her special interests are robotic surgery, thyroid and parathyroid surgery, and she's an avid researcher as well. Welcome, ma'am. Dr. Nupur Kapoor Nerurkar, laryngologist, head of Bombay Hospital, Voice and Swallowing Center, DNB Coordinator ENT Department, President Association of Phonosurgeons of India 2013 to 2016, Fellow ALA and ABEA, founder member of International Association of Trans Voice Surgeons. Next we have Dr. Rajan Kannan, our HNCII consultant, a surgical oncologist, well known for his innovative approaches and dedication to cancer treatment. Can we have a round of applause, please? To begin our next session, please join me in welcoming Dr. Sharmila Agarwal, who will present on the role of single cord irradiation of early laryngeal cancers.
Good evening, everyone. I'll be talking today about one of the novel technique which has been coming in the early laryngeal cancers called single vocal cord irradiation. Some basic facts before we go to the main topic. As you all know, as per the India fact sheet Globocan data, we roughly see around 35,000 new laryngeal cancers. More than 2/3 of them originate in the larynx, in the glottis, and especially we need to catch them early if we have to treat them with single vocal cord radiation. Larynx, as all of you know, has 3 important functions. One is a voice production, second is protects the airway during deglutition, and third is the respiration. Since afternoon, we have been talking about various treatment options for early vocal cord cancers. As you all know, all of them, either transoral laser microsurgery, radiotherapy, or partial or hemilaryngectomy, have equal outcomes both oncologically as well as functional. Radiotherapy, to an extent, in some of the series which have been published, is associated with at least equal or better voice quality. There are various factors based on which we decide which patient goes in for surgery or which patients are taken up for radiotherapy. Some of the important factors are if the tumors are large, if there is an anterior commissure involvement, if the tumors are deep-seated and there is an inadequate exposure. These are the lesions for which radiotherapy is practiced. Since ages, we have been giving radiotherapy to early glottic cancer with either conventional radiation techniques using parallel opposed radiotherapy portals which are centered on thyroid cartilage, or from the era of CT scan simulation, we have been doing a CT scan, but more or less doing the same parallel opposed portals centering on the entire laryngeal framework. We give a dose of 6,300 centigrade in 28 fractions to 6,250 centigrade in 25 fractions. So we are actually hypofractionating compared to the other head and neck cancers. We deliver it over a period of 5 to 6 weeks using 4 to 6 MV photons. Some of the results of radiotherapy series, the largest series comes from Tata Memorial Hospital, approximately 1,000 patients, with T1 larynx, another 670 patients, and look at the control rates at 62 months. 84% control rate at a follow-up period of 62 months. There were recurrences of 16%, but look at the 5-year disease-specific survival. So most of the recurrences were salvaged with a disease-specific survival of 96% at 5 years. Some of the prognostic factors which have been studied by Mucha Maleka et al. With T1 glottic cancers who have been treated with radiotherapy, almost a group of 569 patients with T1 squamous cell carcinomas. They have a 5 and a 10-year overall survival rates of around 60, 85 and 68%, and a local control rate of 89 and 87% respectively. But multivariate analysis showed that if there was an anterior commissure involvement, this group fared poorly. If there was a fractionation of 2 or less than 2 gray while giving radiotherapy treatment, these people fared badly compared to the group which received hypofractionated radiotherapy. Another series from Tata Memorial Hospital by Dr. J.P. Agarwal et al., which did a prospective analysis of quality of voice in early glottic cancer patients treated with radiation. A voice quality of around 50 patients were analyzed following the treatment at baseline. There was a significant improvement in the majority of measured voice quality parameters. However, perturbation and HNR remained inferior compared to the control population. They also did a multivariate analysis, and they said a history of continuous smoking, anterior commissure involvement, and larger radiotherapy volumes resulted in poorer outcomes and poorer voice parameters following radiation. Now, in a lesion or in an early cancer, what is the incentive for me to change? Incentive for me to change comes from toxicity reduction. There has been a lot of publications in last 15, 20 years which talked about persistent voice impairment in a few percentage of patients. There has been a SEER database report which talks about these are the patients of early glottic cancer who have been treated, who are locally controlled, who are survived. But they noticed that there is an increased risk of cerebrovascular accidents in this group, leading to increase in morbidity. Then, in minimum percentage of patients, there is also a persistent laryngeal edema which needs either a permanent tracheostomy or dysfunctional larynx, leading to total laryngectomy. And in a certain less percentage, there's also a mild to moderate dysphagia, which has been found out because the constrictor muscles, the middle and inferior, as well as the cricopharyngeus muscle, is coming in the high dose region. Because when we are doing radiotherapy, entire larynx is the target volume. So how do I spare? How do I spare and reduce this toxicity? With the advent of intensity modulated radiotherapy in last 15 to 20 years, for all the head and neck cancers, IMRT has become the standard of care, but not for early glottic cancers. We have been doing early glottic cancers with conventional or conformal porters. But then researchers started work with intention to reduce the toxicity and see whether they are faring better. So the ways in doing this technique is, one is by doing intensity modulated radiation. The second way is volumetric arc therapy. And the third one is single vocal cord radiation. The work started in MD Anderson and MSKCC, wherein they did simple carotid sparing intensity modulated radiotherapy technique, and they reported their preliminary experience for T1 and T2 glottic cancers. They concluded that IMRT significantly reduced the radiation dose to the carotid arteries compared with the conventional lateral fields while maintaining the clinical target volume coverage. Remember, even in this IMRT and volumetric arc technique, it was the entire larynx which was the target volume. The second group from MSKCC also did a retrospective analysis of around 300 consecutive patients with early stage laryngeal cancers. 282 patients received conformal radiation, and around 48 patients were treated with carotid sparing IMRT technique with a median follow-up of 43 months. What they saw was 3-year local control rates were equal in both the groups, and the carotid artery dose was reduced. So coming to the landmark paper, which was a single vocal cord irradiation, this was published in 2015 in IJROBP. This is a research of Peter Levendak group from Rotterdam. Abraham Al-Mamgani and others have published this paper. What they did was, it was a prospectively collected, retrospectively analyzed 30 patients of T1A glottic cancer, but their target volume was only the diseased vocal cord. The treatment dose was 3.63 gray in 16 fractions. Set of verification was daily with online cone beam CT scan correction, and data for voice quality assessment from baseline to 18 months using voice handicap index questionnaire was done. And look at the outcomes. With a follow-up of median 30 months, 2-year local control was 100%, overall survival was 90%. Toxicity, there was no treatment interruptions, no grade 3 or 4 acute toxicities. There were 2 grade 2 acute dermatitis and dysphagia in 5 patients, and 1 patient developed temporary grade 2 laryngeal edema on follow-up. The voice handicap index improved significantly in the group which received the single vocal cord irradiation compared to the group of whole laryngeal RT. Their updated data published in 2022. Now they had 111 patients with a longer term follow-up data of 5 years. They wanted to validate their previous data with a longer follow-up. With a median follow-up of 41 months, 100 patients were available for analysis. 5-year outcome local control was 99.1%. 2 patients failed, treated with total laryngectomy, and 5-year overall survival was 80.6%. VHI again was greater than 30 at baseline was 38%, but VHI score greater than 30 was 22% at 3 years. The toxicity, there were no major toxicity interruptions in this group. No acute grade 3 and 4 toxicity was there, but 7 patients developed grade 3 and 4 late toxicity in the form of radiation, laryngeal necrosis. They concluded that single vocal cord radiation is very much feasible. Overall treatment time is much less compared to what we have been delivering presently. The excellent local control rates and survival, acute toxicity profile was favorable, good preservation of functional voice quality was achieved, and current follow-up results validated the previous data. Another paper, again from Netherlands with 93 patients. This was, they treated in a single center between 2014 and 2020. Local control rate was 100% for T1A, 97% for T1B, and 77% for T2. Laryngectomy-free survival was 90% at 5 years, and grade 3 and higher late toxicity was just 3.7%. They concluded that vocal cord only hypofractionated radiation appears to be oncologically safe in early stage glottic cancer. Now coming to ongoing studies, two ongoing studies which are undergoing in early vocal cord. One is Voice S. Voice S is a phase 3 randomized study for early vocal cord cancer comparing transoral laser microsurgery with single vocal cord irradiation. It is a multicentric, multinational study, and Tata Memorial Hospital is one of the centers. The other one which I'm actually interested in is a trial by David Palma group from Toronto, which is doing a phase 2 study comparing conventional volumes with single vocal cord radiation. We eagerly wait the results of both the studies. So researchers started working after they saw this very encouraging results. Can we shorten the overall treatment time? Can we shorten? Dr. Pradhan that day asked me this question. Can we just give treatment with only CyberKnife in this case? Two publications, in one IJROBP journal, one by David Scher et al. And another by Kang et al. Both the studies had to be closed early. The first one because almost 30% recurrences, and the second one because there were 2 severe late effects in arm 2 of that study. So the editorial said, we are making a progress, but not quite ready for prime time. So my concluding slide, is single vocal cord radiation going to be a new standard? Yes, it's definitely a novel method. It is going to reduce the toxicity. Also, it's improving the quality of voice, but I need to tread with caution because I'm dealing with a disease which is 90-95% curable with standard techniques which are available. I have to select my patients properly. Presently, the data is only of small numbers and a shorter follow-up. So I will wait for the results, especially of vocal RT trial. Thank you, everyone.
Thank you, Dr. Agarwal.
Sorry. Are there any questions for Dr. Sharmila?
Sorry.
I enjoy your communication. Just a comment. When I look at the literature about glottic cancer treated by radiotherapy, is always they always talk about early glottic cancer, put together T1 and T2. I show how is different the evaluation in each category. So my suggestion is, because you have a huge cohort of patients, because you don't try to stratify the patient in one vocal cord, 2 vocal cord, anterior commissure in an horizontal plane, T2, which kind of T2 is, because this gives you more detailed information about the efficacy of the treatment. Because if you put T1 and T2 together, is a big group, very heterogeneous.
We need to really select our patients well to do this step.
Okay.
If we are going to do any mistake, it's going to cost my patient a huge loss. Because finally, if we treat wrongly, he's going to have a local failure and will end up in total laryngectomy. So we really need to select our patients for a single vocal cord irradiation.
Yeah.
There has been a paper which I told the other group of 93 cases, wherein they have done treatment of almost T2 cancers with single vocal cord, or maybe they have marked the volumes properly, but there was definitely an inferior outcome compared to their T1 vocal cord cancer.
Yes, T2 single cord means that you treat T2 spreading superficially to the supraglottis subglottis of deep invasion. So, in my opinion, as in the laser cancer, you will find maybe some different if you stratify in different
So we
subcategories.
actually have huge numbers. We are going
to understand which kind of subcategory is work better than the other. And another point is that if you limited the irradiation to one vocal cord, you need probably a very accurate evaluation, intraoperative evaluation.
So the imaging part we have.
Not only the image, but in this case, probably an intraoperative endoscope, just to see with a biendoscopy if the lesion does transgress in the anterior commissure. So it's very good idea and a very good result, but I suggest to you to try to differentiate the cord, because probably you can achieve a better result if you stratify the lesion.
Thank you.
Okay.
Thank you, Dr. Agrawal, for your... May I request our next speaker, Dr. Alok Thakur, who will discuss the current status of salvage partial laryngoscopy.
Anterior commissure became a T1A, and in vertical extension T2B.
So thank you. Great to be back in Mumbai again with friends. And most of you know I come from Delhi. I represent two institutions. One institution which now has two campuses, the All India Institute of Medical Sciences, and a new campus of Gurgaon, wherein we have our new cancer hospital, the National Cancer Institute. So rather than talk about my institution, let me talk about this institution, which has so much quite taken me today. I loved the experience of being here. Obviously, I expected volumes and competence, that's a given. But now what I also see is compassion, what I see is so much goodness. It's obviously a reflection of the personalities of the leadership. And it percolates to everybody I meet here, be it the doctors, be it the nurses. I certainly get the impression your dream's just starting. So seriously, it's been lovely to be here. I was also rather pleased and flattered to be asked to speaking on a topic which has been Sir's specialization and personal specialization for a very, very long time. So to be called here to speak on laryngeal conservation surgery is indeed an honor. This data comes from our institution. It's very old data. It's 25 years old. But it basically tells you that with early stage cancer, you can expect a fair number of patients to not get better fully and need salvage. And though we did hear about single cord radiation and the potential, I did notice that with 2B, we might still continue to be in the range where we will have 25% patients who would need salvage surgery. So what salvage surgery, though? It's still not quite clear what you should do and what you should do when. And I mean, it's not infrequent to see these patients, and this was a patient I saw a few years ago, and non-smoker, sick gentleman, post-radiation, and a residual or a recurrent, whichever you want to call it, cancer of the glottis, close to the anterior commissure. What should you do? Should you do a total laryngectomy? Should you do a transoral laser surgery? Or should you go down the open partial laryngectomy route? Total laryngectomy is not a bad option. It's oncologically sound, functionally sound. Voice is a given. For laryngeal lesions, I think in competent hands, a TEP does work all the time, nearly all the time. Aspiration-free swallow is a given. Certainly these patients will have a tracheostomy, but this is really the gold standard we should be looking at when we start to compare what else we could offer these patients. Open partial laryngectomy, often oncologically sound, though of course you have to be careful. There are issues with regard to case selection. You do need mobile vocal folds, that's again a given. You do need to make sure there's no subglottic extension. And if you have the right patient and it all goes well, then certainly here's a patient who can have no tracheostomy, reasonable voice, and again aspiration-free swallow. though a little bit concern on every end, which you need to be careful about. And what about transoral laser surgery? Let me say I've done it and burnt my hands, and I don't think it's oncologically sound, which doesn't mean that it's a never or a never. There are situations wherein a transoral laser surgery is quite appropriate. Now, if you have a patient who's got a suprahyoid lesion of the epiglottis, certainly a transoral laser or would be quite appropriate. But when you start looking at glottic and supraglottic situations, in a situation which is obviously biologically aggressive disease, or it is potentially biologically aggressive disease because it's failed one treatment, a disease which is potentially multifocal, because we do know that when we radiate, it's not that tumors shrink in a circumferential way. In a situation where assessment is poor because of edema and inflammation, in a situation where there might be functional compromises, and where healing is compromised, there really are a fair number of challenges beyond what you see in the primary situation. In our book, we are very careful of getting involved with post-chemo artery situations for salvage with conservation surgery in this situation, because a post-chemo artery generally means that this patient had somewhat intermediate or advanced disease to begin with, and also because of the greater concerns with edema and lack of sensation and compromised healing and poor assessment. As I said, I'm not comfortable with transoral laser microsurgery in most situations in salvage, because the initial experience that we had with this did not quite go well. I'm not saying never, but generally very, very careful with getting involved with transoral laser microsurgery in the salvage situation, which generally means a T2 kind of situation. But beyond my own experience, there are these two reviews which I really go a lot by. When I was having this experience, I happened to discuss this with colleagues, as we all do, and at that time, Vin Polleri was putting forth these two systematic reviews. One of them relates to open conservation laryngectomy for radiorecurrent laryngeal carcinoma. The other one relates to oncological outcomes for transoral laser microsurgery for radiorecurrent laryngeal carcinoma. And though these are both two separate papers, they are from the same team and have been done and analyzed by the same methodology. And what comes through is quite stark. Of course, there's a publication bias, because we do know that most of us are not going to quite publish our results which don't come out excellently well. And even if you do wish to, some editors may not accept them. But that being what that is, if you look at the comparative local control rates between open partial laryngectomy and transoral laser microsurgery in the published systematic review, then there's a 30% difference, or at least a 25% difference in terms of local control rates. There's a 20% difference in terms of DFS rates, and a 10% difference in terms of overall survival rates. So in my book, transoral laser microsurgery is to be done very carefully. And if you have a patient who needs salvage following early glottic, supraglottic cancer recurrence, then the thoughts to consider are between an open partial laryngectomy and a total laryngectomy, and very occasionally endoscopic surgery. This is our experience, and if you look at there, some patients have had endoscopic operations. It's not that they've never had. But as a larger group, we do all kinds of partial laryngectomies for salvage. Today, probably it's a supracricoid laryngectomy that is the most frequent, but even the vertical partial laryngectomy is done fairly frequently. And this analysis that I put together last year indicates to us that we do reasonably in terms of disease-free survival and also in terms of functional results. But this probably depends more on case selection than on surgical technique. It's about picking the right patient. It is about executing right, but it's also about picking the right patient. And selection, of course, depends on functional selection and oncological selection. So functional selection, they should be in good health. They should obviously have a functional larynx. They should have reasonable respiratory health. They should have a reasonable voice, good cough, can walk up 2 flights of stairs, that kind of assessment, pulmonary function test. Oncological selection, so it's easier to see what is not on. It's easier to say what is not on. So certainly, significant vocal fold mobility restriction would be a no-no. A mild vocal fold restriction is okay. Arytenoid movement is an essential component. Significant subglottic involvement so that it comes to the cricoid is obviously again a no-no. Invasion of the posterior paraglottic space, as was just articulated by Professor Perrette, is a big concern because you can't quite clear that very well. You can clear it better by a partial laryngectomy than you can clear it by an endoscopic operation, but it is a concern. Anterior commissure involvement, as has been articulated, is not really a concern because anterior disease is easily sorted by an open partial laryngectomy. Extension to pre-epiglottic paraglottic spaces are not a concern. They are fairly well cleared except for the posterior paraglottic space. Minor thyroid cartilage is not a concern. But the one thing that you need to be careful about that the disease has to be both before radiation treatment and after radiation treatment, and both things it should pass the threshold that was oncologically appropriate for the proposed partial laryngectomy excision. This is just about the anatomical analogs of function preservation, which gives you a better understanding of what is oncologically on and what is on. We know that for phonation, you don't need vocal folds. Even patients with total laryngectomy speak. But patients following partial laryngectomy generally don't speak with their vocal folds. They speak with their supraglottic voices. And this can be variable as to what finally comes through. Nevertheless, they will all speak, though they may not sing or speak very loudly. For airway, you need an intact cricoid ring. That is conventional. Of course, there's a small exception to that was talked about. You can do a supratracheal laryngectomy and take out the anterior part of the cricoid ring, but conventionally, you have to preserve the cricoid ring, which is why you have to basically avoid lesions in the subglottis. And functionally, the most important thing about swallow and airway protection, again, is about having a functional cricoarytenoid unit, which means, as has been articulated, the arytenoid with its joint, with its muscles, and with its nerves. And with its nerves means the superior laryngeal nerve and the recurrent laryngeal nerve. So you have to preserve all of that if you're going to get through a successful, functionally successful open partial laryngectomy. We do all three, and this is something I think it should be fairly well known to all. So we still prefer or like to do the vertical partial laryngectomy, especially with patients who have unilateral disease or with patients who have unilateral disease. It continues to be a good operation, functionally very robust. That's the best part about it. Swallowing function is almost a given. So it's a functionally very robust operations, easy to execute, easy to heal, and very consistent in its functional results with regard to swallow and airway. The horizontal partial laryngectomy is something we do very rarely, but nevertheless, it is something we do now and then. It is challenging in terms of swallow function, and certainly there was a time when I started out that we were told that it was never to be done in salvage situations. But today, it is, I think, almost exclusively done in salvage situations, except for the non-squamous cancer patient that might come to you now and then. Of course, the tumors have to be above the ventricular folds, and when there is significant extension to the pre-epiglottic space is when this operation really comes into play. And then there is a supracricoid laryngectomy, which obviously has a bigger expanse in terms of what it covers, and both glottis and the inferior supraglottic you can cover, and anterior lesions are fairly well covered, be it anterior commissure, pre-epiglottic space, paraglottic space. So this is really becoming the go-to operation for these situations. I'm going to spend a few minutes on tips I've picked up along the way, which have helped in having the confidence to execute this. And of course, only if you have the confidence to execute this can you propose this to patients and take it forward. So it's about case selection. This is obvious, both functional and oncological. You have to select the right patient. I have listed out the oncological and the anatomical issues that you have to watch out for. Functional, I think, is well known. In terms of surgical, it is essential to preserve the superior laryngeal nerve. You don't preserve the superior laryngeal nerve, you do not preserve the adduction reflex of the arytenoid, you do not preserve laryngeal elevation and the operation fails. That patient will aspirate. And of course, you have to preserve the recurrent laryngeal nerve. You have to preserve the arytenoid. Other things put forth, Dr. Peretti talked about this a few minutes ago, so this is repetition, but you could call it reinforcement. We take the suture from the vocal process to the cricoid to ensure that the arytenoid stays up erect. This is important. You can't, you cannot allow the arytenoid to fall back because that may not protect your larynx so well. You may do a cricopharyngeal myotomy. I used to do that quite consistently. No longer do that. In any case, when you do the operation, on many occasions, you have disarticulated the thyropharyngeus from the thyroid cartilage anyway, so you have done some kind of loosening. And I got a hint that perhaps this might exacerbate reflux and laryngospasm and aspiration. I don't know. I don't do it anymore, and I am quite comfortable with not doing it. Results continue to be okay. Laryngeal elevation, which occurs with supracricoid laryngectomy, is probably the key as to why these patients do so well. My impression is that patients of supracricoid laryngectomy do better in terms of aspiration than patients of supraglottic laryngectomy, even though the initial concerns were that supracricoid was obviously a bigger operation and would lead to significant swallow. It doesn't happen. And in fact, now when I do a supraglottic laryngectomy, I am careful to do laryngeal elevation, even though it's not part of the operation. And then positioning of the piriform sinus. You have to position the piriform sinus on the side of the larynx so that when the patient swallows, it goes from the tonsillolingual sulcus down the glossoepiglottic fold, down into the piriform sinus. You have to have your piriform sinus in the right place for the food to go down right. So there's a lot of small surgical nuances to ensuring that things go down right and patients don't have swallowing issues. And frankly, today we have fair amount of confidence that we won't have any problems there. Early decannulation, as has been articulated. Certainly early decannulation helps because the subglottic pressure comes back, the larynx is no longer tethered, the larynx is moving. When the larynx moves, the cricopharyngeus opens, the swallowing reflex is back, and then you take out the NG tube. And we have similar protocols of getting the trachytube out in the first 5-7 days and getting the NG tube out at about 10-14 days. And that really is all I have to say. But to reinforce again, so salvage surgery, preference largely for open partial laryngectomy when appropriate. Transoral laser surgery is something we are very, 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 very careful about. Oncologically sound, functionally sound. I've listed the issues which you encounter. I have significant concerns with post-chemo RT and significant and salvage with laser. That is about case selection, functional, oncological. Pre and post-RT disease should both be oncologically appropriate for the proposed resection. And that is techniques which we use to improve swallow function and have the confidence that these patients will swallow right. So time is short, but there's a video on YouTube and you can watch it later.
Thank you, Dr. Thakkar. Excellent presentation. Maybe time for a couple of questions. I'll just start the first question. Do you think, as of today, salvage laryngectomy in India is largely in the recurrent, conservative laryngeal surgery is largely in the recurrent setting? And why do you think it is almost no longer being used in the per primum setting for laryngeal cancers?
I think it should be used in the intermediate cancer settings. So the T2B, early T3 with mobile cord situation, it is an option. I mean, we were having a discussion on this earlier in the day, and there is a lack of clarity with what is the best organ preservation or function preservation technique in this intermediate realm. So we do use it in the T2B or the paraglottic space, pre-epiglottic space, radiological T3 situation, even in the primary setting. We use it in the T4 situation with thyroid cartilage involvement with mobile cords. It was articulated that following a partial laryngectomy, you should be careful about giving post-op RT, but that is, at least in our practice, not a significant concern. So it is used in the primary space. But yes, in the salvage space, there is little other option if you have to do organ preservation. So obviously in that space. But what I would say is that this is a low volume procedure, which obviously units or teams have to build competence on. It's not about building competence and moving on. It's about passing on that competence to the next generation. And I mean, I'm sure there are a few places which can do that and do it well. Yes.
Thank you. From what I know, maybe Dr. Thakkar's center does do a lot of per primum conservative laryngeal surgeries, but overall there seems to be a significant decrease. I know at Tata Memorial Hospital there has been a significant decrease in per primum open conservative laryngeal surgeries, and the thought process there is that as of today, either you do an endoscopic transoral surgery or you give the patient radiation therapy. How do we justify doing an open laryngeal conservative laryngeal surgery in the per primum setting? And maybe we can take some of your comments on that. Yes. So as of today, I know y'all are strong on the conservative laryngeal surgery, open conservative laryngeal surgeries for the patients. But how do you justify that when you cannot do a surgery? Or there are so many transoral techniques. So if you don't do it transorally and you don't give radiotherapy, then is there really a role for doing open partial conservative laryngeal surgeries today?
You are talking about TT2, T3 intermediate stage.
Yes.
Because you can achieve a better oncological result. Because, for sure, I mean, if you perform conservative open surgery, you can, in T2 and selected T3, you can achieve a local control higher than 85%. You cannot achieve the same result with the radiotherapy. And this is the main reason. And also because in T3 probably you have to combine chemo radiation and the post treatment increase morbidity problem. And in Europe we feel more confident with open for this reason.
Yes.
Okay, we reserve chemo radiation, I told you, as an alternative to total laryngectomy.
Sure.
But for sure, you have to follow this strict criteria of selection. You have to follow some tips of technique to improve the post-operative rehabilitation. Is not really, when we talk in conservative surgery, I mean, there are many aspects to...
Yes, of course.
To look.
Thank you. Thank you, sir.
Thank you.
Thank you, Doctor, for your exemplary, distinct, comprehensive overview. May I call upon Professor Peretti?
I promise this is the last talk. It's the last, but in my opinion, is the more interesting because I show you something really new, and is another field of research in my hands. The possibility nowadays to replace the microscope with the exoscope in transoral approach. So nowadays we have different weapons to treat the disease transorally, going from the traditional laser surgery to the robotic surgery that is limited to like oropharynx and supraglottic. For sure, you cannot treat glottic cancer. There is some experience about the office treatment by the Japanese school, but is more indicated for esophageal diseases. And the newborn is the exoscopic approach. If you look at the evolution, we start with Klein-Sasser with the microscope. We combine the cold instrumentation with the laser in the 1970 with Dr. Strong. And thanks to the Storz company, we start to develop the exoscope in the 2017. And now, with the collaboration with this company, we arrive to the new generation. The name is Eagle, the exoscope, coupled with the micromanipulator. So if you look at the literature, the transoral laser microsurgery is stable for the larynx, is decreased for the oropharynx, the torus increase for oropharynx. But if you look in the last years, the use of exoscope increased a lot, particularly in the larynx. And now I show you the comparison between the older generation of the VTOM, of the exoscope, with the new one that is improved a lot compared to the old one. Why? Because now you have a very good magnification. You go from 4 pair in digital wave to 12 pair magnification, because you can combine 2 systems, optical magnification like a microscope plus digital magnification to achieve a very high magnification. So you increase also the definition from full HD to 4K, and now you can also the possibility to modulate the spot of the light to make it possible to go with the light inside also the small laryngoscope and to improve the illumination. This is a setting in the OR with the Eagle, so all the team have special glasses, so you can share with all the team the same imaging of the first surgeon. So everybody can participate actively to the operation, and this, in my opinion, is very, very important from the didactic point of view, because your coworker can see exactly as you see and can help you in very active way. This is some example. You can look in the screen, but the same imaging is shared with all the team. And compared to the first version, where the VTOM interfere between the surgeon and the screen, now with a new model, you can see directly the screen without any obstacle between the surgeon and the screen. So is improve also the ergonomics of the surgeon, and also reduce the muscle fatigue in a long operation. And with the new one, you can adjust the spot of the light, so you can reduce in 7 positions. You can reduce the spot, and this make possible to go inside also the small laryngoscope. Everybody of you know that when you use a small laryngoscope, sometimes you have a kind of reflection or you lose illumination. With this adjustment, you can obtain a very good illumination also in the very small field. Then We improve also the attachment of the micromanipulator to the camera. Now is very stable, and you can have a very good alignment between the visualization and the aim beam. By contrast, in the first version, the micromanipulator was not so stable, and you have to adjust all the time. I show you now some comparison between the two tools just to understand the difference. This is one cordectomy performed with the Vitom, the old system. So it's type 2 cordectomies, as I showed before. And in the you see that you have a good visualization, but it's not so fine as fine-tuning as with the eagle. I show the eagle. With the eagle, you can appreciate very well the anatomic detail. You can see the fiber of the muscle. You can recognize a small vessel, and the visualization is outstanding. This is the vocal ligament. This is the subligamental plane. So you can see much better. Now you are seeing this imaging in 2D, but you can imagine to see this in 3D with the glasses. You can see in the same way as the first surgeon during the operation. So this gives us the possibility to have a very accurate, very precise definition, and also very good magnification compared to the microscope. And one important thing is that you can, this is another comparison between the Vitom again on the left and the eagle on the right. Same operation with different tool. And of course, again, you can appreciate the detail anatomical much better in this way compared to the Vitom. And the Vitom, you take into account, is superior to the microscope. So we jump from the microscope the Vitom and from the Vitom to the eagles. This is what you can obtain nowadays with the Exoscope. It's a really amazing surgery because you can see very well. You can share this imaging with your residents, with your coworkers, so they can learn very fast. The learning curve is become shorter and shorter. You can see the vocal ligament, the conus elasticus, and remain always well focused. But this is another case of type 3 cordectomy. And in this case, I show the transtumoral technique proposed by Steiner. Dr. Pradama asked me this morning to show you. We use this technique that you know very well when we have a bulky lesion. Just is based on the effect, thermal effect of the laser, the different effect of the laser between the cancer and the healthy tissue. When you reach the healthy tissue, as in the case of the muscle, you have no carbonization, so you can spare the muscle in this case. Also, if the lesion is very bulky, I remove the anterior part of the lesion and now approach the posterior part. As you see, I change in this part the tube with a catheter just to better control the posterior part, the medial wall of the arytenoid. And more or less the same procedure done by the eagles. you can see the difference very well between these two procedures. When you see in this way, it's very difficult to make a mistake because you can appreciate in detail the vascularity, the extension, the lesion. You reduce the possibility to have a positive margin. So you have many advantages compared to the visualization of the microscope. And you take in account that the main advantage of the Exoscope is that you can use this tool for many anatomical sites because you can treat the vocal cord, but you can also use for oropharyngectomy or hypopharing or supraglottis. By contrast, with a robot, you can see very well, but the use is limited to the oropharynx base of the tongue that remain probably the only indication for robot, but you can not use the robot for glottic plane, for instance, or for hypopharynx. So with one tool in your OR, you can cover all indication of the transoral approach. Moreover, you can use a CO2 laser or you can use other device according to your need. This is an example of papillomatosis treated again by the Vitom and by the Eagle. And, yeah, I start always with the debrider just to debug the lesion. I use a photocoagulation for the for the remaining diseases. And you see, I don't use a blade, but I use a circle just to make a very superficial vaporization in order to spare completely the vocal ligament and to reduce the thermal damage of the vocal cord. But again, the definition is much better and you can evaluate very well the invasion, the lesion, the superficial extension, and you can see the difference. Another indication can be other diseases. This is Zenker diverticulum, and in this case I perform cricopharyngeal myotomy. This with the Vitom again, and this with the Eagle. With the Eagle, you can have a very good focus, very good detail, even in the cervical esophagus. Here there is some defocus. Here the focus is always in the right way, even if the length or working length is superior to 400 millimeters. So even in a cervical esophagus, you can appreciate very well the muscle, the fiber, and you can tailor your resection. In detail, you see I increase the magnification just to evaluate the difference between the muscle and the fascia. And this is very useful to avoid complication. And at the end of the procedure, yeah, you see the difference between the two techniques and also between the two lasers. You ask me the difference between the Luminis and Deca. This is the Deca laser, this is the Luminis Deca. And usually I put two clips laterally just to resurface the raw area with the remaining mucosa. Just to show that you can use the same tool for a different indication. This is subglottic stenosis. I show this just again to show you how is the precise the visualization even in subglottic plane or in cervical trachea as in cervical esophagus. This is the case. Was idiopathic stenosis, so this is the vocal cord, but you go through the vocal cord, you can increase your magnification, and you can very well focus in cervical trachea, and the laser remain very well defined. I make the radial incision. In this case, I'm using the catheter again, and usually I perform infusion of the cortisone. This is an interesting case. It's a paraganglioma, 3 paraganglioma, 2 in the normal position of body, carotid body tumor, but we have also paraganglioma in the paraglottic space. So we treat the 2 body tumor in the traditional way, but simultaneously we treat the arytenoid with the blue laser. The blue laser has a high affinity for the vascularity, so we try to make a coarctation of the tumor. This just to underline that I can use many thermal device, going from CO2 to blue laser to electrocautery to diode laser, with the same optical device. So for me is the main advantage to have in your operating room just one tool with different thermal device, and you select the thermal device you need more appropriate in this operation. This is soft palate carcinoma. Just to give an example that you can use electrocautery, and you have a straight visualization, and you see the magnification. This is the tip of electrocautery, and so you can see very well. Just to give an example that you can treat this lesion transorally with this technique, as for example oropharyngectomy for the tonsil cancer, as with the robot. So in my opinion, the robot remains a good indication for the base of the tongue, but for the other localization, the Exoscope gave you comparable visualization, very good magnification, but the advantage of to use different tools according to your need. You spare money because it's less expensive compared to the robot, because you use the traditional tools that normally you have in your OR. Okay, the resection is very simple, so I don't go. So in conclusion, we achieve a stable position of the micromanipulator to the camera. We obtain a very good visualization, a higher magnification, combining optical and digital zoom. We can very well see the anatomical vessel. When you see very well the anatomical detail, you reduce the possibility to make a mistake. You have very good ergonomics, especially if you perform a long operation, because you reduce the fatigue, the muscle fatigue of the neck, of your shoulder, when you use the microscope. Probably in the next future we have to optimize the smoothness of the robotic arm, because this camera is controlled by a joystick, a robotic arm that changes the position of the camera. And my dream is to integrate also an angle 30-degree telescope, 3D telescope, 4K, in order to have a good visualization also on the base of the tongue tumor and go around the corner as we normally do with the robotic surgery. Thank you very much.
Excellent presentation, Dr. Peretti. And we look forward to have the exoscope here so we can also operate. If there
Do
is
you
time.
have the new one? The
No,
Eagle?
we don't have the exoscope. We have used the exoscope for a few cases for, I think Prathamesh was there for external surgery. But we
Okay.
haven't.
Because is another indication, external surgery, also lateral skull base surgery.
Yes.
My colleagues in Italy use this also for cochlear implants or lateral skull base, and they replace also the microscope in this field. So it's very promising tool that in our field could be very very new and also very useful.
One is, if you are already someone who does laser surgeries, is the learning curve very difficult with an exoscope?
No, it's much faster.
Yeah, so
my
that's
residents can learn very fast.
Lovely.
Because they can see very well. They see in the same wave, then can interact immediately with. So we perform a so-called forensic surgery, and they can do the operation like me in a few months.
And is the angulation of the exoscope difficult to do for supraglottic or oropharyngeal cancers, or is it just like how you use a micromanipulator and a microscope, or is it a little more difficult as compared to glottic cancers?
No, because if you have a straight view as a microscope, you have the same direction, and but you have higher magnification and higher resolution, so you can see better. It's very easy to move, and your assistant with the joystick can help you simultaneously to change the zoom, to change the focus. So you are always in the right position with a good exposure. Of course, your assistant have to learn what you need in the same way, help you very well. So I'm very happy about this project.
Thank you very much for showing your experience to us. Any questions for Dr. Peretti from anyone?
You take into account that the Eagle, at the moment, I am the only person in Europe that use the Eagle in the larynx, because I developed with the Storz this device, so they start to be diffused in other countries after the meeting in Dublin where I showed this. So the enthusiasm is emerging among the community.
The 3D, the 4D vision,
yes, you cannot imagine, because this is very poor visualization, 2D. But if you look in Dublin, we have the possibility to see my presentation with the glasses. Everybody was astonished because seemed to be in the OR in the moment. Yeah. Okay, thank you.
Thank you, Dr. Peretti.
You have to try.
Professor Goretti, for your talk and advancement in transoral laser surgery. Thank you so much. Now we have a case-based panel discussion. Our moderator will be Dr. Sultan Pradhan. Our panelists are Dr. Anil De Cruz, Dr. Rajan Kannan, Dr. Prathamesh Pai, Dr. Asif Monin, Dr. Sharmila Agarwal, and Dr. Tapan Saikya.
Dr. De Cruz has a suggestion. Everybody is tired, and to have a whole panel discussion now, I think it's quite late in the evening. So what he's suggesting is that we have an open house. Too many issues have been raised, some resolved, and some questions may still be there in people's mind. So rather than me asking these experts, I think you can ask questions to these. I will start with a case of in situ CA. I'll just give you one slide here to tell you how things are evolving in laryngeal cancer. I left Tata Memorial 22 years ago, and ever since that I've stopped attending meetings. Nobody invites me. So I looked up my old records, and I saw this 3-year data in only my unit, in one unit at the Tata Memorial, 120 laryngectomies done, 50 near total laryngectomies, 44 partial laryngectomies, 99 transoral endoscopic resections. And how the pendulum that Professor Paretti showed keeps swinging. Today it's very heartening for me to know that there is a thinking by both the experts here to revive the partial laryngectomies. It is my books, don't get outdated, Gauri.
The anatomy of the larynx is the same, so your book will not get outdated.
Only the thinking changes. So I'm very happy about the enlightenment that you have given. So the first, so we have one case of bilateral leukoplakia in a gentleman who presents with hoarseness of voice, and we do a type 1 chordectomy on this. The next slide. And the result comes as moderate to severe dysplasia consistent with squamous carcinoma in situ. And very often we see that these patients get referred by the ENT surgeons to the radiotherapist for radiation. So first I want to ask Sharmila, do you accept these cases for radiotherapy?
So we don't, because it's carcinoma in situ or the pre-invasive cancer. So we try avoiding giving radiotherapy for in situ cancers.
So I don't think I need to ask this question to Anil. You agree with that? No radiation for carcinoma in situ?
The problem is that people who are uninitiated in cancer, when they see the word carcinoma, hit the panic button.
Yeah.
And that's why they send. So you rightly said a general ENT would. But this is not going to kill. And as we tell, when we give lectures, it's like killing a fly with an atom bomb if you give radiotherapy. I would make an urgent plea that maybe we should change the nomenclature, not use the name carcinoma in situ.
Very severe dysplasia.
Severe, no, like in say, in penile, now they call it PIN, penile intraepithelial neoplasms. Doesn't sound as frightening as carcinoma. Or NMR, nuclear magnetic, they changed it to MRI, something like that.
Next. Just skip it. So now we are here with a T1 glottic cancer, mid-chord glottic cancer, and we've heard a lot about that today. Prathamesh, what was your preference for this?
So you would want to evaluate what is the depth of infiltration, and if it is superficial, when you're not going to do a type 3 chordectomy, you would subject this patient to a laser resection.
So, Anil, same thing?
I
I would agree with Prathamesh. Both are equally good. Guidelines say both. And maybe if I could expand this discussion and ask Dr. Paretti at the beginning of his presentation, he did show a very elegant slide with some good data that if you didn't have good exposure, there was a 49% recurrence. And if you had good exposure, it was much less. But what was missing on that slide was the denominator.
Not a recurrence, but the rate of positive margin.
Positive margin, okay. But the denominator is important. If I took 100 patients like this into the operating rooms, how many would have good exposure and how many would have bad exposure? And would that vary among people who do it often vis-a-vis people who are the occasional laser surgeons? And I make this point because I travel the length and breadth not only of this country but overseas as well. And while your data is very impressive, there are few OASs that do lasers and do conservative. 90% of patients still go for radiotherapy the world over. And that's real world data. Comments?
I mean, you can evaluate the possibility to have a good exposure before put the patient in the surgery. This is important. So before to say, okay, this is a good indication for laser, with the laryngoscope you can anticipate the possibility to have a good exposure or not. So if I have a very high laryngoscope, I don't suggest laser to avoid to put the patient in the OR and make the resections impossible. But if you have a good exposure, in one case like this, I have to see this intraoperative with the 70-degree telescope. The lesion is confined to a single vocal cord. With type 2 cordectomy, you can have a good oncological control, good voice, and very short hospitalization. So it doesn't make sense, in my opinion, to use radiotherapy, 6 weeks of treatment, increase the cost for a lesion that you can treat in one session. Moreover, if you have to perform biopsy before radiotherapy, so you need a biopsy and a radiotherapy with a social cost. So really, I cannot understand, as in the Tata Hospital where you have a high volume of tumor, you use radiotherapy for a case like this. It doesn't make sense because the machine must be used for more advanced cases.
The exposure has to be good. The point that Anil is making is that the exposure has to be good. No transoral laser surgery will work. And you must not, like Dr. Kannav made a point today, that you can't use the transoral laser resection saying that I will debulk it. The little bit that remains, the radiotherapist will take care. That is not on. That should not be done. So before you make the laser cut, you need to have a reasonable certainty that I will be able to encompass it completely, and I will not want it to then go to the radiotherapist. It should be a single modality treatment. That is most important. What percentage will not have good exposure, I don't know. Maybe I think 10 out of 100, maybe 15 out of 100 will not have good exposure.
Sorry, Professor. Another important thing is that you perform a laser, you don't preclude any further treatment.
Yes.
I mean, if you need a radiotherapy after for recurrence or for a second tumor, you don't use a radiotherapy for
No, I'm conversant with all that. I just wanted to make another point. In surgery, and these are just conceptual points after treating head and neck cancers for a long time, whenever you do surgery, healing is unpredictable. When you do thyroid surgery, some people get a good scar, 95%, 5 get a bad scar. I can understand if you do a type 1 or a type 2, transepithelial, transligament. But the moment you start touching the vocal cord, voice is very unpredictable. I've seen videos shown by laser surgeons where people sing soprano after a type 3. But I've also seen videos or real life cases where sometimes they croak like frogs. So how do you, we don't have good data on voice quality. Pittance, 50 cases, 60 cases. When I see series put up, even all the series you showed, 80, 90, 100, yours is a good series. So that's something that we need more data on voice. As you said, or I think Alok said that people don't show their bad results, they only show their good results.
The problem for the voice is the anterior commissure. If you include in the resection anterior commissure, for sure the voice is worse. So when you talk with the patient, as in these cases, you can be sure that the voice will be good. If you have to extend the resection to the contralateral vocal cord, you make a synechia, for sure the worst voice is predictable. So it's important, again, when you talk about type 2, must be type 2. Because if you perform type 2 and you remove the muscle, it's not type 2. So the goal of the classification is just to have a common language when we compare the results. But there is a paper that I wrote more than 15 years ago where I compare patients treated by type 1, type 2, and type 3 with the normal patient without disease, with MDVP and VHE. After type 1 and type 2, the voice was comparable.
So I think that point we have to tell people. Very often people do laser on the cord and they just take a cookie bite out of the tumor with clear margins. And that screws up voice. And I think you have to understand the science of doing one, type 2, type 3. You have to be very clear when you embark on laser.
If type 2 chordectomy has some shaving of the muscle,
yes, very minimal.
yeah, that is what most of our T1 cancers have. Some shaving of the muscle is there. It's not just deep to the lamina propria. Some shaving of the muscle does come in. And there the voice quality is good. But I agree with Anil that nobody does the voice quality index recording, and it is unpredictable. You're very right.
Yes, if you have a good closure, the key is the closure, the competence. If you have the competence, the contralateral cord can have a good mucosal wave. So the voice remains good. If you have incompetence, you have a breathy voice, speak like this, and you have not mucosal wave of the contralateral. So the key is spare the anterior commissure and achieve a good growth. If you respect these two factors, the voice, the result is predictable.
One of the problems
Can
that
I make
we
a point,
face-
sir?
Yes, yes.
So what point Dr. De Cruz was making is that if it's a linear resection, it's a sharp cut along the muscle fiber, you're not going to create a defect which is triangular in shape or circular. So at that point, you would have a phonatory gap.
Yes.
So if you're resecting, even when you resect a muscle, if it is linear along the length of the fibers, you will achieve a good closure.
Yes.
And pre-treatment and post-treatment voice evaluation is very critical. It also helps in the rehabilitation process. When the patient is made to hear his voice pre-treatment, post-treatment, and subsequently at every visit, the speech pathologist will be able to guide the patient towards a better voice. And I think we falter at that point. We don't have a proper team which rehabilitates the patient. So you would need the patient not to have a false chord phonation. He needs to have a proper glottic phonation. He needs to be taught breathing exercises and vocal hygiene. Those are more critical post-treatment, and that is going towards an improvement in the voice quality.
Yes.
Type 1 cordectomy, is it better to excise from the vocal process till the anterior commissure of the epithelium and the ring case space versus just the anterior third, the section? The whole length of the, so reduce the gap.
But, take into account that type 1 must done in very selected cases, where you have a ballooning, where you have a mucosal wave. So I select patient with, a leukoplakia, probably just to be confident that this is not a tumor. But now, with the MBI, with bioendoscopy, if I have leukoplakia and BI is negative, I follow the patient to treat the patient. So my preferred approach is type 2, because when I presume that this is cancer based on the MBI, I perform a type 2 up front. And the result between type 2 and type 1 are comparable, because the key is the closure again. If you spare the vocal lumen, sometimes the vocal cord becomes stiff, because you have a scar tissue over the vocal ligament. So if you spare the muscle, you have a good closure, and is more soft compared to the scare of the vocal ligament.
Yes.
I had a question about NBI. So we are now using a good bit of NBI both for diagnosis and during laser surgery. But I do find, maybe this is because this is early days that we are using it, I do find a lot of subjectivity in NBI. Is there any objective criteria? Because I do see, it's okay, I do see that sometimes I'm staring very hard trying to understand if it's a loop or it's a capillary or if it's convoluted. You know, the type 5, type 1 fine, but in between, I do find that it's very subjective. So is there a learning curve for NBI, or is there a more objective way? How do we interpret NBI well? Because we don't want to be excising too much of someone's vocal cord, because, you know, we have not been able to interpret the NBI correctly.
You have to be very close to the lesion with the endoscope to understand very well. If you stay 1 centimeter, it's not enough. You have to be very close and very well focused. So if you recognize the dark spot, the dark spot are the apex or intracapillary loops. So you have to look at the vascularity of the vocal cord, that the change direction from the longitudinal wave to the perpendicular wave. But if you recognize, if you learn to recognize this simple sign, the probability to have carcinoma is more than 90%. I show you before, you see with artificial intelligence.
Yes, that's better than the NBI.
No, but the artificial intelligence show you if you are doing a good endoscopy or not. Because if you stay far from the lesion, you have a red light.
If you don't have narrowband imaging, then is it better to do type 2 rather than type?
Yeah.
Because
if you have some doubts, better to go type 2, because if you make a type 1 and you have a deeper margin, positive, you are obliged to make a type 3 resection. So it's much better to make a type 2 up front to obtain radicality and good vocal results. For this reason, I said very careful to use type 1, because the risk to have a deeper margin is very high.
One of the problems that we frequently have is ENT surgeons doing an excision biopsy without margins, and it is invasive cancer. And then they send you, and it is very difficult to know where the epicenter of the lesion is, or there is too much of edema, and you have to either send them for radiotherapy, or you have to re-resect it You're always worried what was the epicenter of that lesion. Do you all see this problem also?
So I'll make a comment because I'm not ENT and you said ENTs do that. Prathamesh and Alok will be biased.
With their head and neck surgeons.
ENTs pluck out any growth. Alok and Prathamesh, I want you all to respond because both of you all are teachers in Premier and many people listen to you in the specialty. They pluck out things in the nose with the endoscope. It comes as malignancy. You don't see anything and it's sometimes high grade. They take bites of the tongue for small lesions. It comes as positive and it's TX. Larynx is the least of my problems. The patient will not die. I'll just call the patient 3 months later. But in other parts, it's a disaster. And I think you all guys need to drive this point home. I know it's partly economic when they do this, but apart from that, I also believe it's lack of training. Comments from the two professors.
Look.
I do agree that there is a lack of dissemination of current thought in this area. Certainly happens in the tongue, certainly happens in the buccal mucosa. We see the same issues. In the larynx is a little bit less of a problem today because generally there's good documentation because they have pictures as to where it was and you can use NBI to get someplace. But yes, I mean, it is a problem. I totally agree with you. And the only way out of it is to disseminate knowledge as to why a biopsy or an incisional biopsy or a punch biopsy might be the best way forward rather than to do narrow margin excision.
And you'll have to lock that coblator in the storeroom when they start. They just coblate everything they see. Everything they see, they coblate.
Prathamesh?
Sometimes they see oncosurgeons do the same. That's the whole point. I said sometimes they see oncosurgeons do the same who are demonstrating these operations all over on YouTube. That is the point. So sometimes, and
any views now on anterior commissure lesions? Anybody for transoral laser resection or with very good exposure?
How old is the patient?
I've forgotten how old is he, but I can just tell you 40-year-old.
40-year-old.
Yes, I can recommend laser based on two images like this. This is a transcommissural lesion. So
speak in the mic, please.
It's a transcommissural lesion, so with vertical extension. So based on of our data, is the worst subcategory to treat with the laser. So I reserve the treatment if the patient is an elderly patient, fragile patient. I cannot perform open partial laryngectomy because the ideal treatment in these cases, in my opinion, is open partial laryngectomy or no surgical approach, because the probably to cure the patient is not more than 70% with the laser. This is T2 transcommissural, but you need a CT scan before maybe could be a T3 for paraglottic or pre-epiglottic invasion.
So I think you need to do
accurate workup.
Yeah, I think the lesion on the right and the lesion on the left, you would need to do a 0 degree and a 70 degree evaluation. If the one on the right seems to be pedunculated, and if you do an imaging, you find that the anterior commissure is free, the cartilage is free, you would be able to take that out with a laser. The one on the left is more vicious. It's supraglottic, it's subglottic, like Professor Paredi said, it is going through all the levels. That might be a true T4. It might be invading the cartilage. That might require a proper imaging to understand the anterior spread. That, in my opinion, would be more difficult to tackle than the one on the right.
So I'm just telling you, Prathamesh, that you've done all that imaging and all the workup, and it is feasible to do transoral resection. Would that be your preference, or would you send him to Sharmila for radiation?
So in my opinion, if I'm able to get that out clearly, I would do surgery.
Voice.
The voice, in both, the one on the right, the voice will still might be better because it might be pedunculated more on the right side. And the anterior commissure would be very sparingly involved. The one on the left side will have a very poor voice quality, certainly.
And Sharmila, how confident are your fields to deal with anterior commissure?
Easy to treat.
Easy. At one time it was a big concern. Before the IMRT days, it was a big concern. Now it is not. Anil wants to say something.
No, I just wanted to say that I knew that point would come. In the old days, what Sharmila says is true, not anymore. But I wanted to ask Prathamesh, he was so confident, if you can take it out, I'll do it with laser. 56-year-old professional singer, member of parliament. I'm not going to just charge in and do it. So I need the age, I need the profession. It's just not because I can take it out, I'm going to take it out easy.
So in Delhi, we might have that problem, but
In
in Bombay,
Delhi? Why in Delhi? He might. I thought we are in HNCI and you're the director. They've flown into HNCI for the Pandit in conservative surgery and they know Professor Paretti is here. Why Delhi?
because they would have seen you.
I think the
Jokes
concern
apart,
there.
I think you need to answer that question.
Voice quality today is important for most professionals, most working people. Voice quality is very important. They don't want a voice like mine.
So but we need to look at the data. And as Dr. De Cruz said, we need data for this. The anterior commissure lesion fails both in radiation and in laser surgery. Both. So we need to look at the outcomes with the oncologic outcomes first. So if I'm able to get the complete clearance, the oncologic outcomes in this patient will be far superior to that with radiation. Two, in case of a failure with radiation, I will end up with a bigger surgery than with a transoral laser recurrence.
So my question is that we get out this anterior commissure lesion, but then the follow-up has to be done with check endoscopies. And if you find granulations, you're going to take back this patient to the OR and take the biopsies. So would that be then cost effective as against giving radiotherapy? Anterior commissure lesions, they recommend that the follow-up endoscopies have to be at least 6 weeks to 3 months. And if we keep on finding granulations not healing, if that's something is differential for malignancy potential, we would again take back this patient to the OR and get the biopsies. So the economic burden on the patient also adds on.
Most of the times, that granulation, the clinician will be able to recognize that this is a granuloma and they don't need to be taken to the theater. You wait, a lot of this granuloma will resolve. Once in a while, you may have to take him again and just pluck that thing out. But most of the times, you can recognize clinically that this is a healing granuloma. In a lot of the laser called mid-cord also, when you do a chordectomy, they very often come up with a granuloma. Just reassure them, over a period of time the granuloma resolves. Once in a while you have to take him and pluck that thing.
So, but don't you think it's an important point to tell him it's obviously a problem with him that he's getting granulation again and again? How you prevent granulation, low wattage setting, an aqueous spot, remove all the char, all those techniques at laser will decrease your granulation. I think that's very, very important. You get one of the Korean lasers and you do this, you will get granulation again and again. I'm not speaking for any particular company, but you need fine lasers for glottic work.
So the house is divided on anterior commissure. So here I think that Dr. Paretti will want to do transoral laser resection.
Yes.
So glottosupraglottic. Cords are moving very well. So, Prathamesh.
So this is again a lesion which is going in supraglottis. So it is going along the ventricle. So you would need proper imaging in this patient to understand what is the lateral extent. And then a proper evaluation under microscope to understand what is the lateral extent and whether you are going to get that clearance. Voice is a concern because once you go lateral to the false chord, the ventricle, and go into the true chord, your voice is going to be, will suffer. So a discussion has to happen with the patient as far as the resection is concerned. Though you can see around, you might get a good exposure, you need to have a discussion for voice in this patient.
But most of us have changed over to radiation or chemo-rad for these kinds of cases.
So chemo-rad in this patient?
Yes, Anil.
After the entire workup only, you can decide whether this patient needs chemo-rad or we can get away with only radiotherapy, or you guys can do surgery.
So, but why would you consider chemo-rad? Both the cord and the arytenoid are mobile?
Because she put a needle into the node and it came positive. She said after full workup.
But
not just
there's
this
a node?
lesion. No, I'm just saying this is supraglottis. You have to look at the nodes. Half the patient in the RTOG trial were these patients who had a node positive and went on to the RTOG trial. I have a question.
And they did well. And they did well. No?
Yeah. So over 80% of preserving of the larynx totally.
In 3 years.
I wanted to ask you, Prathamesh, Alok, Dr. Paretti, we read about cartilage erosion. Maybe Asif can jump in here as well. How important? Cricoid's not an issue because if cricoid cartilage gets eroded, you see it, it's subglottic, and then the patient probably goes for surgery. Thyroid cartilage overestimation, underestimation, all that. How important is arytenoid cartilage? There is literature that if you have, and you showed very elegantly the posterior compartment going out, but I was like looking for a line on how you assess arytenoid cartilage. And there is data that says that if the arytenoid cartilage is eroded, outcomes are poorer. So does that drive into your working algorithm on how you choose your patients?
Poorer with chemo-rad or?
Anything, so we'll just get comments and then maybe we can develop the discussion. To me, that's fine-tuning laryngeal as well.
JP has a comment to make. Yes, JP.
So we did a large series, and where the arytenoid was involved or cricoarytenoid joint was involved, the outcome for conservative CTRT were poor. Local failures were high. And the same I expect for the surgical colleague.
So
they aspirate more.
So total laryngectomy.
If the arytenoid is infiltrated, probably you have a fixation of the arytenoid. So this is a contraindication for laser. No way. If you have a sclerosis of the arytenoid, but the arytenoid is still mobile, you have a judge with the CT scan or MRI. But the problem here, you can come to the initial imaging. Go back.
Movie logo.
In the beginning. Okay. So, just to show you the vascularity. You see the dark spot even with the white line. If you decide for TLM, the problem in this case is to have a free margin posteriorly. So if you make a normal intubation, it's difficult to control the posterior margin. So in this case, I start with the normal intubation. At the end, I put a small catheter just to make a wider resection in the medial surface of the arytenoid, just to have a free margin. But I completely agree that if you have erosion fixation, no way. I go for clear release.
No, the point was, Dr. Paretti, if your arytenoid is sclerosed, would you resect it in your surgical plan? Would you go with? Yeah, if the arytenoid is sclerosed. The point was, if the arytenoid is involved.
The anterior part just to have a good margin.
So you'll do a vocal process resection.
Yeah, even a little more than a vocal. The vocal process I always remove, also in type 2.
Okay.
Because I want to be sure that the posterior margin is free. If there is a sclerosis or the tumor like this, I remove also the anterior part of the arytenoid. I spare the body of the arytenoid.
Okay.
but I remove just to dissect all the paraglottic space, but with a mobile arytenoid.
And then would you get a comment of that arytenoid, whether it's involved? Because the concern is on imaging, we are seeing a sclerosis.
Sclerosis sometimes is due to the inflammation, not the infiltration of the arytenoid.
I think even imaging always sometimes overestimates the arytenoid involvement.
Yeah, overestimated.
Yes, and moreover sclerosis can be due to inflammation.
So we work on that. So we try to work on that to understand the sclerosis versus the involvement with the radiomic features. And it was consistent that if there is a high entropy, it was almost involvement, and our local failure were very high.
Just with the sclerosis. For me, it's more important to see the thyroarytenoid space and not just the arytenoid. Yes.
Yes. So
this is the problem. Because if you have a wider space compared to the contralateral, is made.
Yeah.
Exactly.
So that was another point what we saw in our prospective radiological features as well as radiomic features for the CT-RT, and that was consistent. And unfortunately, that is still, we tried to insist that it should be put in the TNM when it was changing, but unfortunately, it didn't got changed. But hopefully, it will change in future.
I missed a part of the discussion, but I heard about sclerosis. There are 4 or 5 points you look in an imaging. There's sclerosis, there's lysis, there's erosion, there's exolaryngeal spread, and there's bowing of the cartilage if you have thyroid cartilage. Sclerosis is the least sensitive in my understanding because cartilage is ossify. So you can never make a judgment on sclerosis. You could be wrong. You look at erosion and lysis. So don't base decisions on sclerosis in my understanding of literature. Then you may supplement with an MR, look at gadolinium, they are T1, T2 weighted. There are different signs that you look, but sclerosis, JP, is not the best to make a decision.
I understand, but it was whitening and all those features were there.
Yes, Asif.
What I learned today is next time before giving sclerosis, I'll also be wanting to know how are the chords. That's my take home from here. So probably we'll make those phonation studies in those cases and try to understand it more, besides the widened gap and extra and the dynamic scan. So that's what I probably would take home as a radiological point for me, not just the sclerosis. And the thyroid cartilage, being so bizarre in the sense we would not be able to just guide you in 100% terms on CT that it is really involved because of the ossification. And ossified areas can get invaded and the cartilaginous part can remain intact. That's been shown quite often in the literature.
Moreover, it's very useful for you to see the endoscopy before make a report, because if you have a fixed arytenoid, is another scenario. If you have mobile arytenoid with the sclerosis, probably is due to simple contact or inflammation. If you have a fixed arytenoid, different diseases. So it's more important to evaluate the paraglottic space and the thyroarytenoid space than the only arytenoid.
So this is another T2 lesion where the cord mobility is impaired. And I know that Alok would like to do a vertical partial laryngectomy on him, or a supracricoid. Isn't that what you were trying to say?
Not a supracricoid on first evaluation, but certainly depending on how the scan goes, if the posterior paraglottic space is free, then certainly vertical hemilaryngectomy is very much on the horizon. If the paraglottic space per se is also free, then even a laser is possibly still in contention. though it seems a little bit too bulky for the laser. But nowadays, a type 4 laser correctomy is something we tend to do very little of because the voice results have been rather disappointing. Previously, maybe 10 years ago, we would have done a type 4 on this. But today, if a scan shows minimal lateral extension, maybe a type 3 correctomy, otherwise possibly a partial. And a vertical frontolateral also seems very much in the loop in this situation.
What about radiation? Would you add chemo to that?
No, sir.
No?
We need to actually do a proper workup, but I don't think so for this case we'll have chemotherapy.
So all the workups showed that this is a T2B lesion. But I generally tend to tell them to add chemo. I'm just telling you. Because I know that if radiotherapy fails, then it fails very often. I think in 35% cases it will fail. But with the addition of chemo, I think it will go up to 75-80%.
Sir, if you add chemo, the OS is only 4% benefit.
The larynx preservation.
No, no.
Larynx
See, overall,
preservation.
what I'm saying, and majority were there of a larynx and an oropharynx patient. And many were there possibly P16 positive patient. So the amount of toxicity it will happen, if we are certain there is no nodes, I don't see that reason to add chemo. Maybe hypofractionated or acceleration fracted will work similarly in larynx, and it is done across the Europe. It is not done in across the Atlantic.
No, like
and the reasons are very fair on that.
Anil mentioned that majority of the RTOG patients were like this.
Yeah, that's what I'm saying, sir. They were with a node positive. So what I'm trying to say, across the Atlantic, most of the people will go for chemoradiation. In Europe, they will go for either hypofractionation or accelerated fractionation in the T2B larynx. I don't know what Dr. Sekia wants to say on that.
Yeah, I think
you people are saying it is a nasty disease in a nice person. Sarmila also says the nice person with a nasty disease and comes to a nice person. So I know it by the time you already know the prognosis is not very good. And as JP says, actually 2021 data of MAC ancients is 3.1%. And they said after that we are not going to do any further meta-analysis. So 10 years down the line, MAC ANC will be forgotten. Nobody will talk about it. So in other words, I would give chemotherapy because that's the way you practice it. But I would probably like what Europeans are doing. I'm a more believer in radiation therapy or surgery in head and neck cancer, not really chemotherapy.
No, but the MAC NC you should not look at.
Of course not. 65 to 2011.
No. In larynx, my vote is with Dr. Pradhan. You look at LPR and laryngectomy-free survival. That's the end point, and that's what we are told today. In all larynx trials, these should be the end point. And if you look at the RTOG 3-arm study, there is a differential of more than 12 points between RT alone and CTRT. It springs to 80%. He told you the figures, and that's randomized evidence. Not what... No, that is okay. I mean, I know people give hypofractionated. I'm telling you randomized evidence. You give me a randomized. Europe might do anything. That's fine. I know that Europeans treat differently. I'm aware. They give low dose, 40 milligrams. After they give neoadjuvant chemotherapy, they never give CTRT. That's European way of practicing. That's okay. I'm telling you randomized. So what Dr. Pradhan is saying is absolutely correct.
It's very late. Half the crowd has gone for on karo. So I just want to show to people what we mean by a transglottic cancer where the cord is fixed and the arytenoid is mobile, as against the next one, because we'll run out of time, so we won't go into discussion. As against that, a fixed hemilarynx that Professor Paretti was trying to show, where both the cord and the arytenoid are fixed. I think there's not too much time left for us to discuss. These are all cases for chemoradiation. The first one is also for supracricoid, which we don't do very often. But I think it's too late, so we'll just skip all this. Everybody's tired. And thank you.
As we come to an end of this momentous occasion, I take this opportunity to extend our heartfelt thanks to all our distinguished guests for gracing us with their presence and sharing their invaluable insights. A special thanks to Dr. Sultan Pradhan for his visionary leadership and relentless efforts towards making Agency II a beacon of hope in the fight against cancer. To our dedicated staff and volunteers, your hard work and commitment are the pillars of our success. Lastly, to all our attendees, thank you for being here and supporting our cause. Your presence today inspires us to continue our mission with renewed vigor. Let's close the ceremony with a round of applause for everyone who made this day possible. Thank you and have a wonderful evening. Kindly proceed for dinner. Bon appetit.